now exclusively come from the protein diet, and the purine is again a direct source of uric acid, which is metabolized. And this uric acid can directly precipitate, give rise to uric acid stone, or interestingly, you can see that the nidus of most of the calcium oxalate stone, which is to the tune of 96 to 97% out of all calcium stones, this is formed by, you can see this white is uric acid. And over this crystallization, then and the the nidus formation, then crystallization, and all around it, there is a peripheral zone of calcium oxalate, monohydrate or dihydrate. So this is how. So it is also seen a diet eliminating animal protein had less than half the calcium loss that they had on their balanced diet. And further, in the Harvard study also, it was found that even in the modest increase in animal protein from 50 gram to 77 gram, there is a rise of stone formation to the tune of 33%. So animal protein is so relevant in cases of urolithiasis. So you know all better than me. We know that 40 to 50 this gram of protein which is needed usually, and this is an average study which usually comes from meat sources or the dairy products, but plant sources are usually preferred, which may come from the soya and other similar products like soya, and this should be a balanced source of protein as to avoid this source of minimize the load of purine in the body. Salt, again, this is the another effect of this globalization. Most of the products which are readily available or the non-vegetarian products, they are very high in the salt. How does the salt play role in the stone formation? This leads to hypercalciuria, increase in urinary pH, and decrease the citrate. Citrate itself, we will coming in the subsequent slides, plays a very important positive effect on the stone of calcium oxalate. And the sodium and the calcium share the same transport in the kidney, and this is how the sodium basically interfere with the reabsorption of the calcium. We all know that whatever the calcium we consume from the absorption after a small bowel, that goes to the kidney, whatever is filtered from glomeruli, more than 98% is reabsorbed. If the sodium is competing with that, that will not be absorbed. Simple explanation, that will come in the urine, oxalate is available, this will all form a complex for formation of the stone. And when it is seen then in various epidemiological study, when people cut their salt, sodium intake in the half, they reduce their need for calcium. And calciuria also increases nearly 40 milligram for every 100 milliculent of supplementation of salt in normal adult. That is why 100 milliculent, I think I could see is aroundly 23 milligram of the table salt in normal adults, while the same in patients those who are having hypercalciuria, this goes to the tune of 80 milligram. So how significant it is. And the dietary advice which you can give is that it is readily available in grains, vegetable, legumes, and the fruits, and have no sodium. That is one good thing you can prescribe. And the dairy products and the meats which contain more salt than plants. And frozen meals can, the steak foods, they have the highest amount the this sodium chloride. Sugar also. So those who have been taken sugar also has an adverse effect. And this is a recent study from National Health and Nutrition Examination Survey, a study of under 18 over 18 years, nearly 28,000 of the patients included in this. And they concluded that compared with less than 5% calories from added sugar population, the more than or equal to 25% from the added sugar had a higher kidney stone prevalence. So we usually do not mind. As a physicians or surgeons, we may avoid taking sugars, but a common man usually add lot of sugar to tea and other these edibles. Similarly, in the nurses study also, who consumed an average of 60 gram or more than more sugars per day, had a 50% higher risk of a stone than those who consumed only about 20 gram of sugar. And we all know that right from the bad tea to cola, from cola to the bedtime milk. Every drink has some amount of sugar. So that leads to hypercalciuria, and that promote basically calcium oxalate, this conglomeration and agglomeration. So this Raman spectroscopy study which is shown that even the sugar could be demonstrated in the calcium oxalate and the uric acid crystal. So how relevant it is? Citrate is another component which is quite important in prevention of the stone disease, and the citrate reduces the urinary supersaturation of the calcium salt by forming soluble complexes with calcium ion, and it inhibits the crystal growth and aggregation, especially for calcium stone, that is calcium oxalate and calcium phosphate. And the basic target is to maintain usually the deficiency is less than 320 milligram per day, and normally it should be more than 2 milligram per kg in 24 hours. And this prevalence of hypocytruria is to the tune of 8 to 60%. This is a clear geographical effect. Different races have different this yeah, prevalence, and the sources are Krebs cycle in the food and can become come in. And these are the various sources which can be taken down from various websites on the textbooks also. And coming to B6 also, and basically the role of B6 is to metabolize glyoxylate, which comes from the Krebs cycles. And if this vitamin is deficient, uh, there will be higher amount of oxalate, and oxalate I have already explained in terms of the calcium oxalate. Just few seconds, I am just finishing it. And the vegetables are not the good source for this, and the usual dose in the stone formation has been 20 to 50 milligram, 500 milligram, those patients who had stone frames. This is another important question. Just few seconds, and like, can I take meat? This is a common question. Can I take non-vegetarian item? General perception is that the vegetarian diets are better. But we know that it is because the high organic iron content, higher citrate, potassium, and the malic acid, which provides acid, this slightly alkaline pH. But we should warn patients, all these vegetables which are taken in India have a high oxalate content. And but the prescription should be avoid abundance and monotony. Similarly, for the non-vegetarian items, they are rich in purines as well as salt in content. But what you can advise is that you can take non-vegetarian even if you are having a stone with wide intervals, avoid solid organ and red meat. So this is the last slide. Avoid generalization, individualize the approach depending upon the abnormality. If you do not find any abnormality, do not lose heart. Encourage plant foods, fresh fruits and vegetables with low oxalate. Make a chart and list and give it to the patient. Reduce ingestion, but do not stop animal press. Never say that this avoid meat. Animal protein salt should be taken as to give a balanced diet. Maintain an intake of calcium 1 gram per day. Increase foods which are having citrate and potassium. Fluid intake very important because of time restrictions. We avoided 3-4 slides on the water. Ensure more than 50 ml per kg per day is for stone formation. Thank you very much. I never thought that I will get the question. Oh,
Yeah, excellent presentation. I have few comments. Anytime we said that our stones are calcium oxalate, there is a tendency for unrestricted use of vitamin D in our population by the physicians without looking at the serum calcium. Normally, 15% of the calcium we ingest is absorbed from the small intestine. When we add vitamin D to that, another 8% is absorbed. Recently, I show two patients seeing every day. They take vitamin D unrestricted. They form recurrent stones. Their calcium is never checked. And this is one of the concerns I have. And for the ladies who are sitting here, there is a publication in American Journal of Kidney Disease recently. They found many youngsters having acute kidney injury in Israel. When they looked at that, the biopsy showed calcium oxalate stone formation. And what was it? They were using keratin. Keratin contains glycolic acid for straightening their hair. And glycolic acid is converted to oxalate, and they form stones there. So please be aware that anybody who is using keratin please be aware that they should check their creatinine and find out that whether they have renal failure or not. So I would tend to agree with you, but the calcium intake, we have to restrict our calcium intake because with vitamin D, it gets absorbed and a lot of people develop. Yeah, I am also one of the stone formers, among the 15% you said that. So once I started restricting my calcium intake, I have no stones. Now I do a ultrasound every 6 months to look at my kidneys. So we cannot give, you already said that 1,000 milligram is the ultimate calcium. In pregnancy may go up to 1,200 milligram. Always remember that calcium is also a poison. When it is combined with vitamin D in patients who are predisposed to form stones, they will form stones. Thank you.
The very good point. This vitamin D is very commonly ignored. Lot of sachet patient is prescribed, and I have seen not only the stone but also with the acute kidney injury, also secondary to vitamin D. Thank you.
Sir, I also have a
Yes.
question. That what is the correlation or association of so-called high salt content of water with the risk for renal stone? If I am asking a silly question, please
No,
forgive
no,
me,
it is a very
because
relevant
many
question.
this salt content of water varies widely across the country. That's why I'm asking this
Yes,
question.
yes, sir. Because it is seen this the water has been extensively studied, salt water and hard water. But basically, the water quality of the water, as such, in terms of softness and hardness, has not left any impact on long-term studies. The only thing which has affected the fluorine content in the water, which basically increases the hypercalciuria and acidic load on the kidneys. Then it becomes a source of the calcium oxalate. But the hardness and the softness has no effect.
So basically, the fluorine content will increase the
Basically,
risk for stone, but
forest.
not the hardness of the water.
Yes, not
Right.
the yes.
So basically, boiling of water will not give additional benefit
And
because that
yes,
takes out the hardness of the water.
yes, you have to treat, yes, to reduce the fluorine content. Yes.
Thank you, sir. So next up we have on.
I request the speaker, sir, to please proceed for the felicitation. Thank you. No, no, sir, that is right to the stage. Thank you. It's a announcement to everyone that please adhere to the time because we have many sessions lined up. We have to restrict ourselves to our time because we need discussion. So it's a request. Thank you. Over to the chairpersons.
So next session is on interaction of basically liver and kidney. Liver disease patients are prone to develop kidney disease in form of hepatorenal syndrome, and the dietary requirement of liver disease patient are likely to be contradicting with the kidney disease patient. So we need more insight and nitty-gritty about the dietary prescription of a cirrhosis patient with hepatorenal syndrome, and we have very good dietitian from our center, Archana ji, and she will talk about it.
Thank you. Good morning to everyone. And I'm grateful to the scientific committee for giving me opportunity to speak on the topic nutritional challenges in cirrhosis patient with renal failure. We all know that here the two complicated diseases, the liver and the kidney, they coexist. So this is really a difficult situation, especially for we the dietitians, because there is no specific guidelines to deal with this complicated situation. So we have to be very careful regarding
we use the low sodium salts very aggressively. The only place. So there is simple. This
Yes.
SRNS, I think, is where
That's the
challenge.
first slide I said that if you have repeated relapses or resistant
Yeah.
disease, that's the only
Yeah.
place where it usually be.
Repeated relapses is not much a problem. It's the resistant disease.
Yeah.
Thank you so much. Thank you, Speaker Madam, and please let us felicitate you. Over to the chair for the next speaker.
So for the next talk, may I have the privilege to invite Dr. George Ibrahim from Chennai for delivering his talk. The topic would be evidence-based approach to prevent malnutrition in CKD patients.
Can you just tell me how to use this pointer? Somebody help me. At the outset, good morning, respected chair, and it's indeed a great pleasure to be here. I dedicate this talk to my dearest and respected friend, Dr. Anita Saxena, whom we lost last year, and she has been a powerful role model for nutrition, not only in India, but also in South Asian countries. Anita, this talk is for you. First, I will dwell upon the Indian data which we have. I will be turning because they don't have a mouse here. Let me see whether this mouse will. Sorry. Yeah, this shows the multi-center study of malnutrition prevalence in Chennai. You have the different colored bar graphs there, which are showing the. Let's see. Okay, different colored bar graphs which are shown, which shows the middle income group, the low income group, the CKD stage 5D, CKD other stages. So you can see that in the low income group, who are the people in the government hospital, the malnutrition rate is 93%, the prevalence. Whereas in the middle income group, who are on dialysis, it is about 68%. So as the severity of CKD decreases, you can see that the malnutrition is much less. So when we looked at the high biological value protein, if you take 1 gram of protein, half gram should be of high biological value. High biological value implies that it is essential amino acids are there. So when you look at the non-dialysis and dialysis, and you can see that the percentage who were taking high biological value varies between 16% to 21 to 22, depending upon what background they come from. So it's a very important message that lot of our people are not taking high biological value protein, which is essential to prevent malnutrition. This is another study we did, effect of high protein nutrition supplements on subjective global assessment of nutrition status of patients on end-stage kidney disease on dialysis. There were 2 cohorts. It was published in Hemodialysis International, and you can see that you have the gender, the various diabetes, hypertension, and frequency of non-vegetarian diet. And as per the conclusion, according to the MIS, improvement was observed in malnutrition status from 3 to 6 months. It was a longitudinal study in 38.1% of the patients in high protein commercial supplement group, whereas only in 8.7% in high kitchen group. So this is something which we have to do. We have to use commercial preparations to support the nutrition of our patients. We have so many hundreds of commercial nutritional preparations available in this country. Should we do that or shouldn't we do that? This is a question. So when you look at the kidney on the left-hand side, as the kidney functions deteriorate, you can see that there is progressive increase in the malnutrition, which I'll show you later. Normally about 50 to 70 gram of amino acid filtered are filtered and about 98% is reabsorbed. This cartoon shows a wasted patient whom we see once in a while, a normal individual and an overweight individual. Essential nutrients are carbohydrates, proteins, fats and vitamins, minerals and water, macronutrients and the micronutrients are there. And thus higher weight means high fat or higher muscle. So this is something we look at that. I have seen in some of my peritoneal dialysis patients, they put on weight because they use hypertonic fluid, and this may not be just muscle, this will be fat. So when you look at malnutrition, chronic kidney disease, you move from the left to the right, stages, stage 1, stage 2, stage 3, stage 4, and stage 5. Either they are on dialysis or not on dialysis. I am showing the US prevalence. I am sure that we will have some data on our own prevalence. So protein energy malnutrition is seen in 28 to 48% of patients in up to stage 4 and up to 75% of patients in stage 5. So malnutrition is the result of an imbalance between nutritional intake and nutrition requirement. There should be supply and there is demand, and intake forms the body stores, and the losses will give rise to malnutrition if the losses are in excess of intake. So nutrition therapy strategies begin with screening and assessment. It includes nutrition screening and assessment on the left-hand side, the diagnosis of malnutrition, individual plan to treat the nutrition problems, management, monitoring, and evaluation. Nutrition therapy refers to the nutrition treatment and management of a patient. This is how the major metabolic steps in nutritional deficiency. You have a well-nourished patient and who goes into inadequate intake, impaired absorption, increased nutrient loss from body, leading to dietary survey nutritional intake, which the dietitians do. This leads to depletion of tissue levels of body stores, which lead to again altered biological and physiological function. The individual is at risk and will have biochemical and physiological studies are necessary to highlight that. Deterioration in capacity to function normally leads to clinical symptoms, morbidity, and mortality. These are the vital statistics you look at. So the energy expenditure is shown in the bar graph there, and you have physical activity is 15 to 30%, and diet induced is about 7 to 13%. So depending upon the physical activity, that is the red part of the bar, decides how much energy you require. And we need to modify that or alter it with the help of a nutritionist on renal therapy. So factors influencing nutrition status are depression, altered taste sensation, increased catabolism, decreased anabolism, amino acid abnormalities, metabolic acidosis. I feel still are we only sodium potassium nephrologists in the country? Don't we have to check the bicarbonate level? Many a times I see that it is not being checked because metabolic acidosis leads to muscle wasting through many pathways, including the proteasome pathway. So hormonal derangements, insulin resistance, and PTH resistance. So deprived with CKD non-dialysis patients seen, and you can see that the muscle man standing there because a lot of our CKD dialysis and non-dialysis patients do exercise, including weightlifting. The nutritional assessment is essential for early intervention, significant impact on patient care. No single marker, but multiple parameters are necessary at the initiation and at follow-up. Medical history is very important. Yesterday, I was reading the newspaper in Kerala. Every government doctor gets only 2 minutes to see a patient. So they have such a busy OP. How will you do all these things? So the role of nutrition is important and a paramount duty for the nutritionist to look at that. So medical history should be included in any nutrition assessment. As I said, comorbidities, medications, functional limitations, residual renal function, renal replacement therapy characteristics, and socioeconomic and cultural factors. Because one of the Orissa nephrologist told me we were talking all these high-grade things. He said, our patients can only afford a morsel of rice and rasam. So what can we do with all these patients? So let me move on. And so physical exam is equally important. We all do physical examination, but in 2 minutes, how can you do a physical examination in a patient? So the screening tools collect weight loss and appetite information. Principal screening tool questions are involuntary decrease in weight, that is over 5% of usual weight over 1 month or over 10% of usual weight over 6 months, which suggests inadequate oral intake. It could also be due to lack of appetite, and the dietary intake should be done through food records, 24-hour recall, and food frequency. So nutrition screening should be routine nutrition screen. It should include a malnutrition screening such as MST. Unintentional weight loss should be looked at. Poor appetite, downward trend in serum albumin or BMI. Result is at risk, not at risk. If they are at risk, schedule nutrition assessment and schedule next routine screen. I won't go into detail. The malnutrition screening tool is very important. So nutrition assessment, widely used assessment tools are subjective global assessment described by Detsky in Toronto for assessing surgical malnourished patients, then malnutrition inflammation score. So special consideration for nutrition assessment in CKD patient includes fluid status, inflammatory status, looking at the CRP, proteinuria, residual renal function, method of renal replacement therapy. Nutrition assessment must take into account the unique influence of CKD, whether they are vegetarians or non-vegetarians, or do they have any other comorbidities. So subjective global assessment is widely used in CKD, and I am not going into details. The advantages are robust, widely used, quick to administer. Limitations are requires training and based on clinical judgment. So malnutrition inflammation score can help diagnose protein energy wasting. SGA with scoring, it includes BMI, albumin transferrin. The scoring is each MIS component has 4 levels of severity. Final score ranges from 0 to 30. An MIS of over 5 is considered malnourished. Advantages are can help identify presence of PW. Limitations are requires training like SGA, need lab values as well, albumin and transferrin. MIS may be used without transferrin also. So anthropometric measures are, you have the BCM on the left-hand side. Now you have a wearable BCM by InBios from Bangalore, and it's very easy. You can tie on your hand with an electrode, and the results will come in 60 seconds. And you have the mid-arm muscle circumference, skin fold thickness. DEXA, as the previous speaker has already alluded to, it has got its own limitations, and grip strength in the non-fistula arm. So serum albumin is widely used as a nutrition marker in CKD. So nutrition recommendation CKD include pre-dialysis patient, hemodialysis patients, and PD patient. And the calories should be about 35 or 30 in those who are above the age of 60. And protein intake is shown here, 0.6 to 0.8 kilogram per body weight. I am not sure how many of our patients in the pre-dialysis would take that much protein. Then in patients on hemodialysis, 1.2 to 1.4 kilogram. PD patients, 1.3 to 1.5 kilogram gram per kilogram. Sodium intake should be limited. Potassium less than 1 millimole per kilogram per day if elevated. Less than 1 millimole per kilogram. Not usually an issue in PD patients unless they eat tremendous amount of fruits, which are citrus fruits, which are high in potassium. Phosphorus 800 to 1000 milligram in all way through. And in hemodialysis patient, the fluid intake is individualized. I do the BCM to look at the fluid therapy. It is very difficult to say that you take only 500 cc or whatever it is. So it is an individualized therapy regarding fluid intake. Sorry. So use of intradialytic parenteral nutrition in patients undergoing hemodialysis. We usually do it in private corporate hospitals. This is not affordable for the patients who belong to the lower socioeconomic status. So it has got its own advantages and limitations. So exercise, intradialytic exercise program, which we were doing at the Madras Medical Mission Hospital during dialysis in patients who has no reduced ejection fraction. If somebody has got an ejection fraction which is less than 40, we don't encourage them to do this. Next is appetite stimulants. Appetite stimulants such as megestrol acetate, cannabinoids, and anabolic steroids such as oxandrolone have been used anecdotally to increase protein intake in severely malnourished patients. So, in summary, we have the intake, we do have the anthropometry, serum albumin, and DEXA or BAA look at the stores, and the losses are measured by normalized protein accumulation of nitrogen, and the functional status is looked at by hand grip strength, and the diet recall by the trained dietitian, which we have only few in the country, are a real value to our program, and look at the SGA. Last few slides. So monitoring nutritional intake, urinary, the equations are there for the NPNA. So, and key points are nutrition screening and assessment are necessary before recommending nutrition therapy. Screen using rapid and readily available methods for identifying patients at risk for protein allergy wasting. Nutrition assessment will help to determine a diagnosis which will be the basis for nutrition therapy. In order to achieve best clinical outcomes, one should use complementary assessment tools, follow trends over time, and consider the entire clinical content. And I thank my colleagues who helped me in making this book possible. I'm sure that many of you are there. This picture was taken many years ago, and we have all aged over a period of time, but we are not malnourished. And you can see that, Dr. Balla has receded his hair more in the forehead. And as I conclude, it's a close interaction between nephrologists, intensivists, nutritionists holding hands together to save our humanity from malnutrition. Thank you.
Thank you, Dr. Jarji, for giving excellent talk. Now the session is open for any question, one or two question only.
Excellent talk, sir. Not a question, rather a comment for the dietitians that though we divide India in non-vegetarian and vegetarian, the low socioeconomic group population we were referring to, we must want to know what is the frequency of non-vegetarian diet they have. Many poor people, they can't afford more than two or one non-veg meal in 15 days. But when we will take history, they will represent them as non-vegetarian. That has been revealed during the ICKD cohort exploration that had gone with Professor Jha. So that is the important point that I want to make for our junior dietitians.
Thank you. It's a very valid comment. And I think that how do we address this? This is a big problem, because we have different states, different dietitians, different nephrologists, but do we have enough trained nutritionists to address these challenges? Shruti?
Sir, I think that is why a nutritional assessment or a urine protein nitrogen appearance done before we give a diet is extremely important. So, in our program, we do a 24-hour urea, creatinine, protein, sodium, and then only send to the dietitian so that she knows to calculate how much protein the patient is having even before any intervention has been done. And 95% of the times they fall into the zero point 0.4 to 0.6 category any which way, so you do not need any restriction. So when the patients say ki we have a kidney disease and we have been told not to eat proteins, that is not true because they are already on a low protein diet. We actually should not make a lot of changes and make them malnourished. So for the nutritionists, make it a point that you need the 24-hour assessment, otherwise we go wrong.
Thank you.
Excuse me, sir. So, how frequent the reassessment should be done in malnourished patients?
How
Frequent the reassessment should be done in
Well,
malnourished
I would
patients.
say that if it is a malnourished patient whom we are looking at, it should be done every 2 months. And if it's a well-nourished patient, maybe Samrat can answer that. And I would request your help. Please make your comments. Samrat.
Good morning, sir. For a malnourished patient, normally a 4 week assessment is something that we look at. And for a well nourished patient, obviously once in 3 months is something that we target.
Thank you so much, sir. And I request the speaker, sir, and the chairpersons to please allow us to felicitate you right side of the stage. Thank you so much. Thanks for your precious time, for all the energy, the positivity that you have given to the morning session. Thanks a lot. Now is the time to again invite eminent nephrologists from various parts of India. I invite Dr. Afzal Azim, Professor Critical Care Medicine, SGPGIMS Lucknow on stage. Please put your hands together to welcome sir. Dr. Priyank Yadav, Associate Professor, Urology, SGPGIMS Lucknow. Dr. Vishal Punia, Associate Professor, Pediatrics, King George's Medical University, Lucknow. And Dr. Smita Singh, Chief Nutritionist, Medland Hospital, Lucknow. As we are delayed by half an hour, I request speaker to please the time and let us restrict ourselves to limited questions. Thank you so much. Over to the chair for the intro.
Malnutrition is seen whether patient is on CAPD or hemodialysis. And roughly half of the patients on dialysis would be having mild to moderate malnutrition, and roughly 6 to 10% has severe malnutrition. And presence of malnutrition at the initiation of dialysis is with high risk of mortality and morbidity. All of us have seen in the other practice. Besides this, despite the high prevalence of malnutrition, but rarely it is listed cause of death, because majority would not die because of this. They would die because of other complications, cardiac deaths, or related to the infections. And this malnutrition would lead to the impaired immune functions. We will discuss what are the ways, and host resistance results into the more infections and poor wound healing. Besides, these infections are important cause of hospitalization in CKD patients. All of us are seeing this, and it has been found that As the stage advances, you have more of the infections, and these are resistant infections. It's a major cause of mortality, only exceeded by the cardiovascular mortality. Infections are a major cause of mortality. Besides this, patients with impaired renal function also has high risk of infection with the multi-drug resistant organisms. This is a chart which usually shows an interaction that how this chronic kidney disease has impact on the immunity. As you can see, that chronic kidney disease also has interaction with the gut, which is a source of microbiota. We'll be talking about that. So CKD, obviously, your kidneys are not working, kidneys disease, and because of this, actually, you know that हमारे यहाँ बोला गया ना संगति का असर पड़ता है. Similar way, kidney की संगति gut पर आ जाती है. So gut microbiota is also having dysbiosis. So gut microbiota is altered because of that. So these together are causing accumulation of the protein-bound uremic toxins. So mean to say there are a lot of them. Important one like glycyl sulfate and iodyl sulfate. It leads to the toxicity of endothelial cells as well as activation of the monocytes, which leads to the more atherosclerosis. Besides, this also has impact on the impaired antibacterial capacity. We have more bacterial infections. Besides this, has impact on the cellular immunity as well. T cytotoxicity, premature aging of the T cells, antigen production presentation is also impaired. Lot of methods are there, and there's more risk of malignancy, more viral infection as well. And besides this, you have poor response to the vaccination. This is why we are practicing actually hepatitis B vaccination, which is in higher dose, and you have more frequencies in the CKD patients. So with kidney function which is impaired, you have more comorbidities, you have a lot of medications, dietary habits like anorexia and low fiber and constipation, which leads to the reduced motility of the gut, reduced protein digestion, and reduced absorption because of edema, which leads to the increased proteolytic bacterium flora and more toxin generation, which will lead to the more mucosal injury, translocation of bacteria and toxins, ultimately leads to the more cytokines and uremic toxins, which again will cause progression of kidney disease. So this all is interconnected. You have more CKD, more toxins, again more cytokines, which cause more of CKD. So certain nutrients such as arginine and glutamine may enhance immune response. So usually they are deficient in the CKD. But CKD patients are usually susceptible to the zinc, vitamin B6, vitamin C, and folic acid, most of which will cause alteration in the host defense, such as diminished antibody response, polymononuclear leukocytes, and lymphocyte dysfunction. There was a study published in the Biomedicine, the CKD an underestimated risk factor for antimicrobial resistance in patients with urinary tract infection. So let's see the results quickly. They actually found that if you do univariate analysis, besides the other factors we usually expect, that is the age more than 65 years, obstructions, stones, immunosuppression, but CKD and hemodialysis itself were the important risk factors for the infections, those are with the antimicrobial resistance organism. Even if you do the multivariate analysis in this, still hemodialysis patients or CKD patients are the more prone for the infections with such organisms. Though we don't have great literature on this topic, but there is a small study which found that characterization of metalloid and antibiotic resistance in bacteria of human gut microbiota in CKD subjects. Small study, approximately 16 patients were there, though in different stages from 3, 4, 5. But the beauty was they also compared with the normal population. As you know that human gut microbiota is composed of more than 1,000 of the species, which is important role in health status of individual. And this biosis is augmented by CKD, and as CKD advances, there is more of the dysbiosis. Besides this, consumption of nephrotoxic heavy metals, which could be present actually in tap water, might increase the dysbiosis state. And they found that presence of cadmium A and arsenic C genetic markers of antibiotics and metalloid resistance were detected in samples from stage 3 CKD subjects. They also found that lower gene amplification in advanced stage of CKD was seen, possibly associated with the decrease in resident human gut microbiota. They found that actually once CKD advances, you have the normal gut microbiota, which is actually having dysbiosis, and you have quantitatively it is less also. So whether it makes it prone for the bacteria, those are actually not friendly to us. We have to see. This is the study actually which found that impact of childhood malnutrition and intestinal microbiota on multi-resistant infections. So majority of the global burden of such infections is in malnutrition, which is common in actually children in this Africa. So majority study has come from the Africa itself actually. These populations have high rates of malnutrition, making them more vulnerable to the infection and intestinal-derived pathogens. So malnourished children experience increased incidence of intestinal carriage and invasive infection with the intestinal-derived multiple drug-resistant organisms, including ESBL and carbamazepine-producing enterobacteria. It also impairs the intestinal barrier, adaptive immunity, and increases for infection with the intestinal-derived pathogens. And there's increasing appreciation for the role of intestinal microbiota in this process. And this high risk of infection actually in the malnutrition children, along with the other way also that malnutrition is there and you have more infection. And once infection has occurred, you have actually again more malnutrition. So it is bidirectional. So because of that, actually WHO recommended that we should give them the prophylactic antibiotics. Mostly, there were two randomized control trial. One was in the Malawi, other was in the Niger, again in the Africa, and they usually actually use amoxicillin. In first study, they found that it it improved nutrition if you give them amoxicillin short course. Besides this, mortality was also reduced with the help of this. Though other studies from the Niger did not was so encouraging, but still it showed that if you use amoxicillin, then there was reduced need of the hospitalization. So widespread administration of this actually made other challenges. Follow-up study has found that if you keep on giving these antibiotics, after a couple of years, they followed that they have more of resistant infection in their microbiota. Even to the extent that their household also had actually different kind of organisms which are actually resistant to the amoxicillin. So obviously, other studies also showed that once you use the antibiotics, you will have more of resistant infection. So this is what we should think that whether is it appropriate to use antibiotics or should we have some manipulation in the diet which can improve the macrobiota? Probably there will be less of the infection. So we just want to explore this. So there is evidence that malnourished children are at the increased risk of these MDRO infections, independent of initial antibiotic as well. Though we are talking antibiotics, but there is some data which shows that even when you don't use antibiotic, they're antibiotic naive patients, but still they have higher chances of the resistant organisms. So there was a study which was published in NEJM from the Niger again. They found that around 9.1% of children hospitalized for SAM had bloodstream infections, while majority, approximately 61%, were because of the resistant organisms. So these were patients antibiotic naive, no antibiotic were used. Similarly, another study also showed the same information. For that, we should have some idea about the composition and activity of microbiota during healthy and malnourished states. So all of us know that there is some microbiota in our gut, which is dominated by the several major phyla. We just keep it short that these are actually firmicutes and bacteroids, most apparently. Some proportion is actually actinobacteria and proteobacteria. Within these major group, actually, both these have important role for the nurturing intestinal epithelium for optimal digestion, absorption of dietary nutrients, as well as for the barrier integrity. Other important functions are also there, like micronutrients, vitamin B, vitamin K, folate, and they assist in the metabolism of amino acids also. Digestion of complex carbohydrates should be there, and they will produce short chain fatty acids. We'll be talking about that. These short chain fatty acids have been used in some clinical trials to manipulate the gut microbiota. So through regulation of nutrient absorption and metabolism, intestinal microbiota will influence the nutritional status. So whatever microbiota is there, it influences your nutritional status, and other way around also that composition of the microbiota itself is affected by your nutrition also. Whatever you take, it can alter your microbiota. Studies have found that long-term dietary habits have influence over gut microbiota. So there's some suggestion that if you use high fat, high protein diet, you have increased proportion of bacteroids species in comparison to the persons those have more carbohydrate rich diet, which are with the greater proportion of the prevotella species. So already we have been talking into in our mythology also that whatever we eat, like us become. So mean to there is also suggestion that if you eat the healthy diet, probably your gut microbiota has some change. There's some animal human studies which showed that dietary fiber from plant sources can promote growth of the myofibacterium and lactobacillus, which is capable of making short chain fatty acids, which promote healthy metabolism. While there was study on mice that if you give high fat diet, there's reduction of the short chain fatty acids, more inflammatory states, and more gram-negative bacterial sepsis. So in nutshell, all these demonstrate that in childhood malnutrition, there are changes in microbiota which may have critical implications for the clinical disease of the host. There was small study from the India which found that if you see these malnutrition child, they have more of Streptococcus genera proteobacteria with E. coli, Shigella, and Enterobacteria. All are enriched in the malnourished state. But in comparison, if children are well nourished, they have more of the firmicutes, which are actually beneficial for digestion and metabolism. So, you healthy child has better microbiota. So there's interaction between microbiota and intestinal pathogens. So just to make idea about that, that if your microbiota is healthy, it actually tries to suppress the resistant organisms. If you have healthy microbiota, so your this is called actually that you have colonial resistance. So you have better colonization resistance if you have better microbiota. And this is because of that actually. Once you use antibiotics, this is disturbed and you have more of the actually resistant organism. So some studies have been done. If you use short chain fatty acids, then it can mediate resistance to the multiple drug resistant enteropathogens, which is actually done by the butyrate production along with the cooperation of the lactobacillus, which was seen in the mice as well as patients of the acute leukemia. Other studies also have found that if you use this, then by means of intracellular acidification and neutralization, you do have this. Just a couple of slides. There's some dietary intervention has been done. People have done fecal microbial transplant, which is actually successful for only one group, that is the Clostridium infection. For other group, you don't have much data, that but maybe future we might be using this. It is interesting study in short that though in mice, multiple micronutrient deficiency in early life will cause multi-kingdom alteration in gut microbiome and intrinsic antibiotic resistance. Just to having idea about this study, actually they had a mouse model which was deficient in micronutrients, that is zinc, folate, iron, vitamin, and vitamin B12. And they found that if you use this, then because of deficiency of all this, gut microbiota was changed of the mice, and they had changed to the more pathogenic organisms, not bacteria only. You had more of bacteriophages and candida also. So fungal organism and viral organism also having pathogenicity if gut microbiota is changed. This is what the study has suggested. So to conclude that around 30 to 70% of CKD patients would have malnutrition. Infections are leading cause of the morbidity and mortality. Infection with antimicrobial resistant organisms is common in this population. And malnutrition is associated with the impaired immune function and host resistance. There is some data in children that nutrition can change microbiota. Some data that multiple nutritional deficiency can lead to change in gut microbiota and cause infection with antibiotic resistant organisms. And we have to wait actually that whether there is role of probiotics or short chain fatty acids or fecal microbiota transplantation so that this microbiota can be changed and we can have less of the infection. Thank you very much for your patient listening.
Thank you so much for such a nice deliberation and teaching us unthought topic even. Thank you so much.
Any questions from the house? So I would like to ask if the prebiotics have any role to play here?
Okay, what happened there, as we was looking for the data, you don't have any hardcore data. Do mean to say it isn't promoted that if you use prebiotics, there are some studies which have shown that even you can or change the progression of kidney disease also. As mean to say, we have seen some studies in children that if you use probiotics or shortened fatty acids, you have might have some changes, but still we need to wait probably for data. We don't have great data.
And what about the pre and probiotics in combination?
Okay, but this would mean to say that still we don't have great data to support this. There are some studies that mostly show some results are there, some studies show that there is no results. So both ways, neither disappointing nor very encouraging.
Sir, very excellent presentation. I have just comments. First thing that what you have rightly said, because certain fatty acids and butyrates, because we use basically complex carbohydrate or unripened like green banana in persistent diarrhea in children. So they goes to the undigested to the colon where it acts by bacteria and they are changed into certain fatty acids and to the butyrate. This butyrate is basically directly utilized as a energy source for the colonic cells. So that's why they change the gut microbiome. That is very, very important. And there are many, many studies that has been shown that in cases of like diabetes or chronic diseases, allergic diseases, there has been change in the microbiota with basically giving of the long-term probiotics. Is there? There is some studies is there like from the firmicutes to probiotics to the good or bad bacteria. So definitely they are underway and there is a lot of studies being across the world is going. Thank you.
Thank you very much.
And I think so. There's a very much importance of ratio of good and bad bacteria. If the good bacteria are there, then we can protect ourselves from the bad bacteria even.
That's true. That's true.
Thank you so much, sir. I request the organizers to please felicitate our speaker, sir, and request the chairpersons to introduce our next speaker and the topic. Thank you.
Thank you very much. The next topic is nutritional challenges in pediatric CKD, which will be presented by Dr. Sanjeev Gulati, who is Director Nephrology Service at Fortis Healthcare, Delhi. He is the President of Indian Society of Nephrology and has vast experience in pediatric kidney disease with over 200 publications. Thank you, sir.
Thank you and good morning, everyone. At the outset, I'd like to thank the organizing scientific committee for inviting me here and giving me an opportunity to share my thoughts on this very complex subject. I was reminded of this quote by Aristotle, the father of modern medicine. And it was he who said that let food be thy medicine and not medicine be thy food, highlighting the importance of nutrition in diseases. But as we stand today in 2023, I think it's the other way around. You know, when you see a prescription of our, especially for our kidney patients, it seems that we have just reversed the trend and their medicines have become their food. And I think if we pay proper attention to nutrition, we have a chance to reverse this. Start off with an index case, which actually I started following when I was in SGPGI. This is a 24-year-old male. He's a BTech. He's employed. He does cricket, cycling, and used to do an annual trek to Vaishno Devi. Why I'm telling you this story? He had chronic kidney disease at 2.5 years of age. But with proper management, we ensured that his hemoglobins were always good. Serum creatinine, he saw me a couple of years back, was 4.5, I think. EGFR of 18, stage 4 chronic kidney disease. So, if you pay proper attention to nutrition, optimize all the medical management, this is what chronic kidney disease children can do. The prevalence of chronic kidney disease is far less than the adult population. This is Dr. Srivastav's data from All India Institute of Medical Sciences. 0.8% of all hospital admissions in a pediatric unit. Our own data from SGPGI, 5.3% of all CKD patients. So you can imagine that 95% are adults, very small segment of children, which again is reflected worldwide. So there is lack of data, lack of studies. What we also found was that the mean duration of symptoms prior to diagnosis, now this is symptoms, the disease would have been onset much earlier, was nearly 3.5 years. So there's a lot of time for malnutrition to set in, for the disease to progress, a long story of lost opportunity. So these are the stages of chronic kidney disease. This is a mixed audience, so I'm just taking the liberty just to remind everyone. And these are the nutritional treatments that need to be put into place right in stage 1 CKD. So the first time you see a child, we need to ensure adequate nutrition for growth, treat comorbidities, and monitor for cardiovascular risk when there are no symptoms. And this continues and obviously, as the disease progresses, things will change. But what I'm trying to say is stage 1 CKD is the time that in children, that because this is a very crucial period. In children, nutrition and growth are very closely interlinked. So opportunity loss for nutrition is opportunity miss for growth. So these are pillars of CKD management in children. No doubt you'll control blood pressure, take measures to reduce proteinuria, management of hyperparathyroidism, management of hyperlipidemia, correction of acidosis, and ensure appropriate supplementation. So as you can see, other than control of blood pressure, the 5 other pillars are directly or indirectly related to nutrition. Again, highlighting, I think that if we have to optimize the results, we need to have a multi-D team. Now, there is an inadequate diagnosis of definition of nutrition in children. We don't know what is undernutrition. Unlike adults, very good studies are not available. So, in children with CKD, the prevalence of undernutrition varies from 2 to 65%, depending on what definition we use. What are the goals? Well, first and foremost, prevention and treatment of undernutrition, correction of uremic metabolic disturbances, prevention of electrolyte disturbances like hyperkalemia, which can be life threatening, attenuation of disease progression through optimization of protein or phosphate intake. And I'll tell you how this is completely different from adults. And preservation of intestinal mucosal integrity and function. There was an excellent talk by Alok earlier, and he showed that this is an area which is untapped, unexplored. A lot of studies need to be done here. So, what about nutrition and growth? Growth retardation is a hallmark of all chronic illnesses, especially chronic kidney disease in children. More than 50% of adults with childhood onset CKD will attain a final height which is less than the third centile. And the mean height deficit for all patients is at least 1.85 minus 1.85 shorter than the third centile for peers. And growth in nutrition is in fact in infancy is completely nutrition dependent. No role for growth hormone at all. And it's associated with increased mortality and morbidity both. So again, if you need to focus on nutrition and growth if you have to achieve good long-term results. So this is the definition of the International Society of Renal Nutrition and Metabolism regarding protein energy wasting. It is defined as a state of decreased body stores of protein and energy fuels. Uh, PEW or uremic malnutrition is a distinct condition in chronic kidney disease as has been realized. It is one of the strongest risk factors for mortality, morbidity, and impaired quality of life in patients, and is often associated with diminished renal function capacity. So, as Alok showed you earlier, recurrent infections which lead to progression. So that's why attention is very important. So these are some of the causes of protein energy wasting in children with chronic kidney disease. They need adequate feed intake, maybe secondary to anorexia, altered taste sensation, nausea, vomiting, emotional distress. Often we underestimate that. Intercurrent illnesses, unpalatable prescribed diets. So the child is your boss. When you're prescribing a diet, all nutritions you should need to understand that it is not you. You have to work with this child because otherwise, whatever you may write, this child is not going to take that. They impose dietary restriction and impaired ability to procure food because of socio-economic situation in many parts of our country. This is the correlation between protein energy wasting and advancing stages of chronic kidney disease. The mechanism of actions, you have nutritional restrictions, increased leptin, inflammatory cytokines, metabolic acidosis, vitamin D deficiency. Very important and very easily addressed in our setup. Altered glucose homeostasis, increased activity of the mitochondrial coupling proteins, leading to decreased intake, anorexia, proteolysis, increased resting energy expenditure, ultimately downstream regulation to protein energy wasting. These principles are in fact common to adults also. So This is the disability adjusted life years in children. So we are doing well. It has decreased with time, but I think there's a lot more that needs to be done. Now, this is a study in Lancet which showed global, regional, and national burden of chronic kidney diseases, a systemic analysis. So a lot more needs to be done here. So we start off with how would you assess nutritional status in children? Fairly challenging aspect. Dietary intake, a 3-day diet record or at least 3 24 hours dietary records are very important. Length or height for age centile or standard deviation scores, which are different, what you see in adults. Length or height velocity for age or SDS. Estimate dry weight or weight for age, centile or SDS. So you need to have your nomograms, BMI for height, age, centile or SDS, and head circumference, especially in the first year of life. Um, Head circumference for age centiles for SGS. So you have to be armed with all your centile charts if you have to, assess nutrition. Certainly not an easy task in your busy practice. So these are again the at different ages the different things that we do. But I think broadly speaking, as you can see here, it is all related to weight for age, weight for length, height for age, height circumference, weight for age, and serum albumin certainly as compared to adults, where simple things like body weight, BMI, skin fold thickness would do. So assessment in infants, toddlers, children, and adolescents are far more complex than in adults. So this is the anthropometric tools, a physical examination, blood pressure, biochemistry, which we all need to do to assess nutrition. Now again, one thing which is radically different in children is the protein requirement. A lot of time when our patient children go to nutritionists, they are advised protein restriction, which is totally, off the mark, because studies have shown, multiple studies, this is a randomized multi-center study of low protein diet on the progression of chronic kidney disease in children. And they showed beyond doubt that low protein is linked with poor renal survival. That's period. So no role of protein restriction at all. And again, these are certain guidelines for protein intake. So at different ages, you can see. Um, so recommendation for stage 3 CKD is 100 to 140% of your DRI. For stage 4 to stage 5, 100 to 120%. So this translates to 1.5 to 2.1, and in an average, say about 10-year-old, 0.9 to 1.135, 0.95 to 1. And the moment you are on dialysis, obviously the protein requirements increase. So protein intake, I think, in my experience, is one of the most neglected aspects of nutrition in children. Many times, these families are following social media, their neighbors. So everybody's an expert except the nutritionist and your treating pediatric nephrologist. Uh, these are the energy requirements here. Carbohydrate intake of 45 to 65, fat of 30 to 40%, protein of 5 to 20%. Now, if you calculate the energy requirements, it's fairly challenging. And oral intake of an energy-dense diet and commercial nutritional supplements should be considered as the preferable route for supplementing nutritional support for stages between 2 to 5 and 5D. When energy expenditure requirements cannot be met with oral supplementation, you should consider tube feeding or gastrostomy feeding, because you only have a limited number of years to optimize the growth. So it's not easy for the parents also to accept this, but I think a repeated counseling you can, achieve this. Again, as I showed you earlier, one of the very important factors in protein energy wasting is acidosis. And this earlier studies regarding the importance of correction of acidosis interestingly came from children with chronic kidney disease. Later on, there was a very good randomized trial published in JASN in adults, which showed that we should be targeting serum bicarbonates of at least 22. Very simple to do. Just give them sodium bicarbonate, which is homemade baking soda, easily available in every Indian kitchen. Again, these are the calcium and phosphorus requirements. You need to keep in mind different ages. So one size does not fit all in children. So they change. The phosphorus requirements also change. These are the vitamin D requirements. And as if you do estimates of vitamin D, a significant number of these children are vitamin D deficient. So vitamin D supplementation is again very simple, very cheap, very and easy to do. Now we are in 2023, very fashionable to prescribe growth hormone. But why I put this slide is that the role of growth hormone starts once the growth deficit persists despite treatment of nutritional deficiencies and metabolic abnormalities. So if you have not corrected this, that entire money is going down the drain. And mind you, once you start growth hormone, it at least a year of therapy, again, beyond the reach of the vast majority of Indian households. So when somebody asks me for growth hormone, a lot of time the parents, the child says, I'm not growing well. Can I use growth hormone? So I tell them, look, your nutrition is not up to date. Your sodium bicarbonate is sitting at 18. Your parathyroid hormone is sky high. There's no point in using growth hormone. You first optimize this. Certain practical tips to manage dietary habits in children. Again, as I said, very difficult task. Um, how to limit offer offer infants low sodium finger foods with solids when introducing solids. Limit or avoid salt in cooking. Now, caveat here: there are certain groups of kidney diseases which are salt-losing nephropathies, and there actually salt supplementation should be done. So, if you monitor growth in children, growth is going down. We actually end up supplementing salt in salt-losing nephropathy. It's only in the glomerular diseases that the principle of sodium restriction holds true. Again, rely on fresh rather than processed foods. Yes, vast rural areas not an issue, but again, as I said, metropolitan cities, it's becoming fashionable to use processed foods. So tell them to stay away from all this. Easier, they are wasting money. Again, you need to, if the child has to eat this food, we need to make it, tasty to his palate. Otherwise, so don't hesitate from using spices, herbs, lemon, some degree of lime juice and even vinegar. And the Indian kitchen is rich with all of this, and most of them are CKD friendly. So modify recipes with low sodium content. Do not drink or use water from a water softening system that replaces hard minerals. Again, it's becoming in most of the metropolitan cities now. RO is being used, and I think we should talk to the family, avoid to stay away from this. Plan for special occasions. Pack low salt snacks for outings. Avoid foods that are high in sodium, soy sauce, again with this Swiggy becoming very popular, this is becoming a big challenge, at least in my practice. The child doesn't eat the food that was cooked at lunch and dinner, and very easy to order food from your KFC or McDonald's. So how to limit phosphorus? Again, in neonates and infants, encourage breast milk. I think one of the most CKD friendly foods. Limit foods that are high in phosphorus thereafter, like milk, yogurt, cheese, organ meats, dried beans, nuts, butters. Again, preserved foods, stay away. Rice milk, interestingly, I found was, a very good substitute for milk. Time the delivery of the phosphate binders that it coincides with the largest amount of the meal that is consumed or the phosphate load. And children and caregivers can be taught to adjust phosphate binders. I think this one or two more slides. This is the phosphate pyramid here in the Indian diet. I think beverages, I think they are one of the biggest culprits of phosphorus. So we can use aerated drinks, Tetra Pak. We can use, the low phosphorate. So learn to read labels, but focus on eggs, fruits and vegetables. Ghee can be given, tender coconut water, buttermilk can be used. Potassium intake is another issue, again, which as the disease advances, we need to keep in mind. Dyslipidemia, again, I think this is the setting. A lot of children, when they grow up, will have cardiovascular disease. So this is the time, to try and to put into place good dietary habits. Um, this is the recommendations for vitamins and minerals for constraints of time. I will not tell you. This is a brief summary how the goals are different in children as compared to adults. First and foremost is that we are looking at much longer uh, outcomes in children, and growth is, you know, is a very important goal in children, unlike in adults. Mortality, fortunately, rare in children if you are, if they are vaccinated infection. The nutritional screening and assessment I showed you is far more complex. You need to have your centile charts. The management strategy, as I said, your breast milk is the optimal choice for infants. Energy intake is the same as in normal children. Nasogastric feeding should be resorted to. High carbohydrate content in supplements. Tubular disorders need electrolytes, supplements, totally different from adults. Low salt, if is recommended in hypertension, chronic glomerular diseases, salt supplements in tubular disorders, polyuric patients. Avoid ultra processed foods because of potassium or phosphate, and encourage high fiber intake, certainly a tall order. So, to sum up what needs to be done, well, we need to screen for chronic kidney disease. And today, obviously, we have to talk about EGFR. The EGFR formula, again, in children is completely different from adults. It's a Short's formula. We need to prevent and treat the complications of reduced renal function, anemia, bone disease, cardiovascular manifestations, hypertension, growth failure, and in each of these, the nutrition plays a critical role. Bone disease, cardio, as I said, dyslipidemia, hypertension, growth failure. So that's the overriding importance of nutrition in children is concerned. And obviously, this is a task which cannot be done without a multi-D team and aggressive nutritional therapy. Thank you. And on this note, I'd like to acknowledge the powerhouse, academic powerhouse, which has shaped my careers and many other careers of people sitting here. Thank you once again.
Thank you, sir. That was really great and enlightening. I have a question. How does the advice differ for children who are oliguric versus who are non-oliguric?
So, polyuric children, I think a very practical question. So, first and foremost, don't be too finicky about your potassium because polyuric children are very unlikely to get into hyperkalemia. So, be liberal with lemon, be liberal with some of the fruits, vegetables, and try and get a palatable diet in place. The second I mentioned, a lot of these polyuric children have salt-losing nephropathies. So, salt is the last thing that you should be restricting. You should, in fact, we are actually supplementing salt in these group of disorders. So it becomes the management to some extent becomes easier that you don't end up restricting all the things. And acidosis again, liberal use of sodium bicarbonate is very easy to use in polyuric patients, unlike in oliguric, where the moment you use sodium bicarbonate supplementation, the blood pressure goes to the roof. Right.
Thank you, sir, for such a comprehensive presentation. Sir, what is your comment about using appetite stimulants? Do you have any experience or would you like to comment? Because these children usually have poor appetite and it is very difficult to feed them. You said that we can go for tube feeding or gastrostomy feeding.
So I don't use appetite stimulant. That's the disclaimer. Appetite stimulants are all steroid based. So you are I don't know. You're choosing one evil against the other. Actually, the appetite is a issue only if the diet is not child friendly, and that's where the challenge is. And as we discussed earlier, if the child is polyuric, he can by and large have most of the things. So the real issue is getting a diet in place, which you have to really negotiate with the child there. And I recall my experience from Sick Kids Toronto, where we had the luxury of a very good nutritionist, in fact. And I mean, we never. I think getting a diet in place, I think for us was the easiest because all we would say was Deanne was I still remember the nutritionist. Hey, Deanne, just look at it. And they were going around centile charts. So make a diet. I think this is more for the nutritionist. Make a diet which is palatable for the using with liberal spices. What we find in day-to-day practice is the diet is very unpalatable. They'll restrict salt. They'll restrict oils. Absolutely no role of oil restriction. Unsaturated fats. So the herbs are restricted. You end up literally giving boiled food which the child is not going to take.
Thank you so much, sir. Thank you so much.
Thank you, sir, for the wonderful talk. And I request the chairpersons and the speaker, sir, to please let us felicitate your time and energy. And with this, we have come to the most awaited portion of the day, and that is Professor Anita Saxena Memorial Oration. And it is my proud privilege to invite on stage the chairpersons, Dr. Anil Kumar Bhalla, Senior Consultant, SGRH, New Delhi, Dr. Narayan Prasad, Professor in Head Nephrology, SGPGIMS Lucknow, Dr. Devdutt Shafekhar, Consultant Nephrologist from Nashik, and Dr. Pratim Sen Gupta, Consultant Nephrologist from Kolkata.
Good morning to all of you. Now we come to the prestigious oration started in the name of Professor Anita Saxena. This was decided in the last year Nasik meeting, and this is the first Professor Anita Saxena memorial oration, which is being delivered by none other than Professor Vivekanand Jha, who has made whole Indian nephrology proud by becoming the president of International Society of Nephrology. And he is the person who is known globally as well as nationally. And I will invite Professor Vivekanand Jha to deliver his oration on a very, very practical and important topic, that is food as medicine, implication for promoting kidney health. Professor Vivekanand, over to Vivekanand Jha, please.
Thank you, Dr. Malla and Professor Narayan Prasad. And let me start by, first of all, acknowledging and paying my homage to Professor Anita Saxena, whose contributions to the field of nutrition, especially renal nutrition, are well known to everyone and have been recounted by multiple speakers over the course of the last 24 hours. And Professor Anita Saxena was not only a force by herself, but she was also shaped and continued to shape the environment around her, as is she seen in the other picture that you see on your screen, which reflects the enabling situation that was presented to her by the leadership of the nephrology department at Sanjay Gandhi PGIMS. Professor Saxena was taken from us too early, but I think one of the best things that we can do is really to make sure that her legacy is continued by colleagues both within the department and outside the department. So, with that said, what I'm going to do over the last 25 to 30 minutes or so is to talk about the topic of food as medicine. How do we reimagine food, really, in the context of current knowledge that we have with regard to non-communicable diseases? And how do we promote not only kidney health, but overall health? It's for a long time that we have lived in silos. Cardiologists are separate and nephrologists are separate, and gastroenterologists and hepatologists are separate, but the patient is one individual, right? I mean, he or she, they have a health problem and they want a solution for those. Now, first of all, coming to kidney disease, I think this is well known and has been recounted, but for my younger colleagues from the nutrition sciences, one in every 10 individuals around the world has some form of chronic kidney disease. So just keep that in mind. We have 7 or 8 billion people living in the world, which means that 700 to 800 million people have kidney disease, in some sort of kidney disease. Not only that, chronic kidney disease is currently the third fastest growing cause of death. And according to the survey that we have done in rural communities in Andhra Pradesh, and this may be true in many other parts of India as well, that almost 9 out of every 10 individuals who, if you test them and find them to have kidney disease, they don't even know that they have kidney disease. The other thing which many of us are already aware of, but bears recounting, that kidney disease doesn't occur in isolation. It often develops in the context of background of hypertension, diabetes, cardiovascular disease, etc. And here you can see the contribution of diabetes in the blue sections of the bar, hypertension in the orange section of the bar, and so on and so forth. So an individual with kidney disease is likely to have all of that, and we have to manage all those conditions together. So therefore, chronic kidney disease is a complex condition. They have, as I said, not only those background conditions, but they will go on to develop protein energy wasting, as many speakers have already emphasized. Many of them will go on to require dialysis. They develop gut dysbiosis. They may develop infections later on. The role of inflammation has been repeatedly highlighted. Patients with kidney disease may also develop superimposed acute kidney injury, or patients may have acute kidney injury by itself without any background of chronic kidney disease. And they don't live as just a patient with a disease condition, but they're shaped by the cultures around them, the food habits that they have grown up with. So we have to keep into mind all of those before we decide how to adjust or manipulate their nutrition. Now, typically, it is a nephrologist. Again, we have often had a blinkered view about how we treat patients, and our goal of our treatment means giving drugs, right? I mean, so we will give you antihypertensives, we'll give you now SGLT2 inhibitors, statins, mineralocorticoid receptor antagonists, etc. But then for the rest, we don't want to spend time with patients. And Dr. George Abraham said earlier in his talk that in Kerala, a physician has 2 minutes to spend with their patients. And the last thing they do perhaps is to talk about diet and food. So, for a long time, we have thought about taking dietary approaches to slowing kidney disease progression, and we have been making a number of recommendations as nephrologists, as physicians, and maybe passing them on to our nutritionist colleagues. But I think all of us will agree here that most of those recommendations have not really been backed by robust evidence, right? And often we have focused on single nutrition targets and we haven't really thought about modifying the entire dietary pattern, which is something which we should keep in mind going forward. Now, if you step back and take a 40,000-foot view of non-communicable diseases, which includes chronic kidney disease, the global burden of disease data has shown that 1 out of every 5 deaths across the globe that is attributable to some sort of suboptimal diet. Please remember, note the use of the word suboptimal. It doesn't mean, that we are simply this diet is deficient in protein or in calories, but it is suboptimal in many ways, more than any other risk factor, and this is even more than tobacco, right? There are so many campaigns against tobacco, but there is hardly any campaign promoting the use of optimal diet. And these are again taking data from Global Burden of Disease study. You have the various disease conditions, and in the darker shade is the contribution of dietary risks to those disease conditions. So you can see that diet contributes to a huge amount of risk of ischemic heart disease, stroke, hypertension, diabetes, and you have chronic kidney disease also. So the contribution to diet CKD risk is relatively smaller. But please remember that many patients with CKD will go on and develop ischemic heart disease. So many of those patients actually are in this box, right, in the top left box. So diet is perhaps contributing to the risk of development of kidney disease and its complications, which goes back to the point that I made, is that when we look at managing these patients, we have to look at it in a holistic manner. When you break the dietary risks down to its individual components, and I apologize if it's difficult to read, but basically it talks about grains, sodium, fruits, seeds, vegetables, and so on and so forth. Right, so we have to, and you can see that still there are a large number of what is called disability adjusted life years, which is one of the measures which is used to determine what harm a particular condition is causing. It may be a disease condition, it may be a risk profile, etc. So this includes both death and years lived with disability. So a individual may not necessarily die right away, but they will live with a lot of disability, as happens to many people with chronic kidney disease, people on dialysis. So they're living, but that is really a life lived with extreme disability. So we now know in general that there are a few dietary patterns which are considered healthful. And these dietary patterns are named differently, but they have a number of common features: Mediterranean diet, DASH diet, dietary patterns which have dietary acid low, which is reduced, and something which is high in healthy eating index. So typically they have rich in legumes, and they are rich in nuts, and and low fat dairy products, and in Mediterranean diet you have olive oils and so on and so forth. But as I said, low diet quality, we shouldn't think of low diet quality as just one homogeneous entity. So there can be two types of insecurity that we have in association with food, nutrition, etc. One is people who are food insecure. Food insecurity is a big problem in many countries, including India. People just don't get sufficient food, right? And the second is nutritionally insecure. So these are people who may be getting adequate food, but that food is not nutritionally optimal. So that is something which we don't often think about. So in today's world, there may be many people who have enough resources, enough wealth to actually obtain food, and even many of our public food insecurity programs, they provide food, but they often don't provide sufficient nutrition. Our National Food Security Act, which was promulgated in 2013 in India, says that the government and the system will ensure food and nutrition security for the most vulnerable through its associated schemes and programs, making access to food a legal right. But despite all of that, there are studies on dietary consumption patterns in India, and I'm quoting here only one of those studies, which reported that adults have poor dietary intakes. More than half reported no consumption of green leafy vegetables. This is really very important. Again, half did not report consumption of even other type of vegetables and fruits. 72% reported consumption of 3 or more servings of energy dense foods. So they get only energy, they don't get any other type of nutrition. More than 90% reported consumption of 3 or more servings of energy dense beverages on the previous day. So, what is energy dense beverage? Something which is rich in sugar, right? So, as you go even in rural areas, we make tea with lots of sugar, and in the cities, children are consuming many fizzy drinks which are very rich in sugar, etc. Fruit consumption was very low in all age groups, and in fact, strikingly, as I said, even though some people may be food secure, so people in higher socioeconomic class strikingly consumed no green leafy vegetables, which means they are high socioeconomic groups, but they are nutritionally not secure. That's very important to remember. There are a number of barriers and facilitators of healthful dietary pattern, and this is something which has come out of US, but still I think the general principles will apply to geographies all across the world, and they are shaped by individual beliefs, their knowledge. So I'm sure that all of us encounter patients who come to our clinic, both nephrologists, physicians, and nutritionists. They will come with their own knowledge, prejudices, which is shaped by what people around their neighborhood, their community have told them. For example, the strong belief that rock salt is good for health or something like that. They come with those kind of beliefs. And then again, these are influenced by interpersonal connections. Family members tell them something. There are peers, people sitting in even in the waiting area talk to other patients and pick up information, then go on to community institutes, and then we have institutions. And here institutions have a wider meaning. Institutions don't mean a medical institute, but the various systems that we have set up around ourselves. So the public distribution system is an institution in itself, and there are rules and regulations, and they decide on what kind of food is availability, how much does it cost, and this is all shaped by the policies that the government makes around this. So again, if we go back and think about food, what role does food play in our lives? Typically, we think of food as a source of nourishment, first of all, but food is heavily influenced by culture. Food is often partaken for enjoyment. You like taking good food, food that tastes well, and often certainly for sustenance. But have we ever thought of using food as a medicine? So what is the difference between food and medicine if you look at it that way? And if you break it down, what is food? Food is for whom? Food is for everyone, right? But medicine is only for people who are not well or and called patients in our terminology. Food can be chosen for a number of reasons, but medicine is chosen primarily for health reasons. You don't consume food for health reasons primarily, right? Health may be one of the factors. Food is taken for our entire lives, but medicines are taken typically only during illnesses. Activities, you have to, we shop for food, we prepare food, then we share food with our families, friends, and so on and so forth. But medicines, you typically take pills and injections. Food is tested for safety only. That it should be safe. It should not be poisonous food. You should not be eating poisonous mushrooms, for example. But it's not tested for efficacy. So you don't typically eat something and think at that time, is it going to be good for me in some way or the other? But medicines are tested primarily for efficacy, but also equally for safety as well. Food is produced by food companies, farmers, individuals in their kitchen gardens, and so on. But medicines are produced by pharma company. Food is regulated by government and food sector, but there are other agencies involved in medicine regulation. Side effects are not accepted with food. you don't expect, except when you over consume, then of course there will be side effects. You will perhaps not lie comfortably in bed that night, but sometimes medicines side effects are accepted with medicines. So then let's talk about how do we think of food as medicine, right? And here we have to again learn from the cardiology literature and cardiology community, who has been always ahead of nephrology community in implementing changes in clinical practice, doing clinical trials, and so on. So the American College of Cardiology, a couple of or just about last year, came up with a presidential advisory on food in medicine, and in that they define food as medicine as a practice where healthy food is provided to prevent, manage, or treat specific clinical conditions. So this is which is what we use medicines for, right? We use medicines to treat specific clinical conditions. So now we have to think of using food to treat and manage specific clinical conditions in a way that is integrated with the healthcare system. This is also very important, because right now we leave, ultimately we give some advice to a patient or an individual regarding their diet, regarding their nutrition, and then we'll leave it to them to follow it or not. But if you think of food as a medicine, then the healthcare system also has a responsibility to provide that appropriate dietary pattern or the dietary combination that we will prescribe. And we'll see how that works. And this is again, there is a lot of information in cardiovascular health, which is relatively strongly evidence based. And so the evidence based guidance to promote cardiovascular health, which is roughly the same as would be required for promoting kidney health, is emphasizing the consumption of certain types of diets, which you see here. Fruits and vegetables, whole grain foods, healthy sources of proteins. Only think of healthy sources of proteins, not just. So, protein is just not one entity, right? There is one type of protein and there is another type of protein. And then liquid plant oils such as soybean oil, canola oil, and etc. And minimize the consumption of beverages, foods with added sugars, ultra processed foods, even the bread slices that we eat every day. We don't even think about it, but it is one of the most richest sources of sodium that we take, right? Processed meats. Indians don't consume a lot of processed meat, but still it is important. Food high in salt. So think about food high in salt, and someone really emphasized the value of reading food labels. Food labels are now becoming more and more ubiquitous, especially in department store foods. But still, a lot of our food is consumed from informal sector where there are no labels, etc. So you'll have to be careful. Consumption of alcoholic beverages should be minimized, and tropical oils should be minimized. Now, Dr. Chen et al. Published a few years ago the nutrition and lifestyle interventions in the trajectory of kidney disease. So, as opposed to cardiovascular disease, kidney disease trajectory is somewhat more complicated than cardiovascular disease, because you will start with someone who is only at risk of kidney disease here and go down on the go to the right on x-axis to a situation where someone goes on to require dialysis. And these are the initially you're thinking of controlling disease progression, then managing some of the complications that might develop. And we have had a number of talks in this conference already, so I won't dwell on it too much. But again, once the patient goes on to a pre-dialysis stage or even on dialysis, then other issues also come into consideration as we think about it. So this is now, let's go into some of the details of food as medicine. So what is food as medicine and how would you approach it? So food, again, you can look at it in a tiered approach, that we can start with interventions that will affect the largest number of people. And as we know, as I said, I hope you're convinced that a large proportion of population around the world, including in India, are at risk of developing non-communicable diseases, right? Diabetes, hypertension, cardiovascular disease, kidney disease, etc. And therefore, it makes sense to have population level healthy food policies and programs, right? So, as I said a minute ago, that our food policies, the government that created it 30, 40, 50 years ago, were simply at that time geared to provide calories more than anything else. They were not necessarily thinking of the entire nutrition programs. And then we have specific nutrition programs. These are US based examples, but in India, we have three specific programs. We have the Integrated Child Development Scheme program, we have the PM Poshan program, And then we have the public distribution system or the ration shop that we are all familiar with. And through those three programs, the government provides solutions for food insecurity once again, rather than for nutrition insecurity. And then we go on to produce prescription programs, and then medically tailored groceries, and we'll talk a little bit, and medically tailored meals. And so these are now groceries and meals which are provided through healthcare system, which is what food is medicine uniquely provides. And the specific food and nutrition interventions that we can use in the healthcare systems which are relevant to kidney care are shown here. And you can look at the populations, people at risk of chronic kidney disease or with very early stages of chronic kidney disease, then going on to those who have established kidney disease, stage 3, 4, 5, etc., and those who will have some unstable conditions. For example, they have developed acute on chronic kidney injury, or they have just been transplanted, require rehabilitation, they have acute infection, and so on. And then there are the types of interventions, as I said before, medically tailored meals, medically tailored groceries, etc., produced prescriptions. Where are they relevant? So produced prescriptions are relevant at more proximate levels, but as we go up, and we have been doing it. It's not that we have not done it ever. For example, if you go to a hospital where in ICUs, medically tailored meals are provided, but I think we have to take it now beyond ICUs and even hospitals. So what are medically tailored meals? And you have the definition here, and I won't read them out, and these slides will be available to you later on. And these are a few examples of the various interventions. The medically tailored grocery intervention, again, participant profile we have discussed, and these will be identified in a clinical setting and may be eligible because of a previously diagnosed condition. And then experts, which will include nutritionists and physicians who have interest in nutrition, will select and source food, and this sourcing of food will be responsible for of healthcare system. For example, your hospital pharmacy right now sources medicines, but then there will be a program in the hospital that will source foods also, hopefully in the food as medicine system. And then food will be prepared and delivered. For example, we have again hospital pharmacy which prepares medicines, and there used to be other types of preparations, IV fluids, etc., would be prepared in hospitals. Then there will be another program components which can include nutrition education, and we should take help of other healthcare professionals such as community health workers and so on. So this is how grocery intervention will work. And similarly, now let's look at meal intervention. So in this, meals will be prepared and then meals will be shared. Actually, the process remains roughly similar in terms of participant profile, identification, food selection, sourcing, and food prep and delivery. Here patients can be given meals which they can take and then use and reheat, etc. So these are the programs that are now being thought of in different parts of the world. Now, I think we have had enough discussion on the matter that I had in the next few slides, so I won't dwell into it, except to say that these kind of interventions not implemented in the food as medicine program have already been shown to reduce, for example, the incidence of chronic kidney disease. This is the atherosclerosis risk in community study, and this is incident chronic kidney disease using different indices. And then you go on to this meta-analysis, which again shows that healthy food provision reduces the incidence of chronic kidney disease in multiple conditions. Established chronic kidney disease, prevention of chronic kidney disease once again has been shown in multiple studies, including meta-analysis that you can see here, that it slows down the progression of chronic kidney disease, which makes the case that yes, we should think of food as medicine as a legitimate intervention. And this is the most recent paper, which has just appeared in press in American Journal of Kidney Diseases from the Creek study, etc. And again, we often talk about these are all Western concepts of Mediterranean diet, etc. But we have to think of there is such a rich culture and tradition of food in India. We have to go ahead and think and develop our own dietary patterns, which our patients can consume. There are 1.4 billion of us on this world, 1/6 of the world population, and we can't continue to remain dependent on European dietary patterns, etc. We have to develop our own. Now, coming towards the end, so medicine, typically we think that the medicines are acting through some pathways. So we should also think of food also in a same way. What are the pathways that food items, can think of, our food systems can work through to prevent development, progression, or development of complications in patients with chronic kidney disease. And there are a number of those. A number of these have been discussed in several talks already, but we have to think of them all together in a holistic manner. Which medicine do you have right now which addresses so many of pathways in the same way, right? Improving blood pressure control, reducing oxidative stress, endothelial dysfunction, improving lipid profile, insulin sensitivity, dysbiosis. We had an excellent talk earlier this morning. Other things we haven't talked about is reducing complement activation, reducing endothelin 1 and renin-angiotensin system activation, and so on. And I'll draw your attention to this excellent review which came out in the Nature Reviews Nephrology a couple of years ago, which also talks about the phenotype, the CKD phenotype and the pathways, and the experimental studies that are being done now to substantiate that work is that food that for which normally we would think of for identifying a medicine for any of these conditions, right? But food actually can do the job, and we don't have to necessarily go out and look for medicines. We often talk about the value of Indian food systems, the ingredients of Indian food systems, starting from turmeric, etc. But we need to do more work. We need more studies in those food systems to identify what is doing it, and doing scientific studies rather than simply going out and promoting, that something is working or not working. Then we must also think of some system level barriers and how to remove those barriers to fully exploit the value and the benefits of food as medicine. So we have to remove barriers to healthy eating, which can in many cases in India will be inability to afford or access recommended foods. So how do we do that? The entire society has to think about it. We have to alleviate constraints that prevent patients from affording medications and also paying bills, so that maybe some sort of food as medicine program could also come under the ambit of insurance coverage of some sort, right? Because if you think of food actually as providing those benefits that typically medicines do, they should also be covered by the same systems that covers payment for medications. We need, of course, more education, and education geared not only to nephrologists and to nutritionists, but also to general population, to maintain more healthful diet which is past the duration of the intervention. Often there is often an intense period of intervention where we deliver something to patients and then we forget about it and the intervention kind of tails off. That shouldn't happen. And of course, we hope that it will improve disease management and cause fewer admissions to hospital, and later on lead to improved long-term outcomes. And mind you, this is something which will make the policymakers sit up and take notice, which is the health economic benefits of medically tailored meals and produced prescriptions. Again, this has not been data has not been generated in India, but it shows that actually one can end up saving huge amounts of money just by providing appropriate medical meal related interventions. But then we need to do a number of other things also to make sure that this will happen. This needs to be integrated in healthcare, should not sit outside. As I said, we need more data. We need to improve clinician knowledge also in this space, and we must get sustainable funding to make it happen. But the fact is that the increasing interplay between diet and medicine should be thought of giving food a higher purpose. So food is not only for sustenance and for enjoyment, but it is really it goes beyond that. It transcends all of those goals that we had. So we can going ahead, we can think of a food symphony in managing chronic kidney disease. So it's not just one type of food. In symphony, you have a lot of instruments coming together, right? It's not only protein or it's not only say low phosphorus diets and so on, but you have to think of food that will do more than one thing. And again, these are the components which are shown here. We have to think of food, energy, nutrients, cardiovascular system, etc., general good health, gut microbiome, how to improve gut health, how to improve muscle and bone health, and eventually all of this will converge on improved kidney health. But also we have to remember that we live in an era of, as I said yesterday, in a climate change. So we have to think of sustainability also. So the sustainable food is both not only fair and accessible, but also ecologically responsible and healthy. And so these are the two main things that we have to think of, that sustainable food should promote and maintain nutrition dense, not only calorie dense, right? So all types of nutrition should be available that optimize health, and they should meet current population needs without compromising the needs of future generations, because they are the ones who will be affected by climate change going forward. There are a number of knowledge gaps. As I said, there are few randomized trials of dietary intervention specifically from India. Foods on outcomes, we need to focus more on outcomes that are clinically important and of relevance to patients. We need to develop dietary interventions which are tailored to the needs and preferences of those populations. All our trials should be locally relevant and applicable in real world settings. Often dietary advice that the patients get, they, they can't apply them at their homes. They are completely unrealistic, and I have to actually sometimes suggest don't follow these advice to I don't like doing that, but that you have to do that also, and we need to keep scale up in mind. So therefore, right on the bell, let me come to my conclusion slide. Food as medicine for kidney health requires us to reimagine food as medicine and its role in healthcare, including in kidney care. We need to strengthen the evidence based around food as medicine through appropriately designed studies. And some of this will require us to talk to other specialists like social scientists, behavior change specialists, etc., to bring in human-centered design into these kind of studies. And we have to expand the complementarities of advocacy and policy work through cross-sector community engagement and inclusive coalitions. You can't only work in clinics. You have to go into the community. All of us have to go into the communities and understand what do they want. And to that end, we must standardize professional education to include nutrition science and food as medicine research as well. Thank you very much again for your attention. And once again, I pay my homage to Professor Anita Saxena.
So just you can imagine with this presentation and so much evidence based. So why Professor Jha has been chosen for this audition, you can just understand. Since this is a audition, so we don't have question answers. But definitely Professor Jha is here, and anybody has any questions, the great topic food as a medicines, you can clear your confusion. Anything is there with Professor Jha, and I would like to have the big round of applause for him. And I will request Dr. Amit Gupta, since our immediate past president of Indian Society of Nephrology, Dr. Gulati is here, Professor Georgie Abraham to come on the dash and to have this felicitations with this oration flag to Dr. Jha.
सम्मान को सम्मानित करते हुए बहुत-बहुत धन्यवाद. Now we have entered our session 8, and I am grateful to invite on stage the chairpersons. Dr. Aditya Kapoor, Professor and Head, Cardiology, SGPGIMS, Lucknow. Please welcome him with a big round of applause. Dr. Mohan Gurjar, Professor, Critical Care Medicine, SGPGIMS, Lucknow. Dr. Pratim Kumar Das, Associate Professor, Ram Manohar Lohiya Institute of Medical Sciences, Lucknow, and Ms. Sunita Saxena, Chief Nutritionist, King George's Medical University, Lucknow. And I request the speakers to please adhere to the time because we are running short of time. And now I turn the time over to the chairpersons to introduce the speaker and to introduce the topic.
So the next lecture is on role of nutritional modification in patients with cardiorenal syndrome. So for this lecture, we invite Dr. Umesh Khanna sir. He is consultant nephrologist and transplant physician based in Mumbai. He is chairman of Mumbai Kidney Foundation. He has more than 30 years of experience, and he is one of the first to start nephrologist managed private dialysis unit in Mumbai. Thank you, sir.
Thank you, Chairpersons, and I pay my obeisance and respect to Professor Anita Saxena. And what a brilliant talk, and the topic which is chosen for her oration. It was really very nice of SRNM Con to choose the oration, the topic, and the speaker, which really was worth listening to. I remember Professor Anita Saxena always, from day one, has invited me and has generally given instructions when the going is too tough and बहुत ज़्यादा अगर सिखाया जाएगा तो you just come in and make the situation a little light so that I think people are not, they will be fresh for the next talk as it comes to. And I thought Dr. Narayan Prasad is a friend of mine. People were given one small topic on, some phosphorus or some calcium or some salt. And I have to not only talk about cardiac diet, but also renal diet, and then mix them together into a palatable and acceptable, cardio-renal diet. And you know how friendly cardiologists and nephrologists are. The heart is king, everybody knows. But I think by now, everybody is also aware that kidney is the most important organ. The heart, of course, decides what to eat. And then after eating the Lucknow food, which we all ate yesterday, and it was brilliant. But then that's how lifestyle diseases, and you land up with kidney problems and heart problems together. So cardiorenal syndrome, I mean, sometimes it's difficult to understand even for us. Is heart disease leading to kidney problems? And so the kidney takes its own badla. I mean, this is natural life, how it goes. And you have then kidney diseases leading to heart diseases. And that leads to 4 types of cardiorenal syndrome. And in this fight between the heart and the kidney, I have to balance a heart healthy diet and a kidney healthy or kidney friendly diet, all in the span of 15 minutes. I take away the 20 minutes because I have been warned. The spectrum of disorders basically involving both heart and kidneys. You could have a acute or a chronic dysfunction in one organ, which may induce a similar acute or chronic dysfunction in the other organ. Cardiorenal syndrome, basically, we have now learned a lot throughout these, 1.25 days session on malnutrition, cachexia, anemia, deconditioning, and I don't want to continue to talk to you about all that. Just to understand briefly, when you have a temporary problem or an acute heart failure resulting in acute kidney injury, you have one type. And if you have a chronic heart failure resulting in CKD, you have another type. So obviously, this is the heart, giving trouble to the kidney. And then, of course, ek bar panga liya kidney se, to obviously they will also retaliate. So you have acute kidney injury, which would basically then result in acute heart failure. And similarly, if you have a chronic kidney disease, along with it, a chronic heart failure, then you have the type 4, and the type 5 is specific to secondary cardiorenal syndrome with some diseases. So this pathophysiology of cardiorenal syndrome, basically it's a jugalbandi, and we've dealt with the inflammation, stress, neurohormonal involvement, inflammation, etc. But I'll keep it simple. Basically, cardiorenal syndrome does not come alone. It comes with comorbidities. यानी अगर है तो उसमें you could have either anemia, obesity, hypertension, diabetes, smoking, tobacco, hyperlipidemia, salt and water retention हो जाता है, electrolyte abnormalities, inflammation, and then you have the basic acute or chronic decompensation of the heart and acute or chronic decompensation of the kidney. This is all that is part of cardiorenal syndrome. This is not a platform to discuss medical therapy of cardiorenal syndrome, but then you know that you're going to use these drugs. It will alter something, which in turn will help the nutritionist and the nephrologist to alter the diet accordingly. For example, you will have to use diuretics and sometimes in very large doses because there is a kind of diuretic resistance at times. And then you'll end up with sodium issues and potassium issues, and therein lies the importance of nutrition in it. Almost all of them would be on ACEs and ARBs, and we have learned in the last so many hours of this meeting that there will be potassium issues along with it. Some are on special drugs called ARNI. Again, you have potassium issues with it. Dr. Vivek Jha and many others alluded to the use of MRAs, which would also cause potassium issues. And then you have lenoxin sometimes used. Maybe if potassium is low, you have problems with lenoxin. People use beta blockers for heart issues, in which again potassium problems. So all in all, what I need to tell you is that medical therapy and nutrition will go hand in hand, especially in cardiorenal syndrome, because of that jugalbandi which is involved in the two, one leading to the other. Now, medical nutritional therapy again would form one of the important areas. There will be some issues which are heart healthy, and there will be some issues which are kidney healthy, and there will be some issues which are common. So like the cardiologists like to have more potassium, and they make it, they call it heart healthy. And then the nephrologists are anti-potassium, although there is now enough evidence to show that you can give a regulated amount of potassium, or heart healthy products need not be banned completely in CKD. So that's the role of a Taylor word, I think, was used very often in the Taylor becomes the most important person here. Everything is tailored to an individual person or the illness. So potassium to give more or less. Proteins, I think a lot has been discussed, and everybody has pointed out this whole country is on a CKD diet, so you don't need to do anything specific to handle the protein part of it. Phosphorus and calcium, the nephrologists are a little more bothered, and when you try and lower phosphorus with calcium drugs, and the associated calcification and issues are there. वो झगड़े के बीच में there are a few factors which are common for both. For example, both of them like low sodium diet because sodium is one of the bigger culprits and poison. Fluid restriction is something which majority of the cases would be needing it. Low saturated and trans fat, again, there is not much discussion. Dono log, they can sit together on one table and discuss on it. And complex carbohydrates preference over simple carbohydrates, again, a non-negotiable item. So these are a few areas which are common to both. I have to keep looking at the watch. Association of malnutrition ho gaya, bahut sara discuss ho gaya, need not discuss. So what are the practical problems which the patients face in cardiorenal syndrome? Calories, most of them will be malnourished or will have poor calories for whatever reasons. Congested liver, bhook nahi lagta, दूधी खा खा के तंग हो गए. So calories are something which you need to work upon, and therefore that's an important area. Proteins we discuss. Fluids, it's an important area because cardiologists probably do not pay that much importance to fluids, and if you don't manage salt and fluids together, you'll end up in difficulty. When मैं जब भी छोटा था, I went immediately after my DNB to Dr. Mani's unit, and one of the most important lesson is he has a formula. 500 ml, no salt. 750 ml, 2 gram. 1 liter, 3 grams. So basically, he has titrated salt and fluid in such a manner that you don't land up with hyponatremia. अगर एक तरफ से पानी पी रहे हैं, एक तरफ से salt कम कर रहे हैं, we have a lot of such dilutional hyponatremia patients referred by cardiologists to us, or at least they are at a loss to understand ये क्या हो रहा है. So salt and fluid, I think there is adequate importance of it. Lowered appetite, again, a lot has been discussed between the use of domperidone and migestrol and appetite stimulants. So again, I won't talk much of it. So generally, the principles would be common. Sodium or salt restrictions, and I don't need to teach the dietitians as to what they do when they ask for salt restriction. Uske badle kya dete hain, what are the adjuncts and what is allowed, what is not allowed. Enough has been talked about Lona. Dr. Vani gave an excellent talk on yesterday on the salt substitutes. This understanding mechanism is not important. Actually restricting salt is important. So we'll not go into the details of it. Fluid management, I just told you what is the importance of not only fluid management, but adjusting it with the amount of salt. Balanced diet, again, there's nothing much talk of. Dr. Vivek Jha very eloquently talked about the importance of DASH diet, the importance of healthy vegetarian diet. In fact, most of us are taking diet, vegetarian diet, which is a kind of similar to the DASH diet, except the olive oil business. Healthy fats, again, everybody knows trans fats and saturated fats are out. Omega-3 fatty acids, in little work on it. Foods rich in omega-3 fatty acids like fish, flax seeds, walnuts may have anti-inflammatory and cardiovascular benefits, helping in dyslipidemia, cardiac, atherosclerotic, and non-cardiac advantages. This is the center of any cardiorenal syndrome management, because potassium will play a very important role, not only because of the disease, but because of the drugs which I highlighted, which are the drugs will lead to hyperkalemia, why some of those drugs are important, and why, in addition to giving those drugs, if you have a dietitian who has already given them advice regarding low potassium diet, you will be in a position to use those beneficial drugs for longer period instead of adding another drug which will bring down potassium. So diet and drugs, that means together we can play a role in continuing those drugs which are very essential but can cause hyperkalemia. So sodium, potassium, phosphorus, again, I think we know now how to handle phosphorus, not very rigidly, but at the same time keeping it nearer to normal as possible. Calorie control, we know, should be and tried best to make the calories as healthy as possible, as much as possible. Micronutrient supplement, I think vitamin D, E, carnitine, etc. Not much of data available, but may help in some cases. So this is the penultimate slide. It basically does tell you, and again I will use this, that in the type 1 cardiorenal syndrome, where it's basically a cardiogenic shock leading to AKI and an acute heart failure resulting in AKI, nutritional management is same like any other critical care patient. High calorie, high protein, as much as tolerated, or whatever is the critical care management. But type 2 is basically chronic heart failure, eventually leading to CKD, renal diet, whatever fluid restriction always will go. Type 3 is ulta, acute renocardiac syndrome. That means heart failure in the setting of AKI, mainly volume overload, correction, electrolyte, potassium, sodium monitoring, and the standard CKD with heart involvement, which we all see. A diabetic CKD is a classical example with low ejection fraction, where protein, which is a typical standard CKD diet, which a lot has been talked about. So in conclusion, nutritional modification plays a pivotal role in management of cardiorenal syndrome. You have to have a well-balanced both kidney and heart-friendly diet, tailor-made, regular monitoring of the nutritional status. Everybody has talked about it. Salt, water, potassium, calories, proteins should be looked into, and avoiding malnutrition or low calorie is the best part. Thanks so much. So I had kept some part of my talk for the advanced nutritional course, which I am sure they will invite me. This is the course which is meant for a simplification of cardiorenal syndrome. Hopefully the questions are also simple. Yeah.
Yeah, I just want, because there are a lot of nutritionists in this audience, just to say a word or a sentence about magnesium homeostasis.
Good point.
Please, you have to make that.
No, so I think magnesium plays a very important role in cardiorenal syndrome also, and especially patients who are on long-term therapy with diuretics. They have hypokalemia, they have hypomagnesemia. Magnesium is important for muscles, including the cardiac, and the other things you could add.
Yeah, some of our patients who are transplanted, They are on CNIs, and CNIs produce magnesium depletion. And also we are just jumping into the onco-nephrology field. A lot of the onco drugs, which are also produce cardiac failure and kidney disease, they have, especially the cisplatin produces magnesium deficiency. So I just want to say that just to add
Magnesium
to your
is-
excellent talk.
Thank you so much.
So apparently, due to lack of time, we told no question. But I know I absolutely loved your lecture.
Thanks.
And I'm a cardiologist, so one small thing. Since we are sitting in the dais, we have to speak something.
I did speak too bad about cardiology.
No. That the only thing I wanted to add was that you when said heart is king. I'd just like to modify that analogy क्योंकि body एक department की तरह है. ठीक है ना? So rotating headship होती रहे तो अच्छा है. कभी kidney बन जाए, कभी
Very
cardiac
nice.
बन जाए.
Thank you. Yeah, okay.
Thank you so much. I request the organizers to felicitate speakers, sir. And there is a quick announcement that many of the faculties are having their flights in the afternoon. So let us restrict ourselves to the time allotted. And please, it's a request not to prolong with the questions. Thank you. Over to the chair for the introduction of the next speaker.
Next talk. So next talk is on the nutritional approach in catabolic AKI. Speaker is Dr. Manjusa. She is a professor and head Department of Nephrology, Gandhi Medical College. She is Deputy Chair, Social Media International Society of Nephrology and General Secretary, Women in Nephrology from India.
Thank you. Thank you so much, sir. As has been suggested by the organizers, I won't take much time. I would like to run through my slides, and thanks to the organizers of this conference for giving me this opportunity to speak on the occasion in the memory of Professor Anita Saxena. This is a little difficult topic because this is not much embarked in our daily practice with respect to the nutritional assessment in AKI. So much literature, so much assessment is done in CKD, but then in AKI, it becomes a little difficult task for us to focus on nutrition aspect because we'll be focusing on the emergency management of a patient. But nevertheless, since the topic is given to me, I would like to take you through brief information about this nutritional approach in a catabolic AKI. So my talk is going to be on briefly on introduction, assessment, how to assess, what are the nutritional therapies in brief, and what probably would be the future. So this definition has been spoken about by many speakers. This, of course, is applicable even to AKI, which has been proposed by ISRNM. This is a state of decreased body stores of protein and energy fuels in patients with CKD and AKI as well. This is what ISRNM has said about protein energy wasting, which is another term for malnutrition. The prevalence of which has been reported to be around 66%. The pathogenesis of PEW in AKI is multifactorial, as has been said: protein catabolism, alteration of metabolism of specific amino acids, reduction of lipolysis, depletion of antioxidant systems, and of course, the inflammatory state which is there. It is a very unclear concept whether the restriction of energy or the protein, or probably giving a good amount of protein, is going to have any influence on mortality. That's the reason why we are at this point. What is the optimal energy or protein requirement in AKI is not yet known. And to have a basic information, this is about the AKI nutritional requirements, wherein they have said the protein requirement in a metabolically not stressed, that means metabolically stable patient of AKI, is about to range from 0.8 to 1 gram to 1.2 to 1.5 there on CRRT. And if it is a hypercatabolic patient, it may go up to 1.7 gram per kg per day if the patient is on CRRT. So the nutritional hallmark of AKI, especially in the setting of critical illness, is excessive protein catabolism. So why is there a high rate of catabolism in AKI? Because of the concurrent illnesses which are associated with a significant pro-inflammatory state and metabolic derangements that predispose the patient to diminished utilization and incorporation of the available nutrients. How to define a malnutrition in ICU? As I said, that's only ISRNM definition is available. There's no validated definition of criteria, but nevertheless, we all understand that PEW is associated with a higher mortality and longer duration of hospitalization. This is the literature that we have, which looks into what is the prevalence of mortality in ICU with respect to the AKI. Assessing the malnutrition is one of the factors which influences the mortality. The focus was on certain markers such as serum albumin and serum prealbumin. So meta-analysis of randomized control trials have demonstrated that energy and protein provisions were not associated. In fact, this is another a little interesting point, which is said that even though we know that so many markers like albumin, pre-albumin, so many other things are available, but meta-analysis has said that the energy and protein provisions are not associated with clinical outcomes in critically ill patients. So how do we assess nutrition AKI? AKI is supposed to be a risk factor for malnutrition. All hospitalized patients with AKI and AKD should be screened for malnutrition. If they're staying more than 48 hours in the ICU, they should be screened for malnutrition. We have many tools such as serum biochemistry, body mass, muscle mass, dietary intake, and certain other tools. Serum biochemistry, if there are good markers, are there any good markers to assess nutrition starting from albumin, pre-albumin, anthropometry, etc., etc. And of course, the latest one to the bandwagon is the BIA. It has been said the serum albumin may be considered as a marker, but more than the assessment of the nutritional status, it is more towards the mortality. So biomarkers alone are not reliable in diagnosing PEW in AKI patients. Serum albumin and pre-albumin not included in standardized diagnostic criteria for malnutrition proposed by SRNM. By Academy of Nutrition and Dietetics and American Society of Parental and Enteral Nutrition. There is another group which has come up that's called GLIM. GLIM stands for Global Leadership Initiative Malnutrition, which suggests that serum albumin and pre-albumin are used as proxy measures for malnutrition, for inflammation rather than malnutrition. So how to assess the nutritional status in a hospitalized patient with AKI or AKD? General nutritional assessment includes the patient history, if there is any unintentional weight loss, decrease in physical performance before hospital admission, and then the physical examination, general assessment of the body composition, muscle mass, and strength. So at this point of time, is it possible for us to calculate BMI, SGA, albumin, or probably albumin and physical examination, which is going to give us a clue with respect to an admitted patient? This is all difficult for us practically, but nevertheless, protein energy wasting assessment and clinical outcomes in patients with acute kidney injury, a systematic review has said that SGA probably can be a better tool. In the tools that I projected, SGA was proposed as a better tool compared to the other tools. And the scores of assessment, good number of scores are there like MUS score, NRS, Nutric score, Renal Linet, CONUT. So many scores are there. But then utility of these scores, applying them bedside, is it feasible for us? And are we going to get an adequate information with respect to nutrition and change of the nutrition with respect to the beneficiary outcomes in management of the patient is truly questionable. So most of them suffer from major limitations, especially when applied to the patients with kidney disease and especially in those admitted in ICU. So the other aspect of assessment in patients in ICU is lean body mass, muscle mass, and function. So body composition assessment should be preferred to anthropometry measurements when diagnosing malnutrition patients of AKI. So how do we identify the muscle mass in the early days when they're admitted in ICU? This muscle mass is supposed to be the major cause for delayed weaning from mechanical ventilation, and it is supposed low muscle mass is associated with morbidity and mortality. But then lack of reliable bedside tools impairs or curtails us from assessing muscle mass in a significant way. But nevertheless, we have these tools, that is BIA, DEXA, CT, MRI, and ultrasound of muscle mass. Again, we understand these are not practically possible for us to shift a patient from ICU, get the things done in radiology department. But then it has been shown that assessment of ultrasound of muscle mass is supposed to be one of the easy and bedside things that can be done. Of the assessment of the quadriceps muscle that's been said, it may be an easier tool to look at the muscle mass, especially in the patients admitted in ICU. Of course, now the focus is on BIA, which gives a reflection assessment, the body composition. This is not being done in public sector hospitals. I do not have much information about it. But then certain private sector hospitals are definitely focusing on BIA to look at the body composition and, of course, managing the patients in ICUs in a very stronger way. So the mortality, the literature is not very supporting that BIA can prognosticate mortality, but then nevertheless, there's a literature which speaks about this. Then the GLIM that I was speaking about, that's the Global Leadership Initiative in Malnutrition, has two-step approach towards the identification of malnutrition, which is like phenotypic criteria and etiologic criteria. The phenotypic criteria, non-volitional weight loss, low BMI, reduced muscle mass as assessed by the various tests that I have mentioned, and etiological criteria, reduced food intake or assimilation, and disease burden or degree of the inflammation. So this has been proposed by the GLIM as a two-step approach. At least one phenotypic and one etiological criteria should be there for us to diagnose the malnutrition. So after diagnosing, what are the nutritional therapies that we have? The goals I will not go into because of the shortage of the time. But then if the patient has got a functioning GI tract, then we focus on enteral nutrition. If there is any nutritional goals that are to be achieved, then continue monitoring. If there are nothing, I think we need to integrate the enteral nutrition with the parenteral nutrition. If the patient doesn't have a functioning GI tract, then go ahead with the parenteral nutrition. So how to assess daily energy requirements? This is assessed. The gold standard is the indirect calorimetry. This is not available in every hospital. But then what has been said is that this is a standard of assessment of the resting energy expenditure. This is how we are supposed to do. In fact, this is the machine which I got from the net, which is useful for the assessment of the resting energy expenditure. That's the indirect calorimetry, which is going to be the future, which is in fact being used quite commonly in the West. I'm not aware about the Indian subcontinent. The Aspen, most of my talk is taken from Aspen, but then the SCCM and the Aspen, what do they recommend? This is estimated, the energy that is to be given to the AK patients has been estimated to be around 25 to 30 kilocalories per kg per day. In fact, when you look at the energy requirements, they can be given based on the equations, which are not valid in AK patients. Based on estimation, this is a recommendation that is given. So the estimation that is being suggested by the societies of nutrition is 25 to 30 kilocalories per kg per day. This is the amount of energy estimated that should be given to the patients admitted in ICU. Protein requirements depends on whether he is on RRT, non-RRT. If he's not an RRT, 1.2 grams per kg per day. Little on the higher side, go up to 2 to 2.5 if the patients are on renal replacement therapy. What route we supposed to start? Enteral and parenteral nutrition. So early nutrition support is provided in less than 48 hours from hospital admission. Compared to later nutrition support, this should be performed in polymorbid medical inpatients. This term is again, which has been emphasized by SPEN, like our patients who are admitted in ICUs are all polymorbid. That means the morbidities are multiple in number. So we need to focus on these polymorbid clinic medical patients, and we need to look at the early initiation of the nutritional support. If oral intake is not possible, then initiate early enteral nutrition within 48 hours in critically ill adult patients. If oral intake is not possible, early EN shall be performed and initiated in critically ill adult patients rather than parenteral nutrition. These are all the guidelines that are given from ESPN, not my own statements or from the literature. So please, the reference of this talk is only ESPN. So what has been suggested, another entity by ESPN, is that hypocaloric nutrition. Hypocaloric nutrition is a nutrition where the nutrition is lower in the calories. In fact, in the first 3 days, it has been suggested that we should embark on hypocaloric nutrition, because if you go into hypercaloric nutrition, the patient may have a disadvantage of overfeeding, or if you go further less, patient may have underfeeding disadvantages. So we need to balance in the first 3 days, especially the patient should be focused on hypocaloric, and subsequently we need to calculate the energy and the protein requirements according to what I said earlier. When to use specific nutritional formulations? Generally, standard enteral nutrition formulations are appropriate, but when significant electrolyte abnormalities are evident, specific nutritional formulations should be used, which are incorporated with the significant electrolytes. And when we should go for EN and PN? EN, PN, or EN and PN shall be given to critically and non-critically ill hospitalized patients with AK and AKD unable to achieve at least 70% of the macronutrient requirements with the oral nutrition. Timing of PN, we will go by the risk scoring, low nutritional risk score and high nutritional risk score. I needn't tell about this to the nutritionist. Nutric score, if it is NRS score less than 3 or a Nutric score less than 5, it's enough. Energy storage is there during the acute phase illness, no need for parenteral nutrition. But then if the patient is having a high nutritional risk score as evidenced by Nutric score of more than 5, then please embark on early parenteral nutrition. When is PN indicated? This is what I just said just now. In the first 3 days, hypocaloric nutrition. If the patient is critically ill, from next 3 days on, if it's not possible for you to introduce enteral nutrition within 48 hours, embark on the parenteral nutrition. Is EN associated with better outcome compared to parenteral nutrition? The answer may be little compromise, but then the guidelines say that it is, answer is yes. As in other clinical settings, enteral nutrition is the most physiological route of feeding in comparison to PN, and in general has been linked to lower infection rates and shorter hospital stay. And is ESN enteral nutrition safe in hospitalized patients? The answer is yes. During CKRT, this is another entity which we come across. I'm not going to deal much about CKRT, but then
During CKRT, indirect calorimetry also needs to be performed, bearing in mind the intrinsic limitations of the method. A minimum of 2 interval needs to be given after an intermittent dialysis session is performed to improve the precision of measurement, provided IC is available for you to do in your hospital with respect to the assessment of nutrition in a critically ill patient who is on CRRT. So this is again according to the guidelines. So the nutritional risk score is low in the first week. Standard nutritional therapy of oral intake, general infusion containing glucose is suggested for critically ill patients with AKI. But if your nutrition score is high, go in for enteral nutrition or parenteral nutrition, which is suggested to be at the earliest initiation. So does early enteral nutrition reflect on mortality? The answer probably is yes. Nutrition KRT, I'm not going to deal with because it's a different topic on its own. There's much coming about the literature about CRRT and the nutrition with respect to the micronutrients, clearance, and the supply that needs to be given. A lot of literature is coming up off late. What is the future? Future is the personalized nutrition in ICU. So this is a patient who is sitting in ICU, all gadgets, smart objects which are there around him, starting from smart bed to artificial intelligence to ultrasound assessment of the body composition, muscle mass, computers information to monitor the tube feeding, metabolic cards. So many things are there which are in store for us, for especially the nutritionists when managing a patient with AKI. So this is how probably we may need to look into a better outcome of a patient who is critically ill admitted in with AKI in ICU. So take home from my 15-minute talk is patients with AKI are at high risk of protein energy wasting, attributing to morbidity and mortality. As of today, no definitive reliable markers are available, but then is a need of the hour for validated nutritional assessment markers to be made available in AKI. Good number of studies are yet to come. But more important is timely and appropriate initiation of whether oral alimentation or enteral nutrition or parenteral nutrition should be embarked upon by the practicing nephrologist too in association with the nutritionist. Thank you. Thank you so much.
Only one question, quick, because we are already late.
Thank you. I just want to make one point.
Yes, sir.
Regarding phosphorus.
Okay.
Because critically ill patients in ICU, they may develop hypophosphatemia. Hypophosphatemia anytime less than 1 milligram
Yes,
is
severe.
a medical emergency.
Correct.
Because P is necessary for all the pumps, NADP,
Yeah,
ADP,
all
everything.
cellular
So
metabolism.
this has to be taken into consideration by the nutritionist when looking at the patient who are critically ill in ICU.
Thank you, sir. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you, madam, for your very excellent talk.
And I salute the excellence on stage and request the organizers to felicitate our chairpersons and speaker madam down the stage towards the right. Thank you so much, sir. And with this, we enter our session number 9. And join me in giving a rousing welcome to our chairpersons. I invite on stage Dr. Mufazzal Ahmad, Senior Consultant Nephrologist from Lucknow. Dr. Archana Padoria, Consultant Nephrologist from Kanpur. Dr. Medhavi Gautam, Associate Professor Medicine, King George's Medical University, Lucknow. Dr. Alok Pandey, Consultant Nephrologist from Regency Hospital, Lucknow. And Dr. Amit Kumar, Consultant Nephrologist, Precision Hospital, Lucknow. And the stage is all set. And over to the chairpersons to introduce the topic and the speaker.
Now the next lecture is by Dr. Tarun Jalokha, who is a senior consultant and head department of nephrology, Manipal Hospital, Pune. Over to you, Tarun.
Respected chairs, let me start by thanking Professor Gupta and Narayan and other organizing committee members to have me here. My topic today is implications of metabolic syndrome in kidney diseases. So without wasting any time, so what I'll do is I'll start with a brief introduction of history, epidemiology, and definition of metabolic syndrome, so you get a better understanding of its implications on kidney diseases. And if time permits, I'll talk about a little bit of limitations of metabolic syndrome as a syndrome And there is an additional controversy which I don't want to dwell unless I'm forced to at the end of my talk about kidneys and metabolic syndrome. So history-wise, so it was Gerard Raven who in 1988, he basically is a diabetologist. So in 1988, while giving a lecture on Banting Memorial Lecture, hypothesized that central to or core to diabetes mellitus and ischemic heart disease is insulin resistance. And at that time, he did not had a particular name to this kind of a picture. He labeled it as a metabolic as a syndrome X. And this syndrome X continued for about a decade when people realized that yes, the core problem is insulin resistance, and they renamed it as insulin resistance syndrome. And henceforth, it has been named one after the other like deadly quartet. And right now, it is called as metabolic syndrome. So it has its implications predominantly on cardiovascular disease, strokes, and many other. And this is a slide which highlights the impact of metabolic syndrome in the body. So central to the metabolic syndrome is abdominal obesity, which along with presence of dyslipidemia, diabetes, and hypertension leads to a cascade of different events like inflammation, hyperuricemia, activation of sympathetic nervous system and tachycardia, polycystic ovarian syndrome, obstructive sleep apnea, heart failure with preserved ejection fraction, fatty liver disease, and our point of interest is impaired kidney function. So we'll highlight on the last part only. A slide on epidemiology, it has been shown that metabolic syndrome confers about 5-fold increase in risk of diabetes and about 2-fold increased risk of cardiovascular disease over 5 to 10 years. And its prevalence in adults is about 20 to 25%. And this thing has been highlighted in several meta-analyses as well. 3 of the meta-analyses showed that the risk of cardiovascular disease and all-cause mortality is pretty high in patients who have got metabolic syndrome. So coming to definition, when do you call a person having a metabolic syndrome? So different organizations at different period of time have defined it differently. To begin with, long back, WHO in 1998 thought that diabetes is core to metabolic syndrome. Later on, IDF in 2005 thought that obesity is the core picture of metabolic syndrome. And this kept on with the newest definition does not include core impact of any of these 5 features. It says 3 out of these 5, if present, can be labeled as metabolic syndrome. And the 5 features are diabetes, increased waist circumference, hypertension, high triglycerides, and low HDL cholesterol. So 3 out of 5, if present, qualify the person to have a metabolic syndrome. So from Indian perspective, let's see what is the prevalence and other features of metabolic syndrome in India. So this was a picture, this was a paper who looked after different studies from India. The point to highlight here is the prevalence of metabolic syndrome in India varies from 15 to 40%, which is a large sum. And the other picture, other important point which this paper shows is that in most of these Indian studies, it is female preponderance. So females are at more risk of metabolic syndrome as compared to males. This is another picture which looks at different countries about prevalence of metabolic syndrome. You see there are huge variability. So there is ethnic variability of metabolic syndrome as well. And many of these countries does show India-like picture that females have higher prevalence of metabolic syndrome, whereas European and American countries do not show this gender-based differences. This is again enhanced-based study which showed that as the age progresses, the incidence of prevalence of metabolic syndrome also increases. So, and this was the latest paper from last month actually, which looked at the Indian paper looked at adolescents from 10 to 19 years having metabolic syndrome, and they quoted that 3.4 to 5% prevalence of metabolic syndrome in adolescents from 10 to 19 years, which is a little worrisome for me. So coming to risk factors altogether, apart from age, gender, ethnicity, Enhance showed that post-menopausal status, smoking, low household income, high carb diet, and no physical activities are important risk factors of metabolic syndrome. And those who are booze favorites would love to see that no alcohol consumption is also a probably a factor of metabolic syndrome. Saying that, high alcohol consumption also results into these kind of dyslipidemia and other factors, which again will lead to metabolic syndrome. So both ways, no alcohol and high alcohol also. And Framingham Heart Study mentioned the soft drink and sugar sweetener beverages, antipsychotic medicines like clozapine, and poor cardiorespiratory fitness. So fitness is again a factor which determines the prevalence of metabolic syndrome. So after coming to the brief introduction about the risk factors, the epidemiology, and the definition of metabolic syndrome, let's dwell into implications on kidneys. So this was a 20-year-old paper from Jason, which looked into metabolic syndrome and its impact on kidneys, especially in non-diabetic adults. Why non-diabetic adults? Because you see, diabetes is a qualifying factor and it also results into diabetes, which I have highlighted. So they picked up non-diabetic adults specifically, and about 10,000 odd patients from Eric's study. They were followed for about 9 years. And what they found is 7% of these 10,000 patients developed chronic kidney disease. And in multivariate analysis, what they found is the incidence of CKD was higher in those who had metabolic analysis, about 43%. So those who had metabolic syndrome, the incidence of kidney disease or chronic kidney disease increased by about 43%, which is a significant increase as compared to those who did not had non-metabolic, no metabolic syndrome. And also notice that number of traits also determine the incidences of chronic kidney disease. So having one trait had a risk of 13%, and having all 5 traits were about 2.45 times higher risk of chronic kidney disease. And those who developed diabetes and hypertension during follow-up of 9 years, after excluding them, still the risk of CKD was about 24% higher in those who had metabolic syndrome. Further, the risk was independent of other confounding factors like age, gender, race, education, BMI, alcohol, etc. So what they concluded, the metabolic syndrome is independently associated with increased risk for incident chronic kidney disease. So we are looking at chronic kidney disease here, which is higher 20 years down the line. Again, when this review and update was published, it is no different. It still shows that CKD and microalbuminuria are higher in those who have metabolic syndrome. So it still holds true. So what by now I have showed is the incidence of CKD is high. But what about those who have CKD? Do they have higher incidence of metabolic syndrome? Yes, that also was shown in many papers. One of the papers from Thailand showed that the prevalence of metabolic syndrome was also higher, up to a tune of 70%, depending upon the stage of CKD. So it's bidirectional basically. What about the progression of CKD? So those who are already in stage 3 or stage 4, and if they have metabolic syndrome, a 2-year study showed that they progress to stage 5 with a tune of 33% higher risk. So incidence and prevalence increases. If you have already CKD, the progression also increases. And among the components of metabolic syndrome, it was seen that hyperlipidemia and elevated blood pressure are more likely to lead to progression of CKD to end-stage renal disease. Low HDL cholesterol increases the risk of death, and impaired glucose metabolism, important risk factor for end-stage renal disease and death both. So diabetes, hyperlipidemia, and elevated blood pressures we know are anyway risk factors for chronic kidney disease, and it confers more risk in metabolic syndrome patients. So a slide quickly on pathogenesis of metabolic syndrome. So we know the components: insulin resistance, that is diabetes, obesity, hypertension, and dyslipidemia. These all lead to increased sympathetic activity, reactive oxygen species. It leads to hemodynamic changes, increase in renin-angiotensin stimulation, and adipokines abnormality. And all together leads to several cytokine play into the body, and that leads to kidney injury. And when you do a biopsy, what you see pathologically, there is glomerulomegaly, podocytopathy, mesangial cell and matrix proliferation, glomerular basement membrane thickening, segmental and global sclerosis, IFTAs, and obviously vascular injuries as well. So all these pictures, they're not very specific for metabolic syndrome, but it shows that there is a chronicity in if you do a biopsy of these metabolic syndrome patients. Diagnosis of kidney involvement is not different than any other patient. So you do a EGFR and you do a urine albumin creatinine ratio, and that proves the involvement of kidneys in metabolic syndrome. But there are few biomarkers also which has been studied, which has been found to be higher in metabolic syndrome patients, both in blood and urine. Some of them are growth differentiation factor 11 and 15, and in Japanese study, urinary amegalin. So these are some biomarkers if you want to pick them early, but it is more of a research purposes. Coming to, I think did I miss a slide? Okay. So let's see the treatment part of metabolic syndrome. Unfortunately, there is no one single pill or injection or a treatment for metabolic syndrome. So basically, we are treating individual component, whatever is present in that particular individual. So if they have obesity, there are guidelines. You can use step 1 is GLP-1 receptor agonist. Then there are different naloxone and bupropion, orlistat. And then ultimately, if it's a morbid obesity, you can go for a metabolic surgery. Similarly, diabetes, you have metformin, GLP-1RA, and then sulfonylureas, SGLT2 inhibitors, etc. Then hypertension, you have to treat with ACRBs and or CCBs, and then go on to use aldosterone antagonist and beta blockers. Similarly, if there is dyslipidemia, interestingly, the guidelines mention about the LDL cholesterol, though the definition doesn't incorporate LDL-C. So that's why there are certain controversies. So, but LDL-C, if it is high, then you use statins, ezetimibe, and then fenofibrates if the triglycerides are very high. So, summarize the management part of metabolic syndrome related kidney injury, there has to be lifestyle interventions. Several talks since morning have focused on that. Weight loss, antihypertensive therapy. I have mentioned lipid adjustments, glucose control. There are certain Chinese herbal, I don't want to name them individually from the studies, but they are mentioned that they help in metabolic syndrome. Other treatments like probiotics, glycine, stem cell therapy are again in some studies not very objective and not very randomized, but have shown some role. And then cellular level and molecular level interventions for endoplasmic reticulum stress, oxidative stress, and all these have also been studied to take care of the metabolic syndrome and its implications on kidney diseases. So last couple of slides, I have time, and I'll mention about the controversy, will not dwell onto that. So ADA and European Society mentioned whether this metabolic syndrome should be called a syndrome or not. So what they say is the critical weakness of metabolic syndrome construct is the treatment of syndrome is no different than treatment for each of its components, which I have highlighted. So why to call it a syndrome if you have to treat it individually? Further down, what they say is there are no clarity of definition. As I have mentioned, there are different associations giving a different definitions. Very interesting is there are multiple different phenotypes. For example, if there is large waist circumference, high triglyceride and high fasting blood glucose versus another individual who has got high blood pressure, low HDL and high triglyceride will be treated differently. So different phenotypes. There is no evidence base for setting the thresholds of these components. Inclusion of patients like cardiovascular disease or diabetes, which are in definition as a result, and the result of metabolic syndrome again becomes controversy. There is unclear pathogenesis of the entire syndrome per se. Then inflammatory markers have not been incorporated, any of these, which are important markers of cardiovascular disease. Then there are certain other risk score factors like Framingham risk score. It doesn't help in adding any other interpretation as a metabolic syndrome. So this, if you do this risk score, it gives much better understanding than metabolic syndrome. So before I go to the summary slide, my last slide. So in kidneys, you must have heard about reverse epidemiology by Kalantar Zade. So this is a very controversial part. I deliberately left out because of the time constraint. In kidneys, it has been shown that obesity may be a better, good prognostic marker. That is part of the metabolic syndrome. Similarly, in certain studies, high blood pressure in dialysis patients to a certain limit is again a good prognostic marker. These are certain controversies which is very important. Some of you can go and dwell onto that. So to summarize my talk, metabolic syndrome has bidirectional relationship with kidney disease. It definitely, there are evidence that it leads to progression of kidney disease and high prevalence. Early identification and appropriate treatment of individual components is warranted, and its significance over and above identification of components is again debated. So thank you again for the opportunity, and thank you for patient hearing. Thank you.
Dr. Singer.
Tarun, you have spoken very, very nicely.
Thank you, sir.
What is the role of, I just want to make comment, what is the role of yoga? You know, this is my observation. Those who are doing yoga regularly in our country, you see from Modi ji to Yogi ji and at a village level, nobody is having metabolic syndrome. Is there any comment?
So I have highlighted briefly about physical fitness or lifestyle modification. It's part of that. Whether you do yoga or you do run or you do a different kind of exercise, fitness is very important, which will take care of many things. The obesity part, which is component of metabolic syndrome, the sugar control or diabetes, the hypertension, all these are part of lifestyle modification. I definitely agree with you that that also will have impact on metabolic syndrome and hence to kidney disease as well. Thank you.
Thanks for the wonderful talk, sir. And we are honoring your inspirational presence with a token of appreciation. Thank you so much. Over to the chair.
So now I invite Dr. A.K. Bhalla for his next talk on Does Malnutrition Set Early in DKD? Unwinding the Myths. Dr. Bhalla is Senior Consultant Nephrology at Sir Ganga Ram Hospital, awarded Padam Shri by Government of India in 2010, former President ISN, and awarded Dr. B.C. Roy National Award in 2019.
Thank you, chairpersons, for kind introduction. And I thank the organizers for giving me the opportunity to deliver this talk. As we all know, diabetic kidney disease is the leading cause of end-stage renal disease. 45% of patients on dialysis are diabetics, and 15 to 23% of diabetics have moderate to severe CKD. Moderate to severe CKD is estimated to be found in 15 to 23% patients with diabetes, and malnutrition and associated comorbid conditions are among the several factors that affect the survival of these patients. Already prevalence has been mentioned by Dr. Georgie also, as we go from stage 1 to stage 5, ranging from 18-20% to as high as 75%. And there's one study done by Dr. Narayan Prasad, published in Journal of Renal Nutrition in 2008, where they analyzed 283 ESRD patients and 81.3% in diabetic patients, whereas 62% in non-diabetic patients was the incidence of PE, protein energy wasting at the initiation of dialysis. Now, what are the various causes of malnutrition in diabetic kidney disease specifically? Decreased nutrient intake, uremic symptoms, concurrent illnesses, infections, heavy proteinuria, and it can go to as high as beyond 10 gram. Diabetic gastroparesis because of autonomic neuropathy, and of course, gut dysbiosis. Already we know that it is a very important factor for malnutrition. Pancreatic insufficiency and comorbid conditions in diabetes. What is the impact of malnutrition on survival? This study published by Chen et al. From China, they found that diabetes were more malnourished as compared to non-diabetes, 54% versus 34%. And as far as survival difference was concerned, there was a 40% increase in annual mortality in diabetes as compared to non-diabetes. Number of hospitalizations were more in diabetes. And this shows that there was a clear-cut difference between when patient had diabetes versus when they were not diabetic. There was so much difference in the survival of these patients. What are the usual comorbidities we see in diabetic kidney disease? Combination of, once we have cardiovascular disease and chronic kidney disease, the risk, if we had a combination of diabetes and CKD, it increases the cardiovascular risk by 20 to 40 times, which is very high. Then excess adiposity, hypertension, dyslipidemia, tobacco use further aggravates. And as most of this population is usually beyond 40 or 50 years, so increasing age itself has its complications. Higher proteinuria leads to higher prevalence of cardiovascular disease in chronic kidney disease. And the impact of comorbidities on survival. So once we have comorbidities like coronary artery disease, cardiovascular disease, peripheral vascular disease, congestive heart failure, malignancies, cardiac arrhythmias, chronic lung disease, chronic liver disease. So all this leads on to it has impact on survival. So when we have low risk means one comorbidity or no comorbidity, more than 2 and more than 3. So there is a clear-cut relationship. As we go higher number of comorbidities, the risk increases. Now coming to protein intake, it has been mentioned that in diabetic kidney disease, we must have minimum of 0.8 to 0.1 to 1 gram per kg in early stages of CKD, at least stage 1 and 2, and beyond that, we should not decrease to less than 0.8 gram per kg per day. So it is very important that we mostly generalize the management of CKD as far as protein restriction is concerned. In diabetes, we should be particular that protein intake should not be reduced to less than 0.8 gram per kg per day. And gut disc biopsies, of course, already has been discussed in detail that it has its impact on because these toxic metabolites produced by the gut microbes rapidly increasing the rate of renal deterioration. Another study from China which showed that with patient, they divided studies, the patient both diabetes as well as without diabetes, and they found that there was a difference in the prevalence of malnutrition. There was a gross difference between the two groups. Again, the malnutrition is associated with rapid progression of chronic kidney disease. Fast CKD progression was observed to be more common in malnourished patients, and various pro-inflammatory cytokines like interleukin 6, interleukin 8, and TNF alpha, they are pivotal to the inflammation and are associated with malnutrition and atherosclerosis in chronic kidney disease. There is strong association of malnutrition, inflammation, atherosclerosis, and it suggests the presence of a syndrome which is known as MIA syndrome, often associated with an exceptionally high mortality rates. Now, coming to nutritional management, when we have to plan nutritional management of these patients with diabetes with CKD, dynamic assessment of the nutritional status and timely intervention, that helps in delaying the progression of chronic kidney disease. It is better to develop a personalized diet plan for each patient under the guidance of a nephrology nutritionist. Effective use of high quality, low protein diet can play a significant role in the control of blood glucose levels in patients with diabetic nephropathy so as to effectively control the progression. Here lies the role of healthcare professionals, and we have to have already it has been highlighted since yesterday that multidisciplinary approach has to be there, where a renal dietitian should be involved in the management of the patient and also proper diabetic management. And we have to have certain preventive strategies like comprehensive management, lifestyle intervention, risk management, in the form of blood sugar control, blood pressure control, lipid control, and balanced diet and increased physical activity. I already has been highlighted in yesterday's lectures also. This was a study, a very important study published by Malnutrition and Comorbidities by Dr. Narayan Prasad, and widely quoted study. So it also shows that there is a clear-cut role of there is a clear-cut impact of diabetes as well as malnutrition is concerned. So there is malnutrition does occur in diabetic kidney disease and requires early intervention. So to conclude, comorbidities and malnutrition are prevalent in diabetic kidney disease patients. Both factors affect the survival of these patients. The multidisciplinary approach, including renal, dietitian, and diabetic management, may help in combating malnutrition. Our main stress should be on early detection, intervention, and prevention of malnutrition and associated comorbidities also in diabetic kidney disease for improving the clinical outcomes. So we have to have involvement of renal nutritionists at the early stages so that we don't allow these patients to go into malnutrition. Because if it already has been suggested by previous speakers, that if we don't interfere early, in early stages, then in later stages, we may not be able to help these patients. Thank you.
We have some time left. I'd like to just comment, sir, that like when the patient becomes a CKD patient, prior to that he's a diabetic patient. So already once a patient comes to know that he's suffering from diabetes, he gets so desperate that he follows any diet plan just to avoid insulin or medicines. So he tries to control his diabetes with modifying his diet. So the role of general physicians come there before our role is there to prevent malnutrition and counsel them for proper management of their blood sugars before kidney failure sets in.
In fact, that is very important that this actually, whatever our stress has to be at the physician level, primary care physicians, medical specialists, because by the time the patients are coming to us, they are already most of the time beyond stage 3.
Sir, another small question, sir. In few patients, like even if they are in a stage of CKD 3 and CKD 4 and having diabetic nephropathy with massive proteinuria, in this type of patient, many a time it come across that they are having malnutrition, anasarca, and very difficult to manage. And you told that the protein intake should be less than
Should not be less than 0.8 gram.
So how to deal with these patients if we are giving the large amount of protein? That's also a risk factor for progression of the disease. And on other hand, we can't directly shift the patient on the dialysis because of the stage is not as advanced. So how to deal with such type of patients?
You have to create a balance. We all know that whether you give them 0.8 gram protein or 1 gram per kg protein, it is not going to matter much as far as the progression of CKD is concerned. But at that stage, if you allow the patient to go into malnutrition, especially severe malnutrition, that will have lead on to much more complications. So, in fact, the main message from my talk is that we have to stress that in diabetic kidney disease patients should not go beyond lower than 0.8 gram per kg body weight of protein, because that will risk these patients to more complications.
So we can
And
increase as much as possible as
yes,
required.
yes, and progression, we all know that it is not that this is the only factor which is going to slow down the progression of CKD. We have now so many other drugs apart from ARBs, ACE inhibitors, SGA2 inhibitors, MRAs. So all those drugs actually can give that benefit, whatever benefit we were getting by reducing the protein intake from MRD study level, where we were decreasing the protein intake to 0.6 gram per kg weight, and we were getting these benefits. All these benefits now can provide to the patient with the use of all these armamentarium we have with you. So that is very important. It is not the protein restriction only which is going to help.
And even if condition is not manageable because of management of all this, so is there any concept of medical nephrectomy sometime being? Okay, sir. Thank you.
Thank you.
Thank you, sir, for a wonderful lecture. And if there are no questions from the audience, we can close this session.
And I thank the chairpersons and request them to please come to the right of the stage for the felicitation. Thank you. Now we have entered into our next presentation, and that is to be chaired by, and I am grateful and delighted to welcome the chairpersons on stage, Dr. Mahendra Narayan Singh, consultant nephrologist from Varanasi, Dr. Rishi Kishore, consultant nephrologist from Patna, Dr. Johnny Agrawal, consultant nephrologist, Apollo Medics, Lucknow, Dr. Rajesh Jaiswal, consultant nephrologist from Lucknow, Ms. Diksha Patel, senior nutritionist, Chandan Hospital, Lucknow. Please welcome them with a big round of applause. As I'm announcing again, many of the speakers are having their flights, so I request you all to please adhere to the time. So we are all set, and I request the chairpersons to introduce the speaker and the topic. Thank you.
The topic for the discussion is nutritional goal in the diabetic kidney disease, evidence versus practice. And for this topic, we would like to invite Dr. Ratan Jha sir. He is a senior consultant nephrology in the Care Hospital, Hyderabad. And he has a publication of the more than 75 research paper, and he has a more than 30 years experience. So over to sir.
Good morning to all of you. At the outset, I will thank the organizers for choosing me to be a speaker. I have fond memories of this institution. I was in the second batch of DM nephrology training, and my teachers are there in the audience. The topic that has been given to me is nutritional goals in diabetic kidney disease. What is the evidence? What is the practice? It's a practical point. We are going to make a simplified presentation so that people in the audience get benefited. When we see a patient, we find that at every kind of interaction, at the end, people will definitely ask, what can I eat? What should I avoid, doctor? And it's not only the patient, the attendants, changing attendants at every visit. They want some kind of magical drug, the diet prescription for them to have a kidney disease progression retardation. And hence the point to discuss. We know that nutrition as a therapy is so important, but it gets often ignored in a busy clinical practice of ours, and it is substituted mostly by fixed diet chart in our day-to-day practice. The non-monitored intake of calories, protein, sodium and phosphate is known to hasten the metabolic alteration in chronic kidney disease and its progression, and hence the point to look at it. Dietitians, particularly in-centered dietitians, or the online consultation, which have now become a kind of way to handle this problem, can bridge the gap for a busy clinician. The link between diet and kidney disease is shown in the slide. That kidney plays a very important role in nutritional homeostasis, ranging from regulation of sodium, potassium, phosphate levels to metabolism of amino acid and glucose, which is practically disrupted as the kidney disease worsens. CKD patients are at increased spectrum of nutritional disorders that we discussed in the whole 1.5 days. It encompasses undernutrition, protein energy wasting, sarcopenia, and electrolyte disturbance. Dietary factors, therefore, have both a cause and consequence effect in the progression of kidney disease and its complication. They are changing goalposts in diet with the fall of GFR. That in a patient who has only a CKD risk factor like hypertension, obesity, diabetes, we at that point of time maybe a general kind of care of in the diet management, like doing exercise, reducing the kind of calorie intake in an obese patient may suffice. But as the kidney disease progresses from early kidney disease to a kind of mid-range kidney failure to advanced kidney failure, the change in the dietary prescription changes from the protein restriction to the salt restriction and phosphate restriction. Hence, dietary prescription will not be same in all stages of kidney disease. The nutritional guidelines in the CKD summarizes the point that what are the things that we tell the patient. The dietary protein intake should be roughly in the range of 6.6 to 8 grams. That has been discussed. Calories should be important. The calorie intake should not get reduced because that will ultimately be counterproductive, 30 to 35 kilocalorie, unless the person is obese. Fat should be around 30% of total energy, with 1/3 distributed from monounsaturated, polyunsaturated, and saturated, with less than 7% trans fat. Fibers are the important component. About 30 grams of the fibers are required. Sodium has to be restricted. Potassium intake has to be guided by serum potassium, but in early stage it could be liberal. Phosphorus intake in the late stage should not be more than 0.8 to 1 gram. So simplistically speaking, when we talk about the protein, fat, and carbohydrate as a proportion of calorie intake chronic kidney disease, the amount of protein that we advocate in late stage is 0.8 gram. That roughly translates to 10% of calories. Amount of carbohydrate varies from 50 to 60%. It is said that less than 10% should be monosaccharide like simple sugar. And if person is having high triglyceride, that maybe carbohydrate has to go to 50%. The choice of high fiber, fruits, vegetable, complex carbohydrates should be a part of this carbohydrate component. Amount of fat should be always around below 30%, with 1/3 coming from each component. Less than 7% should be saturated fat with trans fat. And energy should always be focused, that should not be less than 30 to 35 calories unless person is obese. But those are the basically principles of drug dietary prescription, but there are existing evidences and gaps in the knowledge in the dietary management of diabetic kidney disease, which is shown that dietary protein intake, carbohydrate intake, other nutrients, the DASH diet, Mediterranean diet, all are already been discussed, but there are certain areas which are still not clear, and that is going to be discussed in the subsequent slide. Indians in general, as has been reported, eat more carbohydrates and less protein as for the publication. That it is the phenomenon which is not only seen in the rural areas, but in the urban areas. And the protein consumption is, though it is recommended around 15%, it is roughly around 10% in both rural and urban areas in health. And in kidney disease, as was discussed, hardly we take protein. It's just close to 0.6 gram per kg. And hence, protein restriction may not be an important concept, though that is the basic foundation of drug prescription. So in an Indian scenario, India protein intake is already low. Avoiding common items, which is the common kind of thought process in patients who consult a lot of people, that restricting dal, lentils will lead to protein energy wasting, which is quite common. Individualized diet therapy, therefore, is the way to go forward. Before we advocate protein energy wasting, we need to look at the ABCD criteria, which were discussed in our previous speakers, that there should be no protein energy wasting before a protein restriction is advocated based on the biochemical factors, weight loss, muscle mass, and low protein intake. That is a dietary kind of this advice has to be given after proper kind of assessment. The concept of protein restriction is shown in the slide, that it is believed to decrease the load on remaining nephrons, improves insulin resistance, reduces phosphorus, ameliorates proteinuria, reduces serum parathyroid, has an additive effect on RAS, and decreased likelihood of patient death because of less requirement of dialysis, and improving lipid profile. So these are the basic concepts for which the protein is to be restricted. And this is a very important slide for we have to understand that as the kidney suffers with the loss of glomerular filter from say 6 filters shown in the slide to 2 filters to 1 filter, filters keeps on getting hypertrophied, and that is it suffers from hyperfiltration injury. And one of the ways to reduce the hyperfiltration injury is to reduce protein, which ultimately leads to increased kind of glomerular hyperfiltration as the CKD progresses. So this is a conceptual slide that what happens when we are giving a low protein diet or vegetarian diet, that it reduces the interglomerular pressure, which is going to be useful in the long term. So the protein restriction is the concept, and it has shifted its focus from the animal protein, which is considered to be a first class protein, to a plant based protein, a plado diet, which we advocate in our day-to-day practice. Sodium has to be restricted. We know that sodium in higher amount is detrimental for hypertension and volume overload. And the concept of reducing the sodium to less than 2 gram is valid for people who are having high blood pressure with volume overload or proteinuria. In absence of that, in a patient who has a kind of diabetes with non-diabetic kidney disease like CIN, the protein, the sodium can be as liberal as 3 grams to 5 grams. And it has been shown that only this type of concept will be applicable to all the patients. Higher amount of sodium restriction in a kind of patient who is sodium losing patient will be detrimental, as in CIN patient. Potassium has to be always focused. It is said that we require roughly 1 milligram per kg of potassium. Potassium-rich diets are associated with lower incidence of chronic kidney disease, but this is usually applicable in people who are having a preserved kind of kidney dysfunction in stage 1 and 2, and in late stage of kidney disease, higher amount of potassium is probably detrimental. And hence, the general consensus from the observational studies is that high potassium intake should be allowed in stage 1 to 2 kidney disease because it retards the progression, but beyond stage 3, high potassium intake is associated with more rapid progression and the risk of death. Hence, no potassium restriction in early stage, and in late stage when the GFR is below 60, we need to look at the serum potassium to decide what to do. Coming to the phosphorus, the other component of iron, the high phosphorus levels are associated with cardiovascular outcome and decreasing bone density because of various complex mechanisms. And it has been shown that in a late stage of kidney disease, a patient who has higher by 1 milligram per deciliter of potassium from the level recommended, there is a higher risk of death. The food that we consume is always having a kind of potassium along with protein, and there are certain foods which are having higher amount of this protein compared to phosphorus, while certain foods are having a kind of lower amount of protein with increased phosphorus. So what we see in the slide is that the plant-based protein are having higher amount of the phosphorus compared to protein, but this phosphorus is not getting absorbed because of the lack of phytates in our intestine, and hence it is said that rice will have a high phosphorus, but it will not be absorbed to that extent. Chicken, which has got both high protein and high phosphorus, and fish will have a almost 100% phosphorus which is absorbed. These phosphorus which are coming from the plant or from the animals has to be always therefore factored for protein as well as phosphorus. Phosphorus additives are present in the fast food. That's shown in the various forms of additive which are available, which makes it tastier, but it has to be avoided. And that is a simple thing that we tell the patient that avoid fast food if you are going out. One common kind of misconception that eating more water is probably good for kidneys. People always ask whether we can take more water to improve the kidney health. But what has been shown in different kind of reports that water intake and the risk of kidney disease, if we go beyond 1.5 to 2 liters of fluid, there is no benefit. If you reduce the fluid intake below 1, or if you increase in fluid above 3, there could be a detrimental effect. So hence we recommend our patients to take 1 to 2 liters of water if they are not having edema. If they're having edema or fluid overload, we restrict the fluid to 1 liter. So ultimately, what are we talking about? We are talking about that diet should be not a fixed diet; it should be a pattern. Individual nutrient restriction is important in theory, but doesn't translate in good medical practice. People often consume mixed diets, so it makes more sense to give a dietary pattern that rather than giving a fixed diet chart. Plant-based diets have been found to have an ideal kind of combination of low protein diet with added benefit of low bioavailability of phosphorus, and that's is recommended. These are the different types of plant-based diet which is reported in literature, that it could be totally a plant-based whole food, DASH diet, Plado diet, vegan diet, Mediterranean diet, flexitarian diet, and vegetarian diet. So all these patterns can be given as per the patient's requirement and patient's need and patient's wish, that whether he wants to take some amount of non-veg with a vegetarian diet. The benefits of vegetarian diet and plant diet is shown in the slide, that there's differing kind of amino acid profile which benefits the RAS system. It tries to to reduce the RAS activity. It has higher fiber content, increases bowel motility because of more fibers, and thereby reduce the risk of hyperkalemia, lowers cholesterol. It alters the gut microbiome to a favorable side, and alters a kind of anti-inflammatory property. The plant diet also has a better kind of MUFA to PUFA ratio. It is richer in anions than cations. That is, it is more in having citrate and malate, which is better kind of anion for metabolic acidosis. Plants are generally low in sodium, rich in phytochemicals and vitamins, and phosphorus in the plant foods are present as phytates, hence not easily absorbed. People may think in in Hyderabad kind of population that probably non-veg is the only way to take protein, but there are many kinds of protein which are available, which are in a vegetarian item, which can give the enough amount of protein without producing malnutrition, and that is how we show the slides to the patient to say that vegetarian diet also contains good amount of protein. So what is preferred in the diet is shown in the slide, that we need to have a balanced diet which contains fruits in the early stage, non-starchy vegetables, whole grains, legumes, and 2 to 3 servings of nuts and seeds. But things which you need to exclude in late stage are fruit juices, highly processed foods for reducing for the phosphorus, meat to a good extent, and occasional dairy supplementation. So what do we follow ultimately? We try to follow the low protein diet, which are predominantly plant based with sodium restriction, high fiber, and a kind of repeated review to see that patient is not going into a kind of energy wasting. So this is a slide taken from American Journal of Kidney Disease that says that when we are not having kind of nutritional support in the form of dietitian, we can give a kind of the pattern diet what we talked about. But we need to look at the individual component to whether it need to change. Like person who has hyperkalemia in the with the dietary therapy, we try to first of all see why a patient has developed hyperkalemia before we tell them boil everything and take the vegetables that way, because that will make the food much more unpalatable. So what ultimately we do, we ask them to become a preferable vegetarian in case they are a heavy non-vegetarian. We ask them to take more vegetables. No restriction for dal and essential, and we try to give essential amount supplementation. Avoid fast food. Stop added salt, chutney, papad. One fruit like apple is given for most of the patient for mental satisfaction because they want to take one fruit a day. Fluids 1 to 2 liters. Dietary advice in case dietitian available online or in center. And we do not try to interfere too much in the diet because it leads to protein energy wasting and produces a poor quality of life. So take home is that protein restriction is good in appropriate patient. Daily sodium intake should be less than 2 gram. Potassium rich foods are good in the early stages of CKD till stage 3. Phosphorus intake has to be reduced in the stage 5 disease and beyond. Diet of diabetic nephropathy therefore is challenging because of associated hypertension, hyperlipidemia, uremia, gout, and obesity, and it has to be individualized. The other concept that we use is that we should give enough calories. You look at the calories. A new term has come, the hydroxymethyl butyrate, which is said to be a kind of good kind of supplementation for sarcopenia. I have never used it, but it's available. Essential amino acid and keto acid, we give it for patients who are malnourished. Exercise is always advocated at least 30 minutes a day, 5 days a week. Anabolic supplements and appetite stimulants to take care of the dietary aspect. And mental rehabilitation, that people think that they are depressed because of the kidney disease and that interferes with the diet, and it has to be therefore a dietary prescription has to be holistic approach. It cannot be a fixed diet chart, and we need to take help of the dietitian online or in center to get to the goal. Thank you.
Thank you, sir, for quite a illustrated talk in short duration of time. Sir, I will like to know one thing personally, that during the early stages of CKD, we are using many such drugs which are prone to cause hyperkalemia, such as ACE, ARB, Finrenone. And during that period, if we are not restricting potassium, or in fact, one word you said, ki high potassium. If we are going to give that, then definitely all of the patients are going to land in hyperkalemia, as most of the Indians are habitual in taking high potassium in some other form.
So that is a kind of a theoretical concern, but it has been found in early stage of chronic kidney disease, restricting the potassium below 1 milligram per kg may not be advisable, because it has got many kinds of benefits, and most of the patients who are getting ACE, ARB, Finrenone are also on diuretics. So we have to see that if the person is getting into hyperkalemic zone, then maybe we may have to restrict it. But many of them will not get into that hyperkalemic zone. So the benefit of potassium restriction is in early stage, but in late stages, definitely potassium has to be restricted. So this is the kind of recommendation which has come from the guidelines.
Thank you, sir.
Thank you.
So if due to lack of time, if there are no questions, we can end the session here.
Thank you. Thank you.
Thank you, Speaker Sir and Chairpersons for being here with us. And now I request Chairpersons to please move down the stage towards the right and let us felicitate you. And with this, we enter our session 10, that is the panel discussion. And for the panel discussion, I am deeply honored to invite the moderators on stage. Professor Dr. Amit Gupta, Senior Consultant Nephrologist, Apollo Medics, Lucknow, former Professor and Head SGPGIMS, Lucknow, and Dr. Avilash Chandra, Additional Professor and Head, Department of Nephrology, Ram Manohar Lohia Institute of Medical Sciences. And as the panelist, I am inviting on stage Dr. Nareen Sengar, Dr. Arvind Gupta, Dr. Devasi Saha, Dr. Pritpal Singh, and Dr. Shashi Kumar.
So good morning, good afternoon to all of you. And we have an eminent list of nephrologists who will be participating in this panel discussion. And Dr. Abhilash Chandra, my co-chairperson, is going to present a case and conduct the entire session.
Chair. Good afternoon, everybody. We'll be going through a case before we move on to the set of questions we are going to put forward to our panelists. This is a 26-year-old male, a resident of Lucknow itself, and he has been on dialysis since December 22. And during his presentation, he was biopsied and was found to have IgA nephropathy in the biopsy. He has hypertension as well, with grade 2 hypertensive retinopathy. There is no residual urine output left after a year of dialysis. His usual interdialytic weight gain has been around 3 to 3.5 kgs. This was his first admission in December 22 when he had presented with anorexia and nausea for 3 months with vomitings and all. Biopsied, 3-unit blood, but also transfused. And there was a second admission in February 23 for catheter-related bloodstream infection, and he was managed with antibiotics. This was his examination. 140/90 was his blood pressure. He is an average built person, and he has some degree of pallor. There is no edema, no facial puffiness, and has an active left cephalic fistula through which he is being dialyzed. His rest of the systemic examination is normal, respiratory, cardiovascular, abdominal, and is very well alert. So at this juncture, we see that he's a case of dialysis. He's on dialysis, CKD5D, and hypertensive, as well as he's anemic. So coming to the questions, the first question that comes to our mind is, how common is anemia in dialysis population, and what are its various causes? The question is for Professor Sengar, sir.
Hello. Yeah, anemia is very common, when all CKD, we go through the various stages of CKD, starts from CKD stage 1, 8% to 54% is stage 5, and to reach to the tune of 80 to 85% is when the patient comes to dialysis. And the common causes of anemia in the dialysis patient, obviously, when the patient reaches the CKD stage, the erythropoietin deficiency, because most of the body erythropoietin comes from the kidney, 80% comes from the kidneys. The kidney are damaged, patient or dialysis dependent. So erythropoietin deficiency, another, the dialysis itself is inflammatory thing, CKD is inflammatory thing, inflammation and infections. This patient has sepsis. So sepsis, inflammation, infection, erythropoietin deficiency, blood loss from occult blood loss, maybe from the stool, and the rare cause may be because of the hemolysis, or maybe because of disordered iron metabolism. These are the common causes.
Thank you, sir. Among all the causes you have enumerated, one of the common causes of anemia in this population is nutritional. So the question is, how does poor nutrition status contributes to anemia in this population? Gupta sir, for your kind comments.
The other See, what you mentioned was absolutely right, that you look for erythropoietin deficiency, iron deficiency, infections. Uh, Nutrition is important, and particularly you should look for B12 and folic acid deficiency in addition, because sometimes these are deficient. In addition, before you start erythropoietin, very often we jump to start erythropoietin, but I think we need to make sure that the patient is iron replete. That's most important, because erythropoietin is an expensive medication, and so we must make sure that the patient is iron replete, and if there is a deficiency, then replace with intravenous iron if required. If you have ruled out all these causes, then maybe you should also see for any evidence of parathyroid hyperparathyroidism, which can be one of the lesser common causes, but it is an important cause for patients who are not responding to your usual therapy.
How does poor nutrition status contributes to anemia?
See, generally, if a patient is malnourished, that is going to cause some degree of anemia. And if particularly a patient who is on dialysis, you have to make sure that the protein intake, this is a very difficult and challenging problem, because the patients are usually reluctant to start taking higher amounts of protein. And so, but we have to make sure that they take the right amount of protein, the quantity that we think is desirable, and fortify it with vitamins as well as the minerals that you require.
So, what are the various ways of addressing this problem of nutrition anemia, Sir? Can you throw some light on this question?
We actually, in any patient of chronic kidney disease, we should not directly jump on to the EPO based anemia, or so solely because of the EPO deficiency. We need to consider anemia as a holistically, like the patient coming from various stages of this. Once the patient reaches to ESRD, the patient, large population of the patients are malnourished. Now we need to look into, as Dr. Amit Gupta said, whether the patient is iron depleted or not. Patient has a vitamin B deficiency, adequacy is not there, because correction of anemia will require a cell division, cell proliferation, cell division, accumulation or integration of iron into a heme molecule, and a generation of a globulin molecule. It needs both protein, cellular genesis, cellular division, which needs B12, vitamin B12 and folates, and assimilation of iron into the globulin molecule, heme molecule and the globulin molecule. So we need to have everything with us. Now, apart from all these things, a chronic anemia needs also be looked into it because of the iron deficiency. Very often, the fat soluble vitamins are also deficient, like particularly vitamin A deficiency, which we do not give it very regularly. But it has been seen a low level of vitamin A is associated with raised level of hepcidin in the gut. That actually interferes with the iron absorption. That has to be seen again. So overall, iodine supplementation in a patient with hypothyroid, correction of the fat soluble vitamin, and looking into the other micronutrients which are very essential for the red cell proliferation, to division, to proliferation, to maturation,
and the accumulation and assimilation of iron into globulin molecule.
Do they require deworming?
And yes, definitely. There is a social factor where it's very important. The category, many of the patients do get seasonal infections like malarial infection. Deworming is very important aspect of the correction of the anemia, and various other tropical illness has been also seen. Uh, we treat the patient of chronic malaria with primaquine therapy. So we need to screen the patient before giving primaquine that they should not be deficient or G6PD deficiencies there. So these are the small steps that needs to be seen to avoid unnecessary hemolysis in the patient also.
One point I would like to support the what has been said by Dr. Saha. Actually, from nutritional support point of view, we have very limited option for vegetarians. So we have to supplement with tablets, iron, different formulations are there, and intravenous iron, depending upon the iron status of the body, serum ferritin level. Although these all markers are not very specific for iron deficiency, but when patient is on dialysis and patient is receiving on CAPD, so we have to have the iron profile estimation, and then we have to go first for uh, iron replete patient and the vitamin B12, folic acid, and other. We have to be take care of that. Unless we do it, erythropoietin will not going to be of any help. And vis-a-vis, I want to also to emphasize that it is a disease-related malnutrition, because CKD and dialysis patients are the hyperinflammatory state, and whenever these hyperinflammatory states are there, uh, then there is a, as Dr. Saha said, this hepcidin pathway is very important, because every hyperinflammatory state is leading to the increase in hepcidin secretion, and in hepcidin secretion they reduce the iron absorption from gut, they reduce the uh, erythropoiesis, they reduce the erythropoietin secretion, they reduce the erythropoiesis in bone marrow, and vis-a-vis this hepcidin causes the accumulation of iron, running iron into the macrophages, and these macrophages when activated they again force the hepcidin secretion.
So after a good discussion on anemia management in CKD5D population, we moved to the next part of our discussion. Is on the nutrition status. We have this patient of.
I would like to make a comment.
Yes.
Tell it, yes, but there you may also have to look at the clinical scale. The polypharmacy may induce 2% hemolytic anemia in dialysis patient. So please look at that, the withdrawal experience we had earlier on. So also, while looking at other causes, please look at whether there is a 2% hemolytic anemia, and for that the patient will got to.
Yes, sir. Thank you, sir. Thanks for the comment, sir. This patient had a low body weight of 52 kg, height was 172 centimeter with a BMI of 17.6. He was calorie deficient, deficit of around 270 kilocalories per day, and he was also having a deficiency of protein intake of around 12.4 gram. Coming to the investigations, we see that he has been anemic over the last 1 year, and his potassium has also been found to be a little high on 2 occasions. Albumin has gone down to 3.17 in the last report of December 23. Phosphorus has been a little on the higher side. Either it has been on the high normal side or has shooted beyond the normal range. SLP has been a little on the higher side. PTH is again a little high, 229, somewhere between 200 to 300, and he has been iron deficient. So he has anemia, he has mineral bone disease, which are being currently managed. So the question is, he has mineral bone disease as is evident from the investigations. So what is the prevalence of mineral bone disease, and how do you diagnose it in this population? Dr. Prithpal, can you just?
Thank you. So, mineral bone disease is prevalent in almost 20 to 60% of cases in Indian studies, and in specifically 5D, CKD 5D, this is almost 40 to 60%. So CKD 5 and 5D both have almost same prevalence. And to diagnose, definitely, as you showed in the chart, initial diagnosis depends on biochemical parameters, calcium, phosphate, parathyroid hormone, vitamin D, etc. And apart from this, to diagnose further, to see high turnover, low turnover, we will have to go for a bone biopsy, which is not usually not routinely done because this is an invasive procedure. To supplement this, we can go for DEXA and sometimes BIA. Sir.
Thanks for the comments. And the next question which comes to our mind is there a role of dietary modification in mineral bone disease in this dialysis population? Dr. Shashi, can you throw some light on this
It's a
question?
very practical question. And as Dr. Pritpal has mentioned, the incidence of CKD-MVD is quite high in our patients. And as the CKD stage is progressing, the incidence prevalence is also increasing. And I must say, this is the one field, this CKD management, your non-pharmacological practices is more important than your pharmacological practice. Because most of the times, what we prescribe to our patient is mostly act on your dietary phosphorus and absorption. So dietary intervention is very important, and we must know which foods are high in phosphorus content and which foods are low or are normal in phosphorus content, because almost all foods contains phosphorus. So what are the foods which are high in phosphorus? It's mainly poultry products, dairy products, processed foods, because most of these preservatives which we are using in our foods are high in phosphorus. And cola drinks, this is the again a very high resource of phosphorus. So we need to avoid or curtail these foods in our patients. And those patients who are low in phosphorus, especially the cereals and rice bran, we can use in our patients. So dietary intervention is very important for this CKD-MVD.
But can I just, so Shashi, in this situation, because patient on dialysis, his albumin levels are going down. His albumin is down to 3.17, and he's obviously malnourished to some extent. So if you cut down on products which are so-called rich in protein, what do we have? Because we want to give vegetarian protein, so you're saying that, but amongst vegetarian, you're saying milk products are, dairy products are high in phosphorus. So how would you solve this problem?
Yes, it's a very practical problem we face in our day-to-day practice. So that's why here comes the role of your plant-based proteins. So when we compare your animal-based protein versus plant-based proteins, the protein and phosphorus contains and their ratio is better in plant-based protein. And here comes the role. But definitely, if patient is protein deficient as well, so we can supplement protein with phosphate binders.
The solution in this situation.
Yeah. I think in the last presentation, what Dr. Ratan Jha had shown that some of the vegetarian sources of protein, they may have a reasonably good amount of protein content. So it's not necessary that you have to take non-vegetarian protein. And so we can get away with protein from the vegetarian sources, which are high in phytates, and phosphorus would be reduced. The absorption would be reduced.
Is there any role of dialyzer clearance of phosphate and increasing the frequency of dialysis that would impact? Rather, class 1 protein is always class 1 protein, class 3 protein is always a class 3 protein. You have to decide the volume of the plant protein that you have to take along with the vis-a-vis the volume of the animal protein that you are going to take. Rather, increasing a dialysis frequency and a better use of a dialyzer is more important. I would like to say this way, rather banking upon the animal protein or plant protein. But that will help us to keep the phosphorus at bay and continuing with the treating the malnutrition also.
Rightly said, sir. High biological value of animal protein is undeniably far superior. Another problem he's been battling is he's a little malnourished.
So I think this is an important point because there's this constant debate with the nutritionists about the protein content, particularly in our dialysis patients, because they're also very concerned about giving a large amount of animal protein because they think that the phosphorus is likely to go out of control. So, can I have any comment from any of the nutritionists? I mean, what is their take on when they're prescribing a diet in a patient on dialysis? Uh, what are they looking at and how are they doing? Hima, yes, please.
Sir, very good afternoon to all of you. When we plan a diet for dialysis patients, first thing we see the protein content of the diet and the source, because the plant protein is low in phosphorus and the absorbability of phosphorus is low. So we usually prefer plant proteins, but the amount of protein should be in hemodialysis 1.2, and mostly we do the patients with hemodialysis, so we do 1.2 gram of protein plant based, and 50% of the protein can be given through uh, milk proteins and egg. That is we do.
Egg as in
Egg white.
egg white is not non-animal protein, or it's a sort of different category of vegetarian. Now the new term has come up.
Sir, egg is a high biological value. Egg white. I am telling you the egg white because egg white is the only source of dietary albumin. And that must be supplied to the patient, not with dialysis or without dialysis. So egg, that we take the liberty to add egg in the diet of patients with CKD, just to increase the albumin content of the diet so that hypoalemia can be corrected. That is the thing.
One point, madam, I want to highlight that why you are skipping the egg yellow, because all
Sir,
malnutrition patients are deficient in cholesterol also. So
Yeah.
how can you calculate that what amount of the cholesterol is given, whether egg albumin or whole egg or egg white or cholesterol and yellow egg?
Sir, because of the phosphorus content as well as, of course, the cholesterol and the triglyceride content of the, egg yellow.
Madam, what is your point? My opinion that 50% protein should come from the high biological value protein.
Yeah, yeah,
What is
yes.
your point on this?
Yeah, but it should not be from, flesh protein, that is red meat or chicken. That is not good, is not a good
Sir,
option because it also increases the uremic, acidity, toxicity, and it is also a good source of saturated fats and cholesterol. That is the
fish, poultry, white egg, milk, yoga, cheese.
Sir, egg white doesn't has fat or cholesterol. It is zero in fat. That is why we take the advantage to add egg white in the diet of CKD patients.
Go forward, but there's somebody.
I'll just add one thing here. So when you have a patient coming to you, there are concepts, whether the patient is vegetarian or the patient is eating non-veg. Then you also have patients who are coming as vegan to us. So whatever the thing is, the protocol remains the same, that you have to give 0.8, 1.2 or 1.3, whatever it is. So one is the counseling. The egg part, it is belief. Some consider it as a plant source, I mean a non-vegetarian source, and some consider it as a non-vegetarian source. So that again becomes your talking with the patient, counseling the patient, and what he or she is trusting about. For the patients who are vegetarian, we can always go for whey protein. We can also go for casein. Whey protein is fast absorbing, casein is slow absorbing. So again, it is based upon what you are looking at and what your intention is. If the patient is cachexic or sarcopenic and high muscle wasting, maybe you can give a combination of casein and whey protein both, so as you have a fast absorbing protein and a slow absorbing protein as well. Where the egg is concerned, you can give the yellow, provided the patient is not in a dyslipidemic stage or a high LDL value. Otherwise, of course, you can give the egg yellow as well. For the fish or the chicken or the mutton part, mutton, of course, we avoid completely. Chicken, fish, can be given. We can give prawns to the patient also, provided we are looking at the sodium value, because fish also comes with a high sodium content if it is coming from the sea source. So it completely depends upon how you counsel, how you talk to the patient, and what information you're getting from the patient completely. Thank you.
Sir, one more thing I just want to add, because fish and chicken are also a high source of phosphorus, and it not only interferes with the bone mineral density, but it also contributes to arterial stiffness. So,
I think we need to move forwards, otherwise,
Thanks for the inputs from the audience
thank you
as
so
well.
much.
Uh, we see that he's also battling malnutrition. So the next question that comes to our mind is, what are the causes and the prevalence of protein energy wasting in dialysis population? Sankar sir, can you just answer this question?
Uh, protein energy malnutrition is very common in dialysis and dialysis, both hemodialysis or peritoneal dialysis population. It extends from the 50% to 80%. One of the slides shown by Dr. Bhalla and diabetic patients, they have shown 80% protein energy malnutrition. The causes of PEW in dialysis population are obviously appetite, protein loss in the dialysate, protein loss in the peritoneal dialysis, because peritoneal dialysis there is loss of lot of protein drained in the peritoneal dialysis, and obviously urinary protein loss, and obviously intercurrent illness and inflammatory state of dialysis. So they are the common causes of protein energy malnutrition in dialysis population.
Thank you, sir. Uh, then how do we assess the nutritional status of dialysis population? And what are the means of assessing nutritional status of the dialysis population? Arvind Gupta sir, can you just throw some light on this question?
Actually, to assess the comprehensive status, nutritional status is not possible by single test. So we have to go with the various tests. And to me, what appears, it is a normalized protein catabolic ratio, which we can do in dialysis patient also, and we can do in CAPD patient also. We have different formula. Recommendation is it should not be less than 0.8. Hi- Higher the higher the ratio, that is more than 1.2, is suggestive of that nutritional status is okay. If less than 0.8, nutrition status is low. Other anthropometric measurement, MRI for fat tissue, MRI for muscle tissue, DEXA for the tissue, dietary recall, 24-hour dietary recall, 3-day dietary recall, and various losses in the dialysis. So all we have to calculate in the complex basis. So there is no single test by which you can say that it is a patient is malnutrition. We have to have the, all the criteria to be fulfilled, and I think normalized protein catabolic ratio is the most important. And residual.
Rightly said, sir. It has to be a combination of biochemical investigations, anthropometric measures, use of various assessment methods like SG and all. So that can help in assessing the nutrition status of these patients.
But I think the most important thing is the SGA score, because that's a simple outpatient score by the nutritionist who can assess whether the patient is getting into malnutrition or not. Because, as you said, the normalized protein creatinine ratio, although very good, but many of your patients may be anuric, and therefore you will not be able to assess that. And doing the other anthropometric measurements requires equipment, which again may or may not be available.
So, sir, what is the role of residual renal function, or what is the use of residual renal function as and the dialysis dose in managing such patients of dialysis? Sir.
Residual renal function still holds that strong ground till date. And it has been shown, the first study actually helped to assess the importance of the residual renal functions came from the Canusa study, where they primarily did with the peritoneal dialysis patient. But they have actually shown the residual renal function, if you estimate by GFR as low as 2 ml per minute, with a equivalent urine volume of around less than 200 ml per day, it actually changes the prognosis and the long-term survival of the patient.
Residual renal function helps in maintaining the solute balance, helps in maintaining the uremic toxins, particularly the middle molecules, and it helps to maintain the hypertension also, helps to maintain the phosphate level, helps to maintain the inflammatory mediator which are also circulating within the body. Thereby, the as the residual renal functions if it's being maintained, it helps in maintaining the phosphate level. Thereby, it has a in inverse relationship. The lesser the residual renal function, the higher is the cardiac mortality because of the vascular calcification and the valvular calcification. As the residual renal function falls, there is a low EPO level, so you have a less hemoglobin level. So anemia, volume expansion, hepatic congestion, hypertension, LV failure, all leads to the increased morbidity and mortality. Vis-a-vis, a lot of poor clearance of inflammatory mediator, persistence of the TNF released by the hepatic congestion adds to the malnutrition again. So it still holds that ground. Keep maintaining the residual renal function is of paramount importance in the patient on dialysis or without not on dialysis. But we need to see the what are the factors which affects the loss of residual function. uh, Pre-dialysis, we need to counsel the patient if the patient is obese to lose the weight. We need to look into the uric acid level, though it's no clear mechanism has been shown. Uric acid does play the role of the progression of the renal disease will fall in the presence or absence of the pre-existing cardiovascular disease, and these are the very important, and use concurrent use of all the aminoglycosides and painkillers needs to be taken care of, and other indigenous medication which has a direct impact on the kidneys. With the treatment at the onset of the dialysis, the greater the interdialytic weight gain, the greater is the ultrafiltration, more is the loss of microcirculation. The more the ischemic changes in the function nephron leads to further inflammatory mediator release and fall in the GFR. So as the GFR falls, urine output falls, the frequency of the dialysis needs to be improved, increased to achieve the KT upon B. So that's how it impacts the malnutrition status.
Uh, Thank you, sir. Uh, One important question, I think, even if we're running short of time, quite often comes to our mind is what is the role of oral supplement vis-a-vis parenteral nutrition supplement in dialysis population? Dr. Shashi, can you answer this question?
So this is a very important point because dialysis patients gives us a opportunity to give intravenous nutrition during dialysis, which our non-dialysis patient does not have. So when we look at our patients, if their nutrition is poor or if their intake is poor because of their disease or because of some gastrointestinal problem, so we can supplement these patients with intradialytic nutritional supplements. And this contains amino acids, contains dextrose, contains some fats, and few trace elements. Problem is that irrespective of, in contrast to those patients who are admitted, we have 24 hours of time. Our dialysis patients have only 4 hours of time. So volume is a constraint, the concentration is a constraint. So we have limitation on that. So we cannot infuse much of the larger volume. So can be restricted between 500 to 700 volume. We can provide around 0.5 gram per kg body weight of protein, 50 to 80 grams of dextrose, and likewise 30 to 50 grams of fats for our patients.
Yeah. I think that's a very important point. The only problem is that very often patients think that if they take a protein supplement, either enteral or parenteral, they don't need to eat their normal food. So that needs to be emphasized that this is a supplement, not a substitute, because there's a difference between the two. And as has been mentioned earlier also, that enteral is much better than having a parenteral if the patient can take it. And the problems with parenteral you have enumerated already. Can you give parenteral nutrition if patient has infection? I mean, that's the issue.
So again, it may increase your triglyceride levels, your blood glucose levels. So that could be a contraindication at that time. But simultaneously, the patient is in hypercatabolic state. So we need to.
Uh, like to thank the panelists for an excellent discussion on various important aspects of nutrition, managing anemia, managing
Yeah,
renal
there are
disease,
many
and
areas that we
nutrition
have
as well.
still not been able to discuss. Unfortunately, it needs greater. And I'd like to thank Dr. Abhilash for preparing this case. And I would like to thank all the panelists who have taken time and okay.
Thanks, everyone. Thanks to the audience.
There is a question. As there in alteration in gut microbiota can lead to uromic toxins and other various toxins leading to progression in CKD. So, can adding probiotics will help in reversing such uh, toxin load or something?
Actually, this microbiota dysbiosis is a vis-a-vis of CKD and dialysis patient. And important saccharolytic bacteria are abolished. And we are using more frequently antibiotics because of infections and CRBCs and UTI and pneumonia, what we are seeing in the practice. So we have to supplement with saccharolytic boulardii like probiotic. Not every probiotic is important, and
Yeah,
not every
strain
probiotic
specific.
is not given. It
Strain
will,
specific
yeah.
probiotics. Okay, sir. Thank you. Thank you so much.
Please put your hands together for the moderators and the panelists and request you all to please come towards the right of the stage and request the organizers to felicitate them. Yes. We are breaking in for a tasty lunch break and it will be of 30 minutes and I request you all to please join us sharp at 1:50 so that we can start again and be on time because many of our delegates are having their flights. Thank you. Ex- So, welcome back, everyone. We are
graft dysfunction. So, what is early post transplant? Traditionally, it has been described as first 4 to 6 weeks after surgery. And this period usually revolves around the recovery. And we should aim for quick recovery, wound healing, and lesser susceptibility to infection. And all these things are affected by the presence or absence of rejection, infection, and surgical complication. As I have said, that this period is very important to anticipate and manage surgical complication because they are going to affect the nutritional status of the patient in a big way. So allograft function may be rapidly improving, slow graft function or delayed graft function. And the electrolytes are very important in this early post-transplant period, especially the potassium, phosphate, and magnesium. And just because these patients are taking many immunosuppressive drugs, and all these drugs are having important and serious side effects on gastrointestinal tracts like acidity and gastrointestinal distress and diarrhea. And in this period, the physical fitness is low because activity is low. And in this period, usually first months of transplantation, food hygiene is very important because if you are not maintaining food hygiene, they can develop serious diarrhea leading to hospitalization in many of these patients. So initially, we are worried about increased nutritional demand, recovery from the surgery. We have to treat catabolism and promote healing. We have to monitor and treat electrolyte abnormalities and achieving optimal glucose control because dysglycemia is very important in early post-transplant. And in late, beyond 6 weeks, we are worried about the metabolic bone disorder, lipid profile, cardiovascular risk, hypertension, etc. So, what is the effect of immunosuppression on the nutritional status? By and large, they are having unfavorable metabolic profile. And GI symptoms are highly prevalent in early post-transplant period. And these drugs are given just to meet the target blood trough level during this important period. And all these drugs, immunosuppression drugs, lead to dyslipidemia, hypertension, and hyperkalemia. And PTDM is also common due to use of these drugs, especially the TAC, mTOR inhibitor, and glucocorticoids. And GI symptoms are more seen with MMF. Glucocorticoids are very important to change the body composition in these patients. Adipose tissues are deposited in these patients in a great fashion. And drug food interaction is very important to consider in this early post transplant period. So the dietary patterns has been discussed, whether it is DASH diet, Mediterranean diet, vegetarian and vegan diets, intermittent fasting, and keto diet. And it has been seen that the DASH and Mediterranean diet are recommended for kidney transplant patients. And the patient consume their meals as a whole, so more realistic dietary patterns should be advised in these patients. So what are the dietary recommendations in early post-transplant period? As I have said that this is a protein catabolic state, so protein intake should be high, 1.2 to 2 grams per day of ideal body weight. Calorie should be 30 to 35 kilocalorie per kg of body weight, and 50 to 70% should be obtained from carbs. And we have to monitor phosphate weekly, and if it is low, then high phosphate products or oral supplements should be advised in these patients. Hypo or hyperkalemia are usually drug induced and they have to be taken care. GI symptoms are there with use of MMF, so we should avoid milk products and high fiber diets during early post transplant period. And just to prevent hyperglycemia, monosaccharides have to be restricted. So this is the summary of daily nutritional requirement post-transplant. This is early and late post-transplant. And in all phases, you have to supplement sodium, potassium, supplement or take care of sodium, potassium, phosphorus, calcium, iron, magnesium, and vitamins and vitamin D3. These are the electrolytes, and hypomagnesemia is very important. Then hypophosphatemia. These are two specific electrolytes which has to be taken care during the early post-transplant period. And luckily, from some pharmaceutical houses, all the oral supplements, electrolyte supplements are available, and you can see that we can manage hypokalemia, hypophosphatemia, and hypomagnesemia with these available products. And this is like potassium is available as potassium chloride, phosphate as sodium acid phosphate, and magnesium as magnesium oxide. These are the various doses of these oral products. So this is the typical dietary plate of a post-transplant period with mention of servings and food as safety, as I have emphasized. And especially you should be worried about the thawing of. Once thawed, they should not be refrigerated. And if there is symptom of food poisoning, you should take care of help of the physician, and whenever in doubt, it should be thrown out. So these are the various food products. So take home message is, the current evidence-based guideline recommends dietary intervention of KTR that are target single nutrients. However, individuals do not consume these nutrients in isolation, but as a part of complete dietary pattern. So we should modify dietary pattern as a whole, and we should take help of the RDN, registered dietitian, and renal nutritionist. Thank you very much for your patient hearing.
Excellent talk, sir. Now house is open for discussion.
Right. After the hypercatabolic state, which is accelerated in these post-surgery period, and also due to the intake of glucocorticoids. So initially is to be high, but once wound healing and recovery is there, then it has to be taken lower down to 0.6 to 0.8 grams per kg body weight. Yeah. So I have mentioned that acute hypophosphatemia is very common, and magnesium is also, hypomagnesemia is very common.
Thank you, sir, for your nice presentation. Now we are moving on to our. Sorry.
Sir, as mentioned by you, garlic and honey is avoided before 7 days before surgery.
Yeah.
I just want to know why.
Because garlic and honey both are antiplatelet activity, and many a times these patients are on single or double antiplatelet drugs. So if they are posted for surgery, it should be stopped 7 days prior to the surgery. This is from the Sebastian textbook of surgery. This chart is from. Yeah. Thank you.
Thank you, Speaker, sir. Organizers, please felicitate sir. Over to the chair for the next chair speaker and the topic.
Now, for the second lecture of the session, I would like to invite Professor Dr. Sylvain Filfer. He is a professor and head in the Department of Nephrology in the BHU. So please deliver your talk.
Thank you, Anurag, for your kind introduction. I am also thankful to organizing committee for giving me opportunity to deliver lecture on this topic, nutritional immunomodulation in renal transplant. So I will cover the topic in this, although the data is not much very scarce, but I'll try to cover this topic in terms of what is immunomodulation diet probably could be, and what are few studies which have shown some benefit in renal transplant. So the immune system is network composed of various structures and biological processes that defend the host against pathogens, and lifestyle, dietary pattern, and environmental hazards affect the immunity. But certain foods can also have immunostimulatory and immunomodulatory effects. So, immune system is broadly grouped into two categories. We all know that innate and adaptive immunity. Innate immunity is which is the first response to various types of infections, and adaptive is antigen specific defense that is characterized by activity of T or B cells. Adaptive immunity is more specific and has memory also. The same in the diagrammatic representation, we can see that neutrophils, eosinophils, basically neutrophils are for innate immunity, and peripheral blood mononuclear cells, they differentiate into lymphocyte, monocyte, and then other T cell, B cell, and they are responsible for adaptive immunity. Now, what is immunonutrition? It is defined as modulation of activities of the immune activation by nutrients or specific food items fed in amounts above those normally encountered in diet. So immunomodulatory substances, they interfere with mucosal barrier function, that is affect the food on gut microbiota, cellular defense mechanism, and local and systemic inflammatory response. So the diet, some dietary supplements like arginine, glutamine, omega-3 fatty acids, prebiotics, they have vitamins A, B, C, zinc have shown to have some immunomodulatory properties, nutritional status of individual, and they both affect the immune efficacy and the effect on infection. Now, the potentially benefit populations from immunonutrition which have been studied are critically ill patients, surgery patients, immune related diseases, malnutrition, elderly patients. And what is the most studies are arginine, glutamine, omega-3 fatty acids, nucleotides, pre-probiotics, and it has been seen that they can affect their supplementation can affect in terms of immune system interplay in health in human microbiome. The gut microbiota is better, wound healing could be better, nutritional status could be better. So supplements have been tried in different group of these patients and have shown some beneficial results. So data regarding immunomodulation by diet in post-transplant patient is scarce, and most of the knowledge about immunomodulation by diet comes from its effect on autoimmune disorders. Like we all know that specific protein in cow milk can mimic beta cell pancreas. So avoid cow milk in type 1 diabetes. Animal-based protein shown to have increased permeability of gut and lower inflammatory markers in vegans. So vegetarian diet is more immunomodulatory. High salt diet has shown to increase new lesions in multiple sclerosis. High potassium diet has shown to be beneficial in rheumatoid arthritis. So the immunomodulatory agents, high fiber diet, omega-3 fatty acids, arginine, glutamine, nucleotides have been seen to modulate immunity and can be beneficial in renal transplant patients. So study run in murine model of kidney transplant resulted in changes to gut microbial landscape. This was high fiber diet, and they have seen that transplant in murine models versus isograft, the dysbiosis was seen in the not in isograft but in allograft recipients. So high fiber diet prevented transplant associated dysbiosis, and protection was mediated by short chain fatty acids and was dependent on CD4, CD5 regulatory mechanism. So dietary fiber is fermented by gut microbia, which results in massive production of short chain fatty acids, and they lower luminal pH. So, and short chain fatty acids are transported through epithelial cells by pH dependent monocarbohydrate transporters, and they improve gut barrier integrity by stimulating globate cells to produce mucus, favor fiber degraders and short chain fatty acids in local microbial competition, thus suppressing growth of mucin degraders, increase the expression of tight junction proteins. And the other benefit is the enhanced gut barrier integrity. So polysaccharide translocation is less, so endotoxemia chances are less. Cytokine and chemokine production by uh, the epithelial cells is also modified. The immunity response in myeloid cells is also balanced. So short chain fatty acids and proton balance the effector function mechanism of type 1 helper T cells and type 17 helper T cells, cytotoxic C cells. They maintain the balance between this and enhance intestinal IgE response, suppressing IgE response. So dietary fibers elegantly maintain the local homeostasis, which efficiently clears pathogens and prevents excessive inflammation at the same time. This is just diagrammatic representation of the same. The short-chain fatty acid, they decrease luminal pH and they balance the T cell, B cell mediated response, increase IgA response, and globate cells producing more mucus and they are maintained. So gut integrity is maintained by them. Next, omega-3 fatty acids, clinical data suggests that they decrease inflammation, arrhythmias, improve tissue microperfusion, improve graft function, decrease cancer cell lines, and limit omega-3 6 immune suppression, maturation of CNS, and increase clearance. Biochemical data suggests that they have biological regulators, cell membrane structure and function, influence membrane fluidity, alter receptor activity, eicosanoid metabolism, cytokine production, and gene expression. So all these effects ultimately result in beneficial effect on immunomodulation. And this was a study on long-term outcome on renal transplant recipients post hoc analysis. And we can see that uh, they saw that EP and DHA, which is omega-3 fatty acid supplementation versus alpha linolenic acid supplementation, two groups were seen, and there was the association remained following the adjustment of BMI, proteinuria, intake of fat, carbohydrate, and protein. The renal transplant recipient in the higher tertile of ALA intake. That is, the rejection rates, the mortality was higher in alpha linolenic acid group compared to omega-3 fatty acid groups. So fish oils are rich in long chain omega-3 fatty acids. 15 studies comprising 733 patients reviewed. All studies were small and had variable methodology. The fish oil didn't significantly affect patient and graft survival, acute rejection, or calcineurin toxicity, but overall serum creatinine was significantly lower in fish oil group compared to placebo. Second is arginine. So it is semi-essential amino acid and it is a precursor of nitric oxide. It has secretory stimulation action and it stimulates secretion of anabolic hormones like insulin, glucagon, prolactin, etc. So arginine transport into beta cells, pancreatic beta cells, stimulation of beta cells occurs. They improve helper T cell function, and they are also called as immune enhancing diet because of effect on T cells and macrophage. But the dose supplement is 2 to 6 times greater than normally uh, present in diet. So we all know that M1 and M2 macrophages, M1 is responsible for fight against infection and M2 is responsible for repair. And arginine, the arginase is present in M2 and nitric oxide synthase in M1. And the balance, the arginine supplementation has shown to improve T cell function and improve anti-tumor activity. So deprivation of arginine has shown to arrest the cell cycle and decrease T cell function. Glutamine, it is essential amino acid and has immunomodulatory and antioxidant properties, but it is contraindicated in ESRD because it is an amino acid can lead to hyperuricemia. So we can see that glutamine has various effects on lymphocyte, decreasing activation, decreased cytokine production, decreased phagocytosis, intestinal immunity is impaired, heat shock protein is decreased in glutamine starvation. So increase heat shock protein, better activity of lymphocytes, monocytes, intestinal immunity is effect of glutamine supplementation. So in GI, they support nucleotide biosynthesis enhance HSP expression, immune cell function, major source of energy for proliferating cells, support neutrophil killing, enhance HSP expression, kidney acid-base regulation, and decrease ammonia metabolism, muscle increase protein synthesis, and lungs the major source of energy for endothelial cells. Other is dietary nucleotides. They are building blocks of DNA and RNA, essential for rapidly replicating cell supplement. A benefit of supplementation is protein synthesis and intestinal repair. So, immunomodulatory functional foods and their molecular mechanism is one article, and they have seen that the various uh, supplements like ginseng, mushroom, cholera, probiotics, they have shown to improve the they have shown the immunomodulatory effect of such foods, and I've already mentioned. So after kidney transplant, what should be diet? Already told, so I'll skip this. And this was an article about dietary approaches in kidney transplant patient. We showed that Mediterranean and DASH diet have demonstrated beneficial effect. So maybe some immunomodulatory effect in that diet. The influence of immunomodulatory diets in transplant cases. This was uh, uh, if I can enlarge this small in my presentation. Okay. Yeah, thank you. Just a minute. So this was immunonutrition, the slideshow. So that was a study which um, they studied the effect. They made two groups. One was supplemented with L-arginine, and other was not. And they shown that there was a bit decreased rejection in the group which were supplemented with L-arginine. So immunomodulation in kidney and liver transplant, they also studied the effect of omega-3 fatty acids and had shown that patients supplemented with omega-3 fatty acids had a bit better graft survival than patients not on that. So to conclude, although the main immunomodulation or immunosuppression drugs are the backbone of the renal transplant, but still, omega-3 fatty acids have shown some benefit, but further RCT are required to establish such guidelines for immunonutrition. Thank you.
Excellent talk, sir. Now the session is open for question answers.
When you activate do immunomodulations, means increase in the immune activity, and was there any literature showing that there was some increase in incidence of rejections like that?
One study had shown that there's supplemental alpha-linolenic acid, but there was increased mortality. Maybe uh, they had you are absolutely correct, sir. Immunomodulation of diet and enhancing immunity may have different effect. So immune enhancers are much more available in literature and they have been tried. But immunomodulatory diet, very less literature is there and it's still just area for exploration.
So there is difference between immunomodulation
Modulation and
and immune
immune
enhancers.
enhancers. Definitely.
That message is good. Thank you very much.
Thanks.
Thank you, Speaker, sir. And we are honoring the inspirational presence of our chairpersons and speaker with a felicitation. Thank you so much. And with this, we come to the next presentation, and I'm delighted to invite the chairpersons on stage. Dr. Deshraj Gurjar, consultant nephrologist from Kanpur. Dr. Manjeet Pal Singh, consultant nephrologist from Varanasi. Dr. Minhaj Akhtar Usmani, associate professor, Department of Food and Nutrition, Era University, Lucknow. And it was indeed a warm welcome. You can clap for everyone. Thank you. Please join us on stage, ma'am. Sir. Thanks for your gracious presence. You can introduce the topic and the speaker. Thank you.
Next presentation is keto diet in CKD. Where does we stand? For this presentation, our speaker is Dr. Ashwani Davi. Dr. Ashwani Davi is senior consultant and physician at Ahmedabad. Kindly proceed, sir.
So thank you so much for the kind introduction, ladies and gentlemen. I am a messenger sent by the then great colleague, Dr. Anita Saxena, who introduced me to this distinguished community of nephrologists and nutritionists. So I liked to share this presentation for all those young dynamic nutritionists who are aiming to become leaders in this specialty. For this talk, I don't have any conflict of disclosure. We learned that addressing nutrition at the initiation of care in a patients with CKD is very important. But we learn lots of things about proteins, carbohydrate, and fats. But my job is to throw some more important role of ketone bodies in this situation. So when we were students like you, we never used to address nutrition even in stage 5 CKD patient, whether on dialysis or not. But since last 2 decades, lots of organization have laid down guidelines and they started recommending nutritional support in stage 3. But time has come that we have to change there is a paradigm shift. So addressing nutrition at the initiation of disease process would be more appropriate. So this is the outline of my presentation. And all of you know that the keto diet is a diet which is significantly low amount of carbohydrate, a very high amount of fat, and appropriate amount of protein. So now we have 2 ways to treat the CKD patients. One is by my nephrology colleagues, is by the drugs. Another very important is by choosing an appropriate dietary regime. This is very crucial. So this is an era of personalized, or we call it a precision, or maybe individualized treatment. So this is very important that whatever evidence is gathered in last few decades has to be implemented in our day-to-day care. And that is why we will be able to deliver optimal results in patients with CKD. Though the CKD and ketosis is a contradictory. Once patient develops CKD, their chances to go into ketosis is negligible because insulin half-lives are elevated and very low or undetectable insulin levels are required to make the ketone bodies. So very importantly, all of you know that for millions of years, we as a Homo sapiens survived only on ketosis because there was scarcity of food. But then we became a kind of processed Homo sapiens for the last 10,000 to 12,000 years with the advent of agriculture. But in last 2 decades, we have become ultra processed Homo sapiens with lots of foods which is being produced in a industry. So our phase of ketosis has gone from scarcity of food. We are loaded with calories and lots of other nutrients. So this is what that fasting is necessary for ketosis, what our elderly people used to do for a better health. But prolonged fasting in a patient with CKD is not good, no, because these patients are already at a risk of protein energy wasting. So that is why for this presentation, I use the term ketogenic metabolic therapy. That not necessarily mean the ketogenic diet. So friends, apart from inducing a weight loss, all these ketogenic medical therapies has other non-nutritional benefit, like in form of reduction in the insulin resistance, reduction in the blood pressure, and reduction in the inflammatory process. So these are all responsible factors for the progression of chronic kidney disease. And none of the guidelines, I'm very happy that I don't have any data to share with you. Whether it is Kedoki, no guidelines in this world. Like I was a part of European Society 2022 guidelines on kidney failure, but we do not have any statement on keto diet. So this is purely from an expert consensus. And I'm very happy that forum like this gives an ample opportunity for non-nephrologist physician like me and also for nephrologists to learn something which is very important in patient care. Mostly, if you look at the nephrology professional, they are very busy with the other care of the patients and they leave nutrition mostly to the patient and their relative. And we hardly have a renal dietitians in country. We can count them on fingers. So this is very important that nutritional has to be addressed. So there are lots of misconception about ketogenic metabolic therapy. Everybody knows that carbohydrates are essential. We can't survive without carbohydrate. But as I said, millions of years humans have survived on a low carb diet. And lots of carbohydrates are manufactured in the body. So carbohydrates are not that essential as we think of. So it is incorrect to say that carbohydrates are mandatory in a survival. And we have understood from the prolonged fasting, some communities like in Muslim community or in Jain communities, they go on fast for days and they survive purely on a ketone bodies. Second most important thing that since ketogenic diet is low carb and high protein, means any amount of protein and fat can be taken. So this high protein is very difficult for kidney patients to metabolize. But unfortunately, there are now studies which have come up that use of plant dominant low protein diet and plant focused nutrition in diabetic kidney disease. By incorporating ketogenic diet, there has been favorable optimization of amino acids. Instead of amino acids going into the oxidation and producing waste products, they are utilized by the body. Other misconception is that keto diet is mostly like a carnivorous Western diet. So that is not true. So though by definition it is a very low carbohydrate and diet with a high amount of fat and protein, but this is very important that it is not the Western type of diet. even we can convert our plant-based diet into a keto type of diet. So that is very important, we must take into consideration. And most importantly, nowadays, many of the studies are done by the industry. And we as the investigators are the part of trials which are run by the industry. So there are lots of investigational and patient selection bias. So this is a significant source of misinformation running in our community. The third point is, what is a rationale? Why should we want to put the patient on ketogenic medical therapy? Because all of you know that most of the CKD patients nowadays, they have a baseline diabetes or a metabolic syndrome kind of thing, or maybe they are overweight. And we now, there is an volcanic eruption in non-communicable diseases after the COVID catastrophe. And all this chronic hyperglycemia adversely affect the kidneys, not only in out of hospital, but also in acute care setting. So we have a wonderful ketogenic diet which improves the insulin sensitivity and reduces the hyperglycemia burden. And recently, all of us are very crazy about using the SGLT2 inhibitors, which throws out the glucose in the urine to the tune of 80 to 100 gram per day. So that is again a kind of, ketogenic metabolic intervention. So this is very important. We want to keep in mind. The other rationale is that by using the ketogenic diet, it has been shown to reduce the blood pressure. So that is very important, that blood pressure, every millimeter of mercury reduction in blood pressure will reduce the progress of CKD. And most importantly, as I said, that it is a inflammaging. All the patients with a chronic disease, they have a hidden inflammation and which has not been addressed for a length of time. And this inflammatory process will lead to the oxidative stress and damages all most of the organs. So we as a clinicians many a times are very reluctant to take the ketogenic metabolic therapy because it is a high protein or high fat. Maybe it will increases the prevalence of cardiovascular disease. So that is not a rationale for not using the ketogenic therapies. So from the scientific evidences which are available, and what till date we had been recommending low protein diet, protein restriction, but very wonderfully elaborated by Dr. Vivekanand in the morning, that all of us are on CKD diet. In India, we hardly have 10 to 12% of calories coming from protein. And with the ketogenic metabolic therapy, I said that you can optimize the protein in a better way than the rest of the diet. So here I just like to give you some of the evidences. So the first study was a randomized controlled 2 years intervention where they compared the keto low carb high fat diet versus Mediterranean diet versus conventional low fat diet. And what they found, that the ketogenic diet had a strongest beneficial effect on the renal function, particularly in a CKD stage 3. So this is very important in our evidences. All the studies which I put in my presentation are in last 2 to 3 years. And to your surprise, I am pleased to say that ketogenic diet was the most searched healthcare word on any Google and other platforms. So this is the power of this ketogenic metabolic therapy. In the second study, they took the 92 obese participants and they subjected to ketogenic diet for 15 weeks. And of that, 38 subjects had CKD stage 2. And what they found, that remarkably 27% of those with CKD, the intervention led to the remission of CKD, leading to normal GFR. So this is unbelievable. It is good to treat the disease, but it is better to address the disease process so that you can reverse the metabolic defects. Similarly, there are a number of studies which are there to identify Like one retrospective cohort study, which had over 2,000 overweight and obese patients, which was conducted over a span of 19 years. And 75% of the cohort had a CKD stage 1 to 3. And what they found that the treatment with ketogenic, low carbohydrate, high fat, and relatively high protein diet, I said that you are able to liberalize the protein intake, which improved the metabolic parameters. So this is very important to understand that rather than, many a times we rely on the guidelines which are thrown by people across the ocean, and it is very difficult to understand. So this is one more study which comprises of ketogenic diet via continuous remote telemedicine. So it is not necessary to do one-in-one counseling in the patient. And what they enroll 262 patients with type 2 diabetes and GFR less than 90. And what they found that in patients who were on the ketogenic diet, the progression of kidney disease was slower compared to the rest of the other groups. There are number of other intervention of ketogenic diet in adult polycystic kidney disease. And also apart from ketogenic diet, you can also use the supplements which are available in the market, which are though very expensive, but can be utilized in day in and day out. This was an one experimental study from China where they give the keto diet to rats whose ureters were obstructed, and they were surprised to so know that in those rats who were on ketogenic diet were able to reduce the fibrosis. So this is very important that dietary interventions are very crucial. But though these diets are good, but they are not without the complications like keto flu or micronutrient deficiency. Very quickly, this was my own patient, 74-year lacto-vegan. So she was diagnosed as a diabetic kidney disease in 2004 with multiple comorbidities in last 20 years. And as yesterday we were discussing, all across the India, carbohydrate consumption is more than two-thirds of the calories. And whether you take it a low carbohydrate or low fat process, you will not able to sustain the weight. Everyone after you stop the intervention will regain. So guidelines, as I said, very confusing. No, by the time we understand the guidelines, the new guidelines will come. So this patient had a gross proteinuria in 2004 and was managed by one of the largest kidney group in Gujarat. But somehow I could come and do the intervention of plant dominant low carb, high fat and low protein diet with keto analogs, and we were able to reverse the disease process. And this patient now doesn't have the proteinuria, and she doesn't have stent, no laser, no diabetic foot problem. So we as a physician are always there to confuse the people, whether take this diet, take that diet. But most important is, please do not forget to request patients to do the exercise. So with that, I just like to conclude that every diet is important. So don't get mad about the Mediterranean diet and the DASH diet. I would recommend dashing dietary solution is more important than any type of diets which are set by the people across the ocean. Thank you.
Sir, I have a question, sir.
Yeah.
So the benefits seen with these keto diets, is it not compounded by the weight loss that a patient incurs because of the keto diet? Like we know, most of the patients, almost 50% of them are secondary to diabetes or obesity and hypertension.
So this is an excellent question, and I just like to give an example. All those patients who are undergoing bariatric surgery, even before the weight loss, their diabetes and hypertension goes up. So this is very important that it is not necessary to achieve the weight loss, but you will definitely achieve the cardiometabolic benefit even without the weight loss. So that is very important.
That one question. Uh,
I am using a ketogenic diet for the refractory seizures. Then, in the patient who is on ketogenic diet, patients require more close monitoring of the blood sugar and urinary ketones. Is it required in for the CKD patient also?
So it is good. This is an excellent question, but since the continuous ketone monitoring devices are currently not available.
Sir, we are doing with the urinary ketodiastates.
Yeah, that is with
6
the
and
urine. I'm
8.
talking about the subcutaneous ketone monitoring, which are coming next year with both simultaneous glucose and ketone monitoring.
Yes, sir.
It is mandatory for keto patients to be blood sugar should be in a double digit.
Yes, sir.
That is most important, and we prefer serum ketone levels between 0.3 to 5,
Yes, sir.
not the urinary ketone levels.
Okay, sir. Thank you, sir.
I'm okay to take a few more questions.
Sir, one question. In context of, I'm sorry, CKD, when we talk about plant-based diet, and if we plan a keto diet with plant-based diet, it will be automatically have a high carbohydrate content because all the plant proteins have almost equal carbohydrates. So how it is possible to design a keto diet with plant proteins without carbohydrate, or which is the recommendation that is 5% of the calorie should come from carbohydrate. So what is the constituent of the diet?
So thank you so much. And what I said that the Indian people consume more than 2/3 of calories. So you cannot overnight jump from normal diet to keto diet. It is a transition process. So if to reduce carbohydrate from 70% to 10 to 20% need few months. Otherwise, these people will develop keto flu. But see, there are optimizing with a plant-based diet. What we used to do, I used to do in my clinic is to use lots of alpha glucosidase inhibitors. So that will suppress the absorption of glucose. And number two, like frying the things. Most of the vegetables, starchy vegetables have a good amount of carbohydrate, but you can use the peanuts, nuts, lentils, mixed dal, and try to fry the food. Use liberally butter and ghee. So this is very important.
Sir, but once you fry the food, the fat gets converted into trans
No,
fat.
who said that? Who said that? It is a wrong fat you choose. Seed soils are dangerous when you give a heat, but saturated fat doesn't oxidize. So to that extent,
So, sir, the recommendation for saturated fat is only 7%
So
of the
that is the
total.
American recommendation. There is a one trial which has come from Australia. I say, for example, in a Greenland, what is the consumption of saturated fat? 70% of calories from saturated fat. But still the cardiovascular prevalence is the very low. So it is a myth. The saturated fats are harmful. I think in the interest of time, we close this.
Thank you, sir.
Okay, thank you so much.
Thank you so much. Thanks to the speaker, sir, and for the chairpersons for gracing the dais with your inspirational presence. Now we are moving to our last session, and that is session 11. And I am honored to invite on stage the chairpersons, Ms. Diksha Patel, Chief Nutritionist, Chandan Hospital, Lucknow, Miss Mridul Vibha, Nutritionist, King George's Medical University, Lucknow, Miss Neha Mohan Singh, Nutritionist and Assistant Professor, RB Nursing College, Lucknow, Dr. Shalini Srivastav, Senior Nutritionist, King George's Medical University, Lucknow, and Convener, NetProfin, UP Chapter, FSSAI, Miss Saima Faruqi, Senior Nutritionist, Medanta Hospital, Lucknow. Please join your hands together. Please applaud. Thank you. This, the stage is all set with the presence of dynamic ladies. And over to the chairperson for introducing the next speaker.
It's an honor to invite Ipshita Di. Miss Ipsita Chakravarti. She is working as a clinical dietitian for more than 23 years. Presently working with Bellevue Clinic, a multi-specialty hospital, Calcutta. Hi, Dee. And Food Map certified Monash from Monash University, Australia. Has had articles published in various Bengali, Hindi, English newspaper and magazines and e-papers. She has also provided inputs for different research works and has publications in her name. External expert in in the board of studies, papers and examiner in Amity University and Midnapur Autonomous College, etc. She is a life member of IDA, IAPN, ISPN, SNT and DAY. And ये सारे सबसे ऊपर एक बहुत ही महत्वपूर्ण जो इप्सिता दी के बारे में, शी इज ब्यूटीफुल इनसाइड एंड आउटसाइड. So start big and heartiest congratulations and welcome to Lucknow. Thank you.
Thank you, Shalini, for this kind introduction. And at the outset, I would like to thank the organizers for inviting me here and for this beautifully arranged conference without wasting much time, as it is my flights are almost knocking. So my topic is micronutrient supplementation in the CKD patients. I just wanted to make one correction in my CV. I think this was the last CV. I am working as a chief head of the department dietetics in Calcutta Hospital. We all know this is a basic definition of CKD, which is defined as the at least last 3 months of a reduced EGFR, which is less than 60 ml per minute, or kidney damage, or as the presence of persistent albuminuria. It is considered a significant public health problem with an increasing prevalence, and around 10% of Indian population suffers from CKD, and every year almost more than 1 lakh of renal cases are being reported. My slides are very simple because not the nephrologists present here and all the senior dietitians present here. I have made these slides for the target audience, which is budding dietitians. So what are micronutrients? The term micronutrients refers to vitamins and minerals, which can be divided into macrominerals, trace minerals, soluble water and fat soluble vitamins. An adequate amount of micronutrient often means aiming for a balanced diet. And vitamins, we all know that it's necessary for energy production, immune function, clotting, and other functions like growth, bone health, fluid balance, and several other physiological processes. And dietary intake of micronutrients is a potentially modifiable factor that may have a role in the prevention of nutritional deficiencies. Restrictions imposed on CKD patients aiming at reducing protein, phosphate, potassium intake that make it difficult to ensure the adequate micronutrient content of the diet. And we all know that for high potassium patients who have high potassium, we always tell them to leach the vegetables, and automatically leaching reduces the water soluble vitamins. It goes out with the water. So these are basic micronutrients which we look into while doing a prescribing a renal CKD patient. So patients with CKD are at substantial risk for malnutrition characterized by PEW and micronutrient deficiency. Different studies have shown that high prevalence rate of malnutrition in adults with CKD, the PEW and muscle wastage and sarcopenia, all this sets in. The pathogenic mechanism of malnutrition in CKD are complex and involve an interplay of multiple pathophysiologic alterations, including decreased appetite because of uremic status, elevated urea and creatinine, the nutrient intake, hormonal derangements, metabolic imbalances, inflammation, increased catabolism, and malnutrition related abnormalities. So, this Aspen defines malnutrition as an imbalance between nutrient requirement and the intake, resulting in the cumulative deficits of energy, protein, and the micronutrients. These definitions assume a state of undernutrition, which constitutes PEW and micronutrient deficiency as well. So, CKD predisposes, we all know, the overall decrease, and the studies of CKD patients show that a decrease in the intake, such as vitamins, folate, iron, pantothenic acid. Recent examinations of CKD patients showed that they are deficient in 25 hydroxy vitamin D also. So in adults with CKD5D who exhibit inadequate dietary intake for sustained period of time, it is reasonable to consider supplementation with multivitamins, including water-soluble vitamins and essential trace elements to prevent or treat micronutrient deficiency. And we all know that when a person reaches this 5D stage, so either that person going for transplantation or that dialysis starts. So body has to be ready either for the surgery or for dialysis. So till such time patient was on a low protein diet, so patient develops PW. So low dietary intake of phosphorus, vitamin B2, and high dietary intake of B6 and C were associated with an increased risk of CKD and stage 3 and over compared to the with the intake at recommended levels. So this is a study where all like a 12 years follow-up cohort study where it was RTA, AI, or National Kidney Foundation guidelines were taken into account for a age group of 51 to 70 years, where they were given the reference value of all those items. So it was seen that low dietary intake of phosphorus, vitamin B2, folate, and high dietary intake of B6 and C were associated with an increase in CKD stage 3B and over, and compared to the recommended level, what I shared in my previous slide. Vitamin B6 can be found in different nutritional sources with animal and vegetable origin. So, although cooking, storage, and processing might cause significant B6 losses, and B6 supplementation in CKD have been investigated in the context of combined therapies with other B vitamins, and available studies report contrasting results. Methionine, this is not actually a vitamin, but the main dietary sources of methionine is either animal proteins or Brazil nut. Although methionine cannot be completely eliminated as it comes under essential amino acids, there is large evidence in vitro that experimental and clinical studies on the benefits of methionine restriction in several pathological conditions and related to accelerated aging, which includes kidney diseases also. Choline, there also again is involved in various mechanism, and it sorry, such as neurotransmitter synthesis, like cell membrane signaling, lipid transport. For all this choline is required. The CKD patient tend to accumulate choline, and because kidney is not functioning well, it's not eliminating, so choline is being accumulated in the body. Again, nicotinic acid, we all know that for a formation of NAD and NADPA, again, nicotinic acid is very much required, and it plays a crucial role in aging-related diseases like cancer, atherosclerosis, metabolic disorder, and renal failure. So these are the things where we need to look into what to give and how much we need to prescribe. Now comes potassium, very, very important mineral where a CKD patient has to keep a close eye on. Hyperkalemia or hypokalemia both happens when for a CKD patient. If hyperkalemia is there, we have to counsel the patient to reduce the intake of potassium rich foods, potassium containing salt substitutes, because yesterday also we have learned a lot about salt substitutes. Patients should be counseled to adhere to bicarbonate therapy if advised, since correcting acidosis, which might help lower the potassium level. Leaching of vegetables is also helpful in lowering the potassium level in vegetables. So mild hyperkalemia may be asymptomatic, but high potassium level it's a life-threatening disease which causes cardiac arrhythmias, muscle weakness, even it can lead to paralysis. So moderate to severe hypokalemia, you can see this is the chart below. If it's normal to mild, these are usually symptoms are asymptomatic. And if it's 2.5 to 3, so it also have mild symptoms. But if it's severe, less than 2.5, the muscle cramps, weakness, heart failure, all these can happen. And we have to be very particular. And usually physicians start giving medications. And if patient is on oral diet, so we have to give potassium-rich diet for those patients. Calcium, again, a very important thing for a CKD patient. Its balance is strictly regulated by the calcium absorption in the intestine, reabsorption in the kidney, and exchange in the bones. So, given the important role of kidneys in calcium balance, the serum calcium level decreases as CKD progresses. So, here also, recommendation of dietary calcium for patients with CKD is yet to be established, but phosphate binding medications which are calcium based may increase intake and elevate calcium levels. Active vitamin D supplementation increases the risk of hypercalcemia. Formula to correct calcium levels with hypoalbuminemia is corrected calcium mg per dl equals to serum calcium 0.8 within bracket 4 minus the serum albumin. This is a basic formula, the way it is being calculated. Again, calcium, the picture of calcium rich foods and corrected calcium for albumin less than 4, we need to do the calculation and need to rectify if it's hyper. So we need to restrict the direct calcium sources for that patient. And if it's hypocalcemia, usually injections are given and supplements are given between meals. Now comes phosphorus, again a very, very important criteria. So restriction of dietary phosphorus is advised if serum phosphorus is elevated. The level of recommended restriction has yet to be determined in CKD. Decreasing dietary protein decreases the, extremely sorry, there's a spelling mistake, I'm sorry. The intake of phosphorus, intake of food with added phosphorus should also be avoided. So we need to, because these days, because of FSSI guideline, whatever packaged foods are coming, so all those have nutritional facts at the back. So while purchasing packaged food, we need to learn how to read the label. So where it is written, and if some terminology is there which ends with phos, so we need to, I understand that particular food item contains a good amount of phosphate, and we need to read the label also. So ideal phosphorus level, we all know normal health is 2.5 to 4.5, stages 3 and 4 is 2.6 to 4.6, and stages 5 it's 3.5 to 4, I mean 5.5. And phosphorus and its balance, this is the way we need to do the balance, the dietary intake, and the way hemodialysis removes, peritoneal dialysis removes, and 50% of dietary phosphorus are removed by the binders. So control equals to, so how can we make it a control, like binders plus diet plus adequate dialysis? So these all combination gives a balance in the phosphorus. As I said, reading of the labels. So these are few phosphorus additives which are found in food packets. So please tell your patient, counsel your patients to purchase accordingly, so that they should learn how to read and what are the items which they should avoid while purchasing. Vitamin C, higher doses of vitamin C supplementation have been shown to increase serum oxalate level, which is a potent physiologic antioxidant, and it also affects the immune function and carnitine metabolism. Patients with any malabsorption of diseases of an inflammatory nature may be more prone to having lower plasma vitamin C levels than the general population. So therefore, supplementation should also be taken into consideration, the medical history, the comorbid condition, and the concomitant medications. So here also we need to keep a close eye on the vitamin C. So always counsel your patient not to buy OTC drugs, over the counter drugs, and go on popping, because after this COVID and all, people started having so much of vitamin C over the counter, purchasing and having it. Vitamin D, again, a very important thing. In adults with CKD 1 to 5D, it is suggested to prescribe vitamin D supplementation in the form of cholecalciferol and argocalciferol to correct the 25 hydroxy vitamin deficiency or insufficiency. Supplementation with proteinuria in adults with CKD 1 to 5, the nephrotic range proteinuria. It is reasonable to consider supplementation of cholecalciferol, argocalciferol, or other safe and effective precursors. This is an opinion, not we cannot consider this as a guideline given by KEDOKI 2020. And vitamin D supplementation usually do not have any effect on phosphorus levels with argocalciferol supplementation. So this is a KEDOKI guidelines which all say, I think all of you know this. Potassium for no restriction, less than 5. Restrict Potassium intake 3 to 4 grams per day. For CKD, restrict potassium intake 2 to 3 gram with ESRD and restrict 2.4 gram per day if patient is hyperkalemic. Phosphorus also we need to restrict depending on the patient, the situation, the blood parameters, as well as the sodium. But for sodium, as it's a balance of fluid, it should be we should have a close eye on sodium because it affects the fluid balance also. So stages 1 to 5, it's usually less than 2.4 gram per day. So foods high in salt and sodium include processed foods like cheese, fast foods as such as pizza, salty snacks and chips, salted nuts and sauces and pickles. This is my concluding slide. Epigenetic regulation in patient with CKD and ESRD is strictly related to the interplay of nutritional intake and supplementation of B vitamins and methyl donors with uremic milieu. Homocysteine is undoubtedly the key factor in methylome status and epigenetic landscape, although the peculiar scenario of uremia is influenced by other co-founding factors like inflammation, gut microbiome, oxidative stress, and lifestyle disorders, lifestyle habits, I should say. A better understanding of this complex network may help the clinicians as well as practicing dietitians in the challenging riddle of individual variations in CKD progression and to identify patient tailored therapeutic approaches based on their own nutritional deficiencies. So do not depend on any internet based diet. Please consult your nephrologist as well as a renal dietitian. Thank you so much for your patient hearing.
Thank you so much, ma'am. Thank you so much, ma'am, for the super quick but the super duper enlightening session. Ipsita di, it's very well said कि different stages हैं और CKD patients बहुत सारी stages में रहते हैं, तो we need to take care each and every stage and the values and the likes and dislikes और बहुत ज़्यादा leaching and all के जो losses हैं, तो sometimes we must honor the likes and dislikes of the patient also, and we can allow some little things which can be taken.
I always tell my renal failure patient, because I work in a multi-specialty hospital, where I always give my number to those because their blood parameters go up and down. So once a patient, one diet chart is given, it is not for the lifetime. So we need to keep a close eye and we need to have a clarity with the patient and the caregivers.
And another responsibility is to make our patient as his family to a smart consumer of any product he's purchasing from market or from local market and so on. Very well presented. Thank you so much.
Thank you. Question. I would like you to comment on carnitine deficiency in dialysis patients because carnitine is a very important molecule for transfer to mitochondria, energy transfer.
Yes, sir.
The other thing is about zinc deficiency in dialysis patients.
Actually, sir, I was told to cover the CKD part, so that's why I didn't go into dialysis thing. Thank you so much, sir.
Thank you, ma'am, and let us felicitate you. I request the organizers to please do the honors. And I also request the chairpersons to please move for the felicitation. And thank you for being here with us, for gracing the dais. With this, we come to the next portion, and that is the panel discussion. And I am deeply honored to invite the moderators on stage. Dr. L.K. Bharti, Professor, Department of Pediatrics, Gastroenterology, SGPGIMS, Lucknow. And Dr. Biju, Professor and Head, Surgical Gastroenterology, JIPMER, Pondicherry, Editor-in-Chief of the Journal of Nutrition Research. Welcome, gentlemen, on stage. And I invite the panelists for the session. We have Ms. Archana Sinha, nutritionist, SGPGIMS, Lucknow. Ms. Renu Raj Shrivastava, nutritionist, SGPGIMS, Lucknow. Dr. Nirupma Singh, senior nutritionist, SGPGIMS, Lucknow. Dr. Shilpi Tripathi, nutritionist, senior nutritionist, SGPGIMS, Lucknow. Ms. Sarita Tripathi, research dietitian, endocrinology, Lucknow, and Dr. Preeti Pandey, Senior Nutritionist, Apollo Medics, Lucknow. Over to the moderators and panelists.
I bring greetings from the IAP in India, and this is our third successful year of collaboration with the Renal Society. And next year, we are the co-host to conduct the International Congress of the Nutrition Society Hyderabad. We are really progressing well. So we were always discussing about restrictions 90% of the time. But as a whole, what we should understand is, despite all these trials, SGA still stands the best method to assess the nutrition. So always watch the patient. Okay, this patient will be having less appetite, nausea, vomiting, low BMI. You have difficult access, and the recommendations when you prescribe prescription to implementation actually going to the body, there'll be a lot of disparities. This is what we've seen, especially in hospital setting. You prescribe something and only 70% will go because of the frequent hospital visits, and they'll have multi-system diseases. So salt restriction we have spoken, and a low salt diet also we have spoken. Protein, these are leaking points of protein, the kidneys. But what we have to know regarding the GFR, there is a lack of significant data. So we have a less monoamine serotonin in our generation of the gut. It reduces the inflammation, oxidative stress, and it increases there will be better insulin sensitivity also. Okay. So, but what we advise generally is we start from very low reserves. Okay. Indian patients are not Western patients. We eat much more carbohydrate than the proportionately required. They come with very less protein in the body overall. So all these are to be managed extremely carefully. Okay, especially patients who are not on dialysis, because they may progress to dialysis. And this point, any panelists want to comment exactly about this point? Practically, do you recommend a strict protein restriction practically? Just a practical point.
Actually, when the patients are coming to us with diabetes or only CKD, then we used to take the diet history first. If the patient is already lacking the protein, generally we have seen that our patients or our general population is also not taking the zero point 0.6 to zero point 0.8, no, more than 0.8 gram of protein. So we have to first take the diet history. If there is over intake of protein, then we can do some restrictions if it is over. If it is not, then I think so there is no need of any restriction
Yeah,
of the
again, the
protein.
same point. We are starting from very low. Okay, many of the patients will not be receiving 1 to 1.2 already.
Yes.
And is there any benefit for other thing, keto analogs and all that? Any panelists want to comment? Do you recommend it?
Yeah, sir, guidelines suggested that as we have discussed in the some lectures, ki with the keto analogs, protein requirement is very less, 0.23 0.3 to 0.4 gram per kg body weight. Being a dietitian, it's very challenging for me to fulfill the requirement of calories. Calorie requirement is 2000 calorie, and protein is only 24 gram of per kg body in 24 hours from diet. So already when suppose a patient taking 40 gram of protein per day, and we are cutting 20 gram of per kg 20 gram in a day, then it's very low protein diet.
So this is a very important point, because we actually work on actual recommendation individually. But when
Yes,
the
sir.
combination come, you always keep a watch on parameters like, are you keeping the proportion with respect to other supplements? Am I correct?
Yes,
So you have
sir.
to go slow, steady, but keep the proportion very well within your limit. It may violate your actual recommendations of particular
Yes.
component or
Yes.
micronutrient. Okay. Now, calorie restriction, do you advise too much calorie restriction? Because
No.
here is a problem of low calorie, but proportion high.
Yes, sir.
So
Yes.
do you advise?
Yeah, there is no calorie restriction for the CKD, as early we know कि malnutrition is very common in CKD patient, and impaired energy metabolism found in the chronic kidney disease. So maintaining adequate energy is required to improve the nutritional status of the patient. There is no need to restrict the energy requirements in chronic kidney disease.
Okay, keto we have already discussed. Phosphorus?
Anybody?
Yeah. Yeah. Phosphorus requirement is around for the lower CKD stage 3 and 4, it should be less than 800 mg, and the patient on dialysis it could be around 800 to 1000 mg per day. And regarding common phosphorus foods in the Indian diet, so not only we need to quantify the amount of phosphorus in the diet, we should also look for the quality of phosphorus. So it is very important that we should teach our patients regarding the phosphorus type also, whether this is the organic phosphorus or inorganic phosphorus, whether they are having diet from the plant based phosphorus or based plant phosphorus, their bioavailability and phosphorus to protein ratio, which is very very important, because mostly the plant proteins.
So what is the implication on the phosphorus to protein ratio? We know that protein intake will be low. They are coming.
So protein intake is low, but if we tell the patients to look for the phosphorus to protein ratio, then they can obviously they can select the foods which are adequate in protein but that are low in phosphorus, and especially the food additives, the phosphorus from the food additives which is 100% bioavailable, means from the processed foods or food based additives, has to be avoided.
Yeah, that
So
same
that
question I want to put in a different way.
Okay.
Like in the plate of a patient of CKD, what are the natural foods you want to avoid that? Yes, this is high in phosphate, or what are the ready-made foods or processed food which you say this keep away from this, or what are the beverages which are high in phosphate? You tell yes, keep away from this.
Yes, sir. Valid question. As I was discussing the foods additives, like the beverages, yeah, cola and or instant food items or the processed foods, they are rich in phosphate based additives or the inorganic phosphorus which is readily available. Any food, if any food preparation which is having high level of phosphorus, like in any carbonated vegetables and the cheese and cheese spreads and instant food, so they should be away from the processed foods and processed meat, but they can go for various cereals, pulses, low fat, जो vegetables हैं, vegetables हैं, potassium, low potassium vegetables हैं, they can have in the diet, because usually they are less bioavailable, so they can have enough of vegetables in the diet.
So about potassium also, about calcium. Calcium will have other implications like along with phosphorus, bone mineral density, a lot of other issues are there.
Yeah.
So this is a ion with a clearly attached with a chronic nutrition deficiency.
Yes,
so
sir.
what is
So-
your comment about that?
Do you
So
want to
no,
comment?
no. I just wanted to make it different way.
Yeah.
So tell me about the bone health of the CKD patients, because you know that general population there is a calcium and bone mineral deficiency of up to 80% has been seen. So how to address that? How much calcium and what are the sources, and what should patient exactly look for his in a diet or in plates, that what is the recommendations?
Right. So actually, in CKD patient, the bone mineral disorders are very common, and the calcium and phosphorus homeostasis is altered even in the early CKD stages, and it progress at the GFR starts declining. And once phosphorus is in the diet increases, the calcium automatically decreases, which and secondary hyperparathyroidism PTH level is high. So we need to counsel our patients to have low phosphorus food products without compromising the protein intake. So restricting the non-protein sources of phosphorus is very very important. Regarding the calcium intake, it should be around 800 to 1000 mg, including the dietary phosphorus as well as phosphate binders and from the phosphorus supplements. So as early Shilpi said, ki we have to take a good diet history from the patient, so that we can calculate the phosphorus, we can calculate the calcium in the diet. Then accordingly we can see if patient is having very low intake of calcium, then depending upon the choice of nephrologist, they can suggest calcium supplements, or if hypophosphatemia is still persists, then depending upon the level of the phosphorus or calcium, they can use either the calcium based or non calcium based phosphorus. And vitamin D, if vitamin D deficiency is there, then they can be supplemented with vitamin D supplementations. And as you put questions about the bone health, then regular physical activity and some sort of
Weight bearing exercise is a must for our patients. And nutritional vitamin D, they should have some degree of sunlight exposure early in the morning with less clothing and without any sunscreen.
Yeah, there are some more pertinent questions. I request Dr. Bharti to come.
Yeah, very good evening. So सुबह से बात हो रही थी कि there is a friendship between heart and kidney. So here are two basically gastroenterologist पेट वाले डॉक्टर बैठे हैं to make a friendship with the गुर्दा वाले डॉक्टर. So just to continue the session, I think the water balance is very very critical in patient with the chronic liver disease. How much to take, and in some patients in critical conditions there is just 500 ml of water is to be taken. In some patients we have to just take a 1 liter, 1.5 liter. So how to basically categorize specific? So Renuraj, would you like to comment on this?
Yes.
Fluid balance and water balance, how to basically cater water in these patients?
Good afternoon to all. Fluid management is main aspects of renal shutdown patient, but initial stage there is no need of restrictions. Patient who needs his or her first she or he take about as per body requirements, but decline of GFR we can reduce their intake of water or fluid, but fluid only form of water, not a fruit juice, soup, others liquid like food substances.
Okay, so how to exactly calculate, like ये जो खाना खाते हैं हम लोग लंच में डिनर में
If
उसमें
patient
take
are
वगैरह
oliguria,
कैसे करेंगे?
then we must restrict their water intake as per previous day urine output plus 500 ml fluid intake as per patient urine output.
So to continue this, I think one lecture from the pediatrics has been taken. I was very happy because I'm from pediatrics background, and Dr. Sanjeev Gulati has told that just 0.8 to 1% population of CKD is from the pediatric population. I don't know, is it really correct, or we are missing many of the cases of CKD, and they are going silently through the infancy to the childhood, and they are presenting at the adulthood. So
Yes, sir. If patient weight is 70 kg, their 80% of water is in his body, but their weight is water weight is 40 kg, 40 liter. So their need of water is.
Renuraj, continue in Hindi, no issues at all. No? I think you can continue. Huh?
If patient weight is 70 kg, their fluid in body is 40%. Their 80% in body there is need of water is 40 liters, but extra fluid if body retention is form of sodium or chloride or water retention in body, pedal edema or body edema, pulmonary edema, then water restrictions is must.
Achana, you want to add on something?
To just summarize, what she want to say is that the ideally the fluid, the thumb rule is that the previous day urine output plus 500 ml is to be given. But as Bikutta sir was emphasizing, weight monitoring is very very important, because if patient has recently gained weight or developed some congestive heart failure, then it means patient is having fluid overload. So it varies depending upon patient to patient, his urine output, and we need to take a diet recall, because fluid means not only water but whatever liquid he is taking, doodh, chai, pani, dal ka pani, gravy, all these and the weather conditions also. Yes, if patient is having from a hot climate and the season winter hai ye, all these things has to be taken into account, because this is highly individualized. It should not be over restricted, and physically we had to look for the physical signs. If pedal is now edema is there, and if the patient in dialysis, then intradialytic weight gain is also one of the important component.
Yeah. So continuing with the questions, uh, in children, actually, I was talking. So regarding the diabetes mellitus onset in children, slowly and slowly, a lot of cases of the diabetes in pediatric population is being organized, and the chunk of the CKD diabetes there is around 30 to 40%. So I think to progress the halt the progress of the CKD in children, to basically delay the progression of the disease in children in diabetes, what precautions should be taken to maintain the glycemia? So who would like to
Yes. So 1.9% टाइप 1 डायबिटीज का प्रेवलेंस है हमारे यहाँ इंडिया में, एंड 4.8% इज टाइप 2 डायबिटीज। एंड डायबिटिक किडनी डिजीज बच्चों में काफ़ी समय के बाद डेवलप होती है या डायग्नोस होती है। इवन ये एडवांस स्टेज में पता चलता है। तो इसके लिए बेहतर यही है कि हम स्टार्टिंग से ही ग्लाइसेमिक कंट्रोल पर ध्यान दें। यानी कि बच्चों की जो हम टीचिंग देते हैं डायबिटीज़ एजुकेशन की है, या हम उन्हें कार्बोहाइड्रेट काउंटिंग बताते हैं, या हम उन्हें लो ग्लाइसेमिक इंडेक्स फूड के बारे में बताते हैं। प्रॉपर न्यूट्रिशनल काउंसलिंग उनके लिए बहुत ज़रूरी है। साथ ही साथ जो उनका हम ग्रोथ मॉनिटरिंग करते हैं आईएपी गाइडलाइंस के थ्रू, वो हमें उसको प्रॉपर करते रहना है। प्लस जो उनका हम रिक्वायरमेंट है वो आरडीए के अकॉर्डिंग ही देंगे, उसमें हमें कुछ भी मिनिमाइज नहीं करना है।
Yes, just to add on, actually there is a all free growth charts are available till 5 years, and after the 5 years, because worldwide till 5 years of age, there is same growth charts is applicable for all the children worldwide. After 5 years, there is a individualized growth charts for the individual countries. We have India has also a growth charts for children from 5 to 17 years, which has been basically published by the Indian Academy of Pediatrics, and all these growth charts are available free on internet WHO website. I think all these children must basically go growth monitoring at very regular basis, because the growth faltering is the one of the earliest feature for the CKD. Of course, you have to rule out the malnutrition and other endocrine causes to rule out before going to the CKD, because it's being very, very less. But if there is no malnutrition or endocrine or gastrointestinal causes is there, you must think of the is there any underlying cause for the CKD? Because one problem is that I don't know, you must be agreeing there is very less number of pediatric nephrologists in our country, and calculating the EGFR in children is very, very difficult. So maybe we are missing that children. So that is very, very important. This is just my so taking this further, diabetes to the in adults. So adult population with the CKD. So already is there. So how to basically strictly monitor or to prevent the progression of the disease in adult population with the CKD in diabetes? So who would like to take this?
Yes, for diabetic CKD patient, if we'll talk, so it is a very important thing just to monitor the blood sugars regularly. What we have seen in our OPDs, patients are missing the blood sugar reports, because they are thinking ki, if one sugar is okay, then whole the week or the 15-day sugars will be okay. So it is very important to monitor the blood sugars very regularly, and to discuss with the endocrinologist and to meet to the dietitian for the dietary counseling. Along with that, there are some thumb rule for the diabetes control, and that the first thing is regular monitoring of blood sugars. Second thing, to do the diet and exercise modifications. So dietary intervention, it is very important to for CKD patient, if we'll talk, its carbohydrate should not be less than 60%. We are talking about the protein and the fat and other things. The carbohydrate we cannot make less than 60% of total calorie, because this is the major part that this will give the major part of the our calorie. And second thing, the more of that in the dietary supplement or in the dietary intake, it should not be
simple sugars like chini, mithaiyan, gud, shahad should be avoided along with the fruit juices. And sugar-free products, that is the culprit. We have seen the market is full of sugar-free sweets, sugar-free biscuits, sugar-free atta, sugar-free aloo, sugar-free chawal. Everything is available. But I would request all to my uh, dietitians or to the nephrologist also, do not suggest any sugar free products because it contains preservatives as well as the high fat intake. So it is very important not to go for the sugar free products. And along with that, the carbohydrate should be complex carbohydrate. Rice should not be restricted for the diabetic patient at all. 2 times rice can be given. माड़ उतारने से, चावल का माड़ उतारने से उसके स्टार्च पे या उसके कार्बोहाइड्रेट पे मैक्सिमम टू मैक्सिमम 5 to 10% का कमी आती है. And that will not increase much of the sugar. So it is very important to increase the palatability of the patient. We have to give the choices of the food. So it is very important that complex carbohydrates should be given, and insulin and OHA. If the patient is, it is also seen that patient is not willing to take the insulin. It is very important कि एक बार का ले रहे हैं फिर नहीं ले रहे हैं. So it is our duty to encourage to patient to take the insulin and OHAs on time to control the blood sugar, and dietary along with that some exercises. सुबह उठ के 5 बजे 6 बजे exercise करने जाना है, walk करने जाना है. It is very difficult for a deceased and for a normal person also. So exercises can be done in the evening. That can be done in the walk or yoga or some other exercises, whatever is comfortable for the patients. So these are the basic things that can control the hyperglycemia. And hypoglycemia is very much seen in the diabetic CKD patients due to the reduced renal gluconeogenesis. It is very important to monitor, and small frequent meals should be given for all the diabetic patients. That's a very important point.
So hypoglycemia can be more dangerous than hypoglycemia. So that must be avoided
Because
very
patient
carefully.
can be go in coma.
Yes,
So
yes, we
and
can.
there is need of then sugar. The management of the hypoglycemia is, if it is less than 70, then we have to give 3 gram, 15 gram of carbohydrate in form of sugar or glucose. That may increase the later on the sugar level. So again is the worry. The burden of this hypoglycemia will continue for for 1 week at least. So it is better to control the blood sugar, not very high, not very low.
Yeah. So coming to again to my own topic, like since morning there was a very good deliberation on the microbiota and gut dysbiosis. So many studies has shown that in all the chronic diseases there is a change in the gut microbiota from the good bacteria like firmicutes and proteus and bacterioids to the basically E. coli and other bad bacteria. So the finally to change the whole microbiota, what people are basically doing the microbiota transplantation. But other measures which people are trying is like giving the probiotics or prebiotics, and apart from that, giving the good amount of fiber. That we had two types of fibers: soluble fibers and insoluble fibers. The insoluble fibers, as told in the morning, it goes to the colon, it changes into short and fatty acids. Then these butyrates is being act as a direct energy source for the colonocytes, which basically becomes healthier, and the good microbiota basically increases in the gut. So continuing the same question, so how much fiber and what food which are rich in fibers to be taken per day by patients of CKD to basically make his microbiota good? So who would like to take this question?
I'll take this call, sir. Fiber. It's something like, as sir has said, that fiber is somewhere related to our GI, gastrointestinal tract. So somewhere or the other where it's not coming into our reports, the first thing, it's not coming as a creatinine or a bun or it's sodium potassium. It's not reflecting in that. So somewhere we relate it like the patients with the CKD, they are more having like nausea, vomiting, aversion to food. So fiber is something like which is not being spoken about more, and we are not talking more about the prebiotics and probiotic health of the patients. So as being a dietitian, please always if the patient's reports are looking normal, if the patient is having like stage 3, stage 4, and the potassium is into the range, phosphorus is into the range, because as I said, the patients are having nausea, vomiting, these all things are present, just have variety in that their food. Be one pieces of carrot or one pieces of cabbage, or either your cucumber or mooli, that it will actually enhance the flavor of the patient. It will actually complete their thali. It will have either we are able to complete their fiber content, and the patient will have the some options to have. Do not completely cut off each and everything, because usually we see fiber is coming from the, as we know, it is coming from the basically from the plant source. Or if we are talk about the probiotics, it will be coming from the the usual the example is curd. So because of the phosphorus level, because of the potassium level, we are cutting down them. So just look at the reports and always have a follow up. Maybe at one report the patient is having the high amount of their potassium is running, so we've restricted everything, like we have restricted like do not give fruits, do not give such things. So maybe in the next follow up, and the patient will keep on following it कि भाई पिछली बार मैडम ने बोला था कि ये चीजें नहीं खानी है, एंड इट बिकम्स लाइक प्लेज फॉर देम कि उसी चीज को फॉलो करना है. तो आस्क द पेशेंट्स टू कम अगेन विथ देयर फ्रेश रिपोर्ट्स, which is very important, and add variety. Portion control is the key. Always portion control is the key. Add variety to the patient's thali. Look on the reports, what the patient's reports are going. Add curd to their diet. Maybe we are having some allowance. It's not like that the patients cannot have milk in any form. They can have a little allowances there, because we have to complete the protein requirements also. We have to complete the calories requirement also. So if we have to add probiotics, just as said, sir has said, the fermented products, ask them to take in a fermented way, like suji can be dipped into curd and we can leave it overnight. Again, the patients will be having variety. Why to go for dalia? Why to go for that only roti and sabzi? We can have variety, and we are the experts of it. You should add the, as per the patient's report. Maybe the patient is having constipation, we are not giving anything, no husk is being given, no green leafy vegetables, no fruits. What the patient will eat? Only roti and sabzi. Again, sabzi may be, we are at times we are doing leaching also, so the taste is completely gone. So always think from the patient's prospect. It is not dengue, it is not typhoid that the patient will recover in next 15 days. It is something the patient has to live with this thing. So always keep the follow up, keep the reports into the hand, and look for the symptoms also. Like if the patient is having pitting edema, again you can you check the legs of the patient, you check the eyes of the patients. If there is a puffiness, again the patient is having fluid, maybe fluid overload. So always call the patients for the follow-ups, always check the reports, and add as per the allowance. Go for the reports and add the things to the patients in a different way. We can suggest the recipes in different way. They can add it into their diet. Thank you, sir.
Okay, thank you, Preeti. Sir, since we are nearing the end of the session, so my last question is to the panelists and for sir, everyone also. Like, if you see that the in the market process, ultra process, restaurant food, they are hugely progressing, and at every home, every alternate day, sometimes weekly, twice, thrice, people are going for eating outside. So I will take the example of a like 24, 25 years old young boy who has graduated from the IIT and who has been diagnosed early CKD. His GFR is around 60 to 70, but he's living alone. He don't have any choice for food. He's having the burger, pizza, processed food. So, what are the recommendations for these children who don't have any choices to basically not to further progress the CKD, and how to curtail their basically these foods, and what recommendations to be given individual or through the NGO level or national level to them? Thank you, sir.
May I
Anyone
answer,
like to
sir?
contribute?
May I
Yeah.
answer, sir? Sir, first food labeling is very must. Before eating something, just see the packets label, ki how much sodium, how much potassium, how much calorie and protein they required. And for these patient being a dietitian, we should give the exchange list. If he is taking a 200 of milk in exchange of 200 milk ml of milk, how much piece of chicken or fish, whatever he want to have, he can have. He can exchange with the exchange list, so diet will be more easy in outside of the home.
So number one is the, I think, sir, our this nutritional level fact should be, I think maybe it should be improved more better to having the more emphasis on the electrolytes, phosphate, because many of the food labels. So maybe all these organizations, including can write to the FSSI, and we can have better food labeling system to basically maybe to make more aware of the children. Sir, I think I I need your comment on this also, sir. This question.
He want
Yes,
Georgie sir or
yes,
Amit
sir.
Gupta sir to answer
Both,
this
sir. I
question.
think this is a very pertinent question. I want, yes, sir.
No, I think most important thing is education. And as you rightly pointed out, is to educate the public about the need
Yeah.
to sort of be aware as to what they're eating. And number two is that this boy, unfortunate boy, you're saying living by himself, he has to learn the skills of cooking. I mean, yeah. I mean,
Yeah, yeah, yeah.
that's the plain simple thing. I agree with what Amit has said that now in my household, since we have no helper, I have also started cooking to help my wife. You know, I do the simple cooking and doesn't add any much salt because I am a person who likes salt, but I am restricting my salt. So somebody who is living alone, and they should also, because there are so many young Indians who are going abroad and they want to live in developed countries, and some of them have chronic kidney disease early stages, and they have to sort of permeate into a diet which is both useful for them to prevent malnutrition. At the same time, they shouldn't be going and eating all the potato chips, which is very high in potassium content. They also add salt to that. So these are some of the things this young man should. And look at Biju sitting there. Biju and his wife are a powerful model for me because she is a nephrologist, where I see that, they are so disciplined in their life and eating their food, and I have seen them, how they function themselves. So we all need to know something about cooking. At the same time, we shouldn't be eating everything what we need. And this young man who has chronic kidney disease, he should learn and he should be disciplined by the help of a expert nutritionist who is a renal nutritionist.
Thank you, sir. Thanks a lot for your comments.
Thank you, sir.
So can we take one or two questions, audience? Anyone? Yeah, if there is no question, thank you. Thank you.
Okay.
Just one thing, the immunonutrition and the probiotic, they are safe. Probably in the chronic liver disease, we have done 2 randomized studies. Probably the first Indian data, 214 patients of 108 patients. They are safe. It reduces IL-6, TNF alpha. These are the inflammatory markers. Increases IL-10. Okay, it increases intestinal permeability markers are altered. So they are safe. I think although our data is from chronic liver disease patient, there's no reason why it cannot be applied in kidney disease patients also. VSL3 is widely available. Frozubin Onco is widely available. So these are safe. Okay, except one diarrhea, no adverse event was reported. Just wanted to thank you.
Add, being nutritionist, we should put do's before don'ts. Rather than giving a list of no, 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 no list, we have to first tell them yes, 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 yes list, so that the compliance अभी patient confidence ही नहीं आता है. तो जैसे बोला monotonous नहीं होना चाहिए. We should provide lots of recipes through them. We should provide lots of variations in the diet rather than ये नहीं खाना वो नहीं खाना. And one point जो छूट गया है, it is regarding the dietary fat. There is nothing like ubla hua khana. Let them maintain the taste. We should be, it's not only the science or the guidelines we are following. We should also deal with tactfully. We have to deal with all those patients. We have to make the food very palatable, very nutritious. And as Gulati sir said in the morning, we have to negotiate with the patient and especially with the kids. So give variety. Thank you.
I thank the panelists and the moderators for the thought-provoking panel discussion, and I request you all to please proceed for the felicitation. Thank you. Please give them a big round of applause. Thank you. And now's the time to invite the chairpersons for the next talk. And I'm delighted to invite Ms. Sunita Saxena, Chief Nutritionist, King George's Medical University, Lucknow. Ms. Zamrud Patel, Chief Nutritionist and Head HOD, Global Hospital, Mumbai. Ms. Ranu Singh, Community Nutritionist from Lucknow. Ms. Rama Tripathi, Senior Nutritionist, SGPGIMS, Lucknow. Mr. Azam Khan, nutritionist, CDE, and regional manager of Diabetic Educators and Dietitians, Kartavya Healthy On Private Limited, Lucknow. I welcome you all on stage. And we are ready to invite our speaker, madam. I request the chairpersons to do the honors.
Hello. I would like to introduce the speaker, Ms. Himani Puri. She is founder, proprietor, Sattva NutriCare, Chief Dietitian at Apex Hospital, Nasik, Program Officer, IPN Renal Nutrition Core Group, Chapter Secretary, IPN Nasik, and Secretary, Nasik District International Human Rights Organization. And she is editor at Healthcare and Medicine for Online Bulletin and TV. Thank you, Himani. Please welcome Himani Puri.
So, good afternoon, everybody. Thank you so much for the organizers for having me here. And I hope everybody is not sleepy. So, since we are towards the tail of the program, it's been 2 days of good information, plenty of information, and a lot of discussions and contemplations happening here. And we have been talking about guidelines a lot, and I'll be going into the practical aspect of the guidelines now. This is something which is much needed. How much protein to give, how much calories to give, that everybody knows. But how do we convert it into the plate is actually a question for everybody, for a dietitian, for a nephrologist, and for the patient as well. So before we do that, the most important aspect that is there for us is we need to understand what the patient is taking. And as per that, we recommend the patient what he has to take, right? So I'll be talking about the dietary intake aspect of the nutrition here. So before that, once again, I would like to invite you all for the upcoming event next year. We would be having the ICRN with SRNM and the RNI annual conference. Hope to see you all in Hyderabad in 2024. So nutrition diet is the prime important or the first factor of the management of a patient care. We talk about the assessment and then we do the counseling. Then we re-evaluate, we reassess, and then we re-counsel the patient, correct? We talk about the medical history, we talk about the medical history background, we talk about what the patient was taking in the medicines, how his health has been in the past year, past 6 months, and so on. We also talk about the patient health in terms of the caregiver aspects for the patient care here. We talk about the BMI, we talk about the body composition, we talk about the waist measurements, we talk about the weight change, gain or loss, but we also talk about the dietary habits of the patient. So, assessing dietary intake of the patient is a very crucial aspect, as I said, because that forms the basis for what you are going to give to the patient henceforth. And what are the management or the goals of the nutritional management? You talk about controlling uremia. You talk about progression of slowing the progression of CKD, about improving the quality of health, ensuring a better dietary intake, ensuring a better nutritional status. So should I call it nutrition management or should I call it dietary management? Right? Because nutrition is coming from the diet that the patient is going to be advised. And therefore, for me, this dietary assessment is a big treasure, a Pandora. The more I talk with the patient, the more findings I get, the more easier it becomes for me to explain it to the patient. For example, there was a patient who was coming to me with hyperkalemia, persistent hyperkalemia, first visit, second visit, third visit. After a lot of discussions, deliberations, what I found out was that the patient was consuming low sodium salt. Biggest reason for the patient landing up into hyperkalemia. Forget about the leaching of the vegetables, forget about restricting the potassium rich foods. What was the major reason here? The low sodium salt. So, as I said, this is a big Pandora box for me where dietary assessment and discussion is concerned. So, there are two ways in which I can do dietary assessment. One, you talk about the patient's medical records and you talk with the patient or the caregiver here. So when you talk about the patient medical records, we talk about their previous diet, if they were taking any, if they have any food allergies which are being listed in the diet, in the previous diet chart, or maybe a prescription which is coming from the nephrologist. You talk about the previous diet diagnosis, you talk about the previous interventions, and maybe the previous records of diet history which were being maintained by the patient. And when we talk to the patient or the caregiver, we talk about the number of members in the family, whether the patient is having any restrictions where the food intake is concerned. As there was the question in the previous talk, that the patient might have to learn to cook himself, correct? But what if the patient is not able to because of certain limitations? Then what do we do? So, that also is something which we need to be taking into consideration and talking about. We need to talk about the patient's usual weight, the recent loss or gain in the weight, his likes, dislikes, his religious beliefs, whether he is able to assess the food sources also. So, this further comes into various categories of dietary assessment, which we can categorize as to talk about diet order, whether the patient has any records from being transferred from one facility to another facility, whether he has any allergies or intolerances, whether or not the nutrient intake is being balanced or imbalanced, whether the patient is on an oral feed or a tube feed, or maybe on a parenteral support, whether the patient's appetite is good or no, because a lot of renal patients come to us with aversion for food and nausea complaints. Whether the patient is able to take a usual diet or we have to give him a soft diet or a semi-solid diet, whether the patient is physically active, whether the patient is able to swallow the food, chew the food well, and is he having any other complaints like dysphagia or oral sores. Again, certain other social factors, the education level, the occupation level, and the income plays a big role. I have to give 0.8 gram of proteins. Fine, I can do that. But if a patient is coming from a high income group, I have liberty. But if the patient is coming from a low income group, I have to cater to those same criteria but with a limited resource. So, therefore, it's very important that I consider the patient's economic status. A lot of times I get asked a question कि मैम जो डब्बा आपने हमको दिया है वे प्रोटीन का क्या वो आप सब लोगों को दे पाते हो? And my answer was no, I cannot, because not everybody would be able to purchase it. And that is where your skill, the dietitian, comes into picture, that you manage those calories, you manage those proteins in that limited budget of amount. Okay. The other is at eating habits and patterns. Somebody is working in a night shift, somebody is working in a morning shift. So again, your pattern of intake changes. For somebody, I have to give them their evening meal at 6, but for somebody, it is 10 p.m. Then we also have people coming with intermittent fasting. We have patients, as was discussed earlier in the day, with keto diet as well. So these patterns also come into play when you're talking about the diet of the patient. So, as a dietitian, you should be able to tackle them, take out the information from the patient, and put it into your practice. So, how do you do that? Start asking questions. The more you ask, the more answers you get, and the more easier it becomes for you to plan a diet. Trust me. So, what you do is first simple question, be very subjective. Do not give MCQ questions, but let the patient answer on his or her. Don't break the flow with the patient. So, क्या आप खाना खाते हो? Of course he does. हमको भी पता है. But you know, it is a way of communicating. So, do you eat? What do you eat? Then, what do you think is a healthy diet for you? Are you feeling healthy with the diet that you are taking right now? Do you have your breakfast? Do you have your lunch? Do you have your dinner? What time do you have it? How much quantity you have? What do you prefer to have? Do you snap snacks? What time do you have snacks? These are all very subjective questions. And the more easily or more fluently you ask, the more better answers you get, and more simplistically and fluidly you will be able to plan a diet for the patient. You ask about the non-veg intake, about the veg intake, whether so we were discussing in the previous talk that there are five varieties of non-vegetarians. I say there are seven varieties of non-vegetarians. Somebody who eats non-veg with alcohol, somebody who eats non-veg only outside, somebody who eats non-veg only on Wednesdays, Fridays, and Saturdays, and then somebody who has eggs but only in cake and not otherwise, right? So this variation is coming to you, and then that is how you are dealing with the patient according to their preferences. Talk to them about their medications. People do take Ayurvedic medications also. They come with a lot of homeopathic medicines, Ayurvedic kadas and Ayurvedic churans, which somebody has told them कि अरे ये खाओगे तो अच्छा होगा. There was a lot of WhatsApp message going on about coriander. धनिया का पानी पीने से creatinine function कम हो जाता है, right? So this misinformation is something which the patient might forget to tell you that he is doing. Again, you ask and you get the answer. So when talking to the patient, focus on the protein, phosphorus, potassium, sodium, and the fluid intake of the patient, the hidden sources of these nutrients. Evaluate the dietary pattern, their food diary if it is coming to you. Assess for the macronutrients, assess for the micronutrients. Try to explain to the patient what is going excess and how it is going excess and what can be done to reduce the quantity. Assess the patient for any special needs for vitamin D, calcium, iron, because we know that renal patients have these parameters gone up and down haywire. Talk about the fluid intake. Chai mein, the cold is on, and we sort of teacups flowing in and out. Lot of coffee being consumed outside on my left and on my right, both the sides. So these all become sources of the fluid intake. So discuss them with the patient. Try to limit it as per the requirement. Then, after you have all this assessment, break it into the food groups. Analyze the macros and the micros based on these food groups. This is the broad category of the food groups. Talk to the patient about the healthy plate. Discuss where he or she is going excess, and then try to modify it and adjust it as per your requirement. Assess the diet based on the portions. Classic. One hand works the best. The thumb size for your teaspoon and your tablespoon, the palm size for your chapati size, for your rice size, the fist for your sabji or the vegetable or your dal size or your curd size or your protein size. Explain the patient and ask them what portion they are consuming and how much portion size they are consuming, so that it becomes easier for you to go back and calculate your macro nutrient intake with the patient. Okay. So a lot of dietary assessment tools are available on for us to use. We have a food frequency questionnaire. You can ask open-ended questions like I told you in my previous slides. You can take a 24-hour diet recall. You can take a 3-day recall. You can take a 7-day recall. You can take a food diary or maybe a month-long recall also. Whatever works best for you. But make sure if you have asked patient to take a 3-day recall, spend time and review it. A lot of times what happens is we get it done from the patient, but then we don't review it ourselves, which is wrong. Okay, so do that. There are other tools like HEI tool or the Healthy Eating Index tool available. We have the latest version of 2022 available, which again can be used as a source of dietary assessment questionnaire. A lot of toolkits are now available online for the dietitians to use. You have the Nina Dash software, which was supported by Novo Nordisk. It's freely available on the net, and you can use it for the dietary assessment. There's a DAPA measurement toolkit, which is UK based. Then you have a National Cancer Institute toolkit, which is basically for cancer patients, but then again can be used for the renal patients also. We have the Acheron method selector for dietary assessment, and we have the Danon DAT tool, which is again a very good and easy to use tool for the patient dietary assessment. So remember, successful implementation of a diet would only happen with the engagement of the dietitians who are trained well specifically in the renal care and who know how to modify, modulate, and ask the questions and get the information from the patient. Assess the regular intake of the dietary intake of the protein and the energy. Maybe go for biochemical parameter, the 24-hour urine, if you want to assess the intake and the output and utilization of the food that is being prescribed. Use telehealth. Post pandemic, people have become comfortable with telecommunication. Use it to communicate with them, discuss with them, be in touch with them, so that again we are able to give the best of the best to our patients. So first 3 months are challenging for us as a dietitian, for a nephrologist, and for the patient also, because it's a transition from the kuch bhi chalta hai, anything you can eat, to regularized and monitored eating. So this is basically when you are teaching them, educating them about the kidney specific foods or healthy foods, and thereafter it becomes more of assessment and improving the health of the patient. So educate, re-educate, assess, reassess every time the patient is coming to you. Maybe if the patient cannot come to you for a special visit, try to match your visits with the nephro visits so that the extra rounds of the patients are safe and you are able to get a regular access of the patient's health and improvement. Maybe plan up monthly or tri-monthly follow-ups. Maybe go for a weekly or a bi-weekly telephone calls if you want to, or maybe appoint a social worker. Just a phone call. कैसे हो, क्या चल रहा है, diet चल रहा है क्या अच्छे से, is good enough to get a good answer from the patient. So positive impact is very, very important, and it helps us give an accurate interpretation of the daily intake of the patient's diet, and helps us to assess, and also helps us to keep the patient on track where the medical nutrition therapy is concerned. So focus on individualizing diet, patient or caregiver centric, with regular follow-ups and adjustments to support optimal renal health, and then we would be able to target our challenges. So therefore, accurate nutrition, education, meal planning is very, very important for us. Behavior change is important. However, the saddest part is that the patient is coming to dietitian only when he or she is going on dialysis. The focus has to be shifted, the trend has to be shifted, and we have to go into the prehab phase, try to make the patient go into the dietary pattern even before he or she is on dialysis. So with this, I finish my talk. So macro is one part, but we should be also looking at the sodium, the potassium, the fluid, the phosphorus, and the fiber intake where the patient is concerned. Thank you so much. Yes.
Thank you very much, Himani. It's a wonderful talk. Any question from the audience?
Either everybody is sleeping or I was too good in my talk. So
Post lunch session, so maybe.
yeah. So there's a question. So, sir, micronutrient is very, very challenging because macro is still easier because we are talking about we know it's a global that 1 gram protein, 1 gram carbohydrate, one fat is what we know. But the micronutrient or the potassium content, sodium content differs from geographical to geographical location. So when I'm using these tools, this is talking only about the assessment of the food, about what food the person is taking. This does not talk about the evaluation of the micro or the macronutrients. For that, I would still try to depend on the NIN data, because the potassium content of India is going to be different from the potassium content of a potato in US or Europe. Yeah. Yes.
This is very general question, means I'm asking to every dietitian over here. There's lot of changes in the nutritive value of Indian foods as we compare to the previous booklet and now 2017. We were, even हम लोग IFCT 2017. So अभी क्या है कि सारे जो भी fruits and vegetables है, they are having quite high amount of potassium, जिनका it was less than 100 mg per 100 gram. But what our experience says, even we put our patients on these fruits like seb, amrud, nashpati, banana, they are able to maintain a good means the potassium level within the range. So, what is our take is we should not restrict all these fruits and vegetables in the diet of our patient. So, what is your take on the new IFCT 2017 regarding this, especially in terms of potassium? Another one thing is if you look for the phosphorus values. Previously, it was saying that the छिलके वाली दालें was almost 3 times higher in the phosphorus content as compared to without छिलका वाली दालें. But if you go through 2017 phosphorus value, it is almost same like छिलके वाली दालें even if you are giving or the बिना छिलके वाली दालें. Then what is your take or your experience for the patients who are not on dialysis for these patients?
See, where this renal patient is concerned, my prime importance is looking at the biochemical parameters. If the values in the reports are good enough, what I am doing is good. One. The other thing is that, of course, as I said, with geographical situation or condition, the potassium content, the sodium content differs. In fact, even if the water which you are going to use for irrigation has a high sodium potassium content, the potassium sodium content of your vegetables like carrots and potato is going to get affected. Okay, so we cannot rely 100% on that, because in India the farming or agricultural system is very varied, and therefore again I depend upon my reports which are coming. That is one thing. Leaching does not help. Okay, there have been research papers now which say that restricting too much of potassium in the diet is actually not going to help you reduce the potassium levels in the serum. It's not the only one factor. Of course, you try to limit it, but then you cannot go into a complete restriction of the potassium intake. That is one. For the phosphorus, see, the values which we are getting now are basically or calculative, I mean, laboratorical values. So what we are getting now is also accurate, and what we were getting then also should be accurate. So I cannot comment on that again. But again, restricting the dals because of the high phosphorus content is not something which I would advise. I would prefer to go for non-veg source restriction where phosphorus is concerned.
That's what I am saying. Even I'm not talking about the restriction of dal. I'm what I am saying is like छिलके वाली dal and the without छिलके वाली दालें are almost now equal in
You can
phosphorus
see, I
content,
don't
so we
restrict.
can allow
Correct.
every dal to our patients
See,
rather than
normally
restricting it.
what happens is CKD patients also come to you with a high uric acid. So you have to look for the purine-rich food sources there. वहाँ पे I'm not going to look at the whole pulses or the split pulses where the phosphorus is concerned. My concern would be the purine-rich and not the phosphorus coming from a split dal or from the whole dal. So I do definitely give the whole dals or whole pulses to my patients there.
Sorry for interruption. Now the session is closed on.
Thank you so
There is
much.
shortage of time, so there is no question. Thank you so much. Thank you, Imani.
Thank you, ma'am. And request you for the photograph. I request the chairpersons for the photograph as well. And finally, we have entered into the last talk, and I am grateful to invite on stage the chairpersons, Ms. Saurabh Vibhushan from Lucknow, Ms. Deepti Rawat from Lucknow. Please put your hands together. Dr. Induja Dikshit from Lucknow and Dr. Smita Singh from Lucknow. I welcome you all on stage. So we have the beautiful faces and intellectual minds on stage, and I hand over the mic to the chairperson for introducing the speaker and the topic. Thank you.
Okay, so now we are into a very nice deliberation, which is on medical nutrition therapy in CKD and focusing on the cardiovascular diseases, which is a little bit different from the topics which we've been learning from since 2 days. So I would invite it to be delivered by my very good friend, Dr. Ritu Singh, who is an RD also and consultant nutritionist, Jagrani Hospital, Lucknow. She's been working from last 23 years in the field of clinical nutrition and dietetics, completed doctorate degree in 2012, qualified exam of registered dietitian 2015 conducted by IDA, and supervising and conducting clinical research and presenting them on various platforms. She worked as an academy faculty in Lucknow University and GL Gupta Institute of Public Health, organizing internship programs for students of clinical nutrition and dietetics, and also an active participation in dissemination of current nutrition research through various platforms. So I invite Dr. Ritu Singh. Thank you.
First of all, thank you for inviting me and giving this nice, beautiful introduction, Smita. A very good afternoon to all of you. And I am thankful to organizing committee of Society of Renal Nutrition and Metabolism for allowing me to present my ideas on the topic medical nutrition therapy in CKD, focusing mainly on cardiovascular risks. Okay. Okay. This is the overview of the my presentation. I'll start with the correlation between cardiovascular diseases and CKD. British physician Richard Bright first found that there is a strong correlation between the vascular diseases and the patient with kidney diseases. He found that around 50 to 60% of kidney patients with stage 4 and 5 have cardiovascular ailments, and out of them, around 70 to 80% die in the end of the disease process with cardiac ailments. So, the main factors which are responsible for vascular diseases are uncontrolled hypertension, dyslipidemia caused due to altered lipid metabolism, uncontrolled diabetes, obesity and overweight if the patient is, and the high protein diet in the kidney disease patients, especially in CKD stage 3 and above. And apart from this, smoking and physical inactivity also play an important role in development of vascular diseases in CKD patients. So, what is the internal milieu of the disease? Actually, these are three organs which are interrelated. If we go to the pathophysiology of the disease, if there is kidney disease, there is uh, uh, inflammatory process going on inside the body, which causes the luminal injury and the fibrosis of the myocardial tissue, dysfunction of valve that represents in the cardiovascular disease. So, what should be the medical nutrition therapy if we are aiming to reduce the risk of cardiovascular diseases in the patients with kidney disease? Basically, medical nutrition therapy is the personalized plan which is made according to the patient's nutritional need, taking into consideration the physical signs, the biochemical parameters, the clinical symptoms, and the dietary preferences of the patient. So usually when we talk about MNTs, we start with calories, then protein, then fat, and so on and so forth. But I have taken the privilege to start my topic from salt, because the main culprit of cardiovascular diseases may be salt, because it is involved with the fluid overload mechanism. And as we all know, if there is fluid retention in the body, there will be uncontrolled hypertension, which will lead to ventricular, megaly and cardiomegaly, and ultimately lead to cardiac malfunction and cardiac arrest. So, salt intake should be counseled first when you are talking to the CKD patient, and every patient will say, no, I don't take too much salt, मैं नमक खाता नहीं, ऊपर से मैं सलाद में नहीं नमक खाता, मैं कोई नमक नहीं खाता. But if you will do the urine analysis of sodium, you will find that they are having around 7 to 8 grams of salt, that is around 5 gram of sodium. The recommendation is 3 grams of salt in CKD with 1.5 milligram, 1.5 gram, that is 1,500 milligram of sodium. If there is fluid overload, the sodium restriction should be 2 grams. One more thing, the type of salt that we are doing since yesterday, it should not be sodium substituted. So why I am talking about the salt? Because salt, the kidney patients have inability in excretion of sodium. So, and if the patient takes extra salt or the salt more than the recommendation, there will be excess sodium in the body, which will lead to fluid overload, and with that will damage the kidney and cardiovascular risk, vice versa, because of the fluid overload, hypertension, oxidative stress, inflammation, and endothelial dysfunction. One more thing, with additional salt or the salt more than the recommendation, proteinuria has been found. So if we reduce 1 gram of salt from the patient's diet, we will be well manage the proteinuria, which is the sign of progression of kidney disease in renal patients. So this I have discussed to you. So next is the fats or the lipids. There is no recommendation for strict fat, limit. 20 to 25% of calories can be given through fat, because fat is the important source of energy in the CKD patient who are malnourished usually. But the type of fat should be unsaturated fat rich in PUFA and MUFA. If we don't give too much attention on the type of fat, it may develop the increased visceral fat, which will cause free fatty acid and triglyceride elevation, which will ultimately cause myocardial dysfunction because of the poor estimated GFR rates. So the type of fat is very important. Quality is very important than quantity. You can give 20 to 25% of fat, but it should not be saturated, not more than 7% of the total fat, and trans fat is big no. The seeds are good, seed oils are good options because they contain omega-3, as usually the Indians are vegan or they don't take non-veg. So fish oil and fish oil can be supplemented, but the seed oils can be given to the patients in order to complete the omega-3 fatty acid requirement. Now, next is the fiber. As we all know, fiber not only reduces the transit time, but it also absorbs the fat from the lumen and excretes it from the with the feces. So it is also important in managing dyslipidemia. So the diet of the CKD patient should include fruits with low potassium content, vegetables with low potassium content, they should be included in the diet to incorporate fats. Oh, sorry, fibers. I'm sorry. So, protein, as we all know, it depends upon the stage of kidney failure. So, I'll not go too much into this. But again, it is the uh, topic for discussion since morning. I will again say soy protein is best for CKD patient because small amount gives a larger, almost twice protein than other legumes. So soy protein should be incorporated in CKD patient, and it is also less in phosphorus, less in saturated fat, and it also adds fiber. So it is good for CKD patient. Again, animal protein should be restricted. The reasons we are discussing from since the morning. So there is a question. There is a question that the dietary approach to stop hypertension, that is DASH diet, should be given to the kidney patient. Should we embrace it? What is your say? कुछ कहेंगे आप लोग? Sorry. Huh. There are studies which suggest that the DASH diet is a cardioprotective effect and till the stage 3. If the patient is in stage 3, you can give DASH diet, preferably the potassium and the phosphorus content, because as we all know that the DASH diet is the rich source of potassium, and potassium toxicity is very common in CKD patients. So till stage 3, DASH diet can be given with low content of potassium and phosphorus. These are the options. Low potassium fruits and vegetables, whole grains can be given, healthy fats, low phosphorus foods, lean protein, dairy, and low sodium food items. There is again a study which suggests that higher adherence to the DASH diet was associated with lower risk of chronic kidney disease among people with high blood sugar levels, high blood pressure, and high cholesterol level. I will again add that it should be monitored for potassium and phosphorus. So this is a phosphorus pyramid, we all know, and we can take from the 2 segment from the base liberally, and the rest should be taken in moderation. And cola drinks and processed food items should be omitted from the diet. Next thing, to prevent cardiovascular risk, patient who are obese or overweight and the patient who are having hyperglycemia in diabetes case, both the things should be taken into consideration. It has been found that the obese patient have the long disease process. The progression of disease is less in obese patient because of the accumulated fat, but they are also, if they are diabetic, they will be hyperglycemic, and that will aggravate the disease process. So diabetes should be taken into consideration. I'm sorry. Now the next is the fluid. Fluid should not be restricted unless and until there is a fluid overload or there is a urine retention. So, and fluid for a dialysis patient, it should be 1 liter, involving the beverages and other liquid food items. Extra fluid with fluid overload patients having symptoms like edema, accelerated hypertension, can cause cardiovascular complications. So my keynotes of the talk is medical nutrition therapy is a cornerstone in managing CKD and reducing the cardiovascular risk. It is very important to collaborate with the professional dietitian for personalized nutrition plan for each and every individual who is having kidney disease. So my request is to nephrologist also, please send your patient to us. Regular monitoring or blood pressure, blood glucose levels, and the kidney function test is crucial for effective management of the disease. And yes, no doubt, the patient's characteristics, their preferences, their cultural backgrounds, and their do's and likes and dislikes should be taken into consideration, and holistic approach is needed involving the physical activity in the daily routine of the chronic kidney disease patients. Last, stay updated with the latest researches, guidelines, and that will help you to provide evidence-based care to the CKD patients. These are the references. Thank you so much for your patient listening. At last, I want to pay homage and my gratitude to Dr. Anita Saxena ma'am. I am missing her badly, and she was and is a continuous inspiration for all of us. So thank you so much. Yeah, yes.
Basically, what we think about the salt is you have given a lot of emphasis, and most of the times when we think about the salt, we think about the hypertension and cardiovascular complications only. So that is not true. There is a lot of effect on kidney disease progression of the salt. One thing is fine, the hypertension is causing some injury to the kidney, and by reducing salt intake, you are reducing hypertension, and then but increase salt intake, increase volume, and indirectly there will be hyperfiltration injury. For all kidney disease, the common pathway of progression of the kidney disease is hyperfiltration at the kidney bed, at the glomerular filtration rate go up, and hyperfiltration is a very important mechanism. So we have to say, give emphasis whenever we write about the low salt diet. No, this is going to reduce your kidney progressions also, kidney disease progression also.
Yes,
so
sir.
that should be the emphasis. Then my hypertension is controlled, it is fine. So indirectly, there is a lot of effect on the
It reduces the
kidney
kidney.
beds.
Yeah.
So that emphasis should be given. Thank you.
Thank you. Thank you so much. Any more questions?
Ma'am, what's your say on the intake of millets by CKD patients?
As millets are, though they are rich in fiber, but they are again have good amount of potassium and phosphorus. So lab values should be taken into account while providing or prescribing millets to the CKD patient. Yeah. Thank you so much. Thank you very much.
Thank you. And thanks to the chairpersons. I request you all for a photograph. And there is an announcement. Those who have not yet received the felicitation gift, please, I request you to join us on the right side of the stage. And I invite Professor Narayan Prasad sir on stage for a very special moment.
I will. This is all pleasure that you all stayed till the end of this conference. And before starting this validatory functions, I would like to have our all faculty member of Department of Nephrology to be here on the stage. So please, Dr. Anupma, Dr. Ravi, Dr. Manas, everyone from the Department of Nephrology should come here. Dr. Dharmendra. So all faculty members, Dr. Abdullah, Dr. Bashar. Please come. And before we'll start our validatory functions, I would like to call a very special guest of the today, the master chef of this hotel, Centrum, Mr. Atul Kumar Mishra. Please come on the desk. And I hope every one of us has enjoyed his food. And it is very personal that we should not disclose, but he is a very good patient of the chronic kidney disease on dialysis. You can imagine from the health. No angle he looks like any patient of the chronic kidney disease, and he is deliberating all his duties very carefully and with full strength. He never complains anything. So big round of applause for him, Atul Kumar Mishra, and for providing us a very good food. So on this occasion, we like to felicitate him with some of the special gift today. Dr. Manas Ranjan Behra, who is the organizing secretary today, he was very much impressed with him, and he thought that we must felicitate him with some bouquet. Please, all should come to this side. This way. So before we will speak something, I would like to invite from one of you or anyone who wants to speak about this meeting. If any suggestions from you to how to we can improve the content of the scientific program, well, if you have any suggestions from your side, you are most welcome to come here and speak about the arrangements, about the scientific program, about the contents, how we can go ahead in the next meetings. So any one of you can come. But particularly, I would like to have from nutritionist side. Please, you can come here. Come here.
The comment that I was wanting to make is that get a feedback form which you can circulate amongst the nutritionists, because essentially this program is for not only for nephrologists but for mainly for them. So they can give you an anonymous feedback as to what all they want on the next time.
So only thing we can do, we can send you one feedback form. Here everyone writes this is good, 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 good. So you will get one good feedback form in your mail. Registration number and email of every one of yours are here with us. So you will get it at your home, and you can find out the time. You can give suggestions to us, and accordingly we will take some actions which is possible from our side to improve the scientific content or improve the program. So you want to speak on that? You can come here also. You can come and just.
सर बहुत ही अच्छा, बहुत ही सुंदर और अत्यंत सराहनीय। कहते हैं कि जब कोई नींव का पत्थर होता है, जैसे कि डॉक्टर अनीता सक्सेना जी थी, तो वो नींव का पत्थर एक बीज की तरह नीचे दब जाता है। लेकिन जब उसमें मिट्टी पड़ती है, पानी मिलता है, फेवरेबल कंडीशंस मिलती हैं, तो वो पौधा बहुत बड़ा हो जाता है और उसका अंश जो जेनेटिक्स होता है, वो पौधा जब ग्रो करता है तो वो हर पत्ती, हर शाखा, हर फूल में नज़र आता है। वही एसेंस इस कॉन्फ्रेंस में फ़ील हो रहा था और जितनी बार हम लोग उनका नाम लेते हैं, उतनी बार एक ये फीलिंग आती है कि यस, समवन स्टार्टेड द थिंग वेरी ब्यूटीफुली, दो शी इज़ नॉट हियर, बट इसको ऑर्गेनाइज़ करने में हर व्यक्ति के अंदर थोड़ी-थोड़ी सी वो जो एसेंस आई है, दैट इज़ रियली ब्यूटीफुल, रियली कमेंडेबल जॉब एंड हम सब ने उसे जो आत्मसात करके आगे बढ़ रहे हैं, वो वैसे ही बढ़ते जाएँ, यही सबसे बेस्ट पार्ट है। बहुत सारी अच्छाइयाँ हैं, बहुत सारी चीज़ें हैं, हम सब उसे ऐसे ही लेकर के आगे बढ़ते चलें। छोटा-सा एक करेक्शन है कि हम सब क्वेश्चन आंसर सेशन में बहुत
कम आगे पीछे होते हैं, एक दूसरे से कनेक्ट कम होते हैं, तो बहुत सारी अपॉर्चुनिटीज मिलती हैं जो हम लोग छोड़ देते हैं। जैसे कि लक्ष्मीकांत सर ने एक क्वेश्चन पूछा था, तो डाइटिशियंस के लिए एक बहुत अच्छी अपॉर्चुनिटी मिसिंग बात है कि वो क्लिनिकल किचन स्टार्ट कर सकते हैं और उसमें मेंटी को सर्व किया जा सकता है। जैसे कि एक एग्जाम्पल लिया गया था कि किसी प्रकार से इस बॉन्ड को और स्ट्रांग बनाया जाए। डाइटिशियन सर यहाँ पर जो आए हैं वो 50% है, तो 50% और कहाँ पर रह गए उस पे वर्कआउट करने की ज़रूरत है। और सेम एप्लीकेशन इज़ विद अवर रेसिडेंट डॉक्टर्स एंड नेफ्रोलॉजिस्ट, तो उनको भी कनेक्ट किया जाना चाहिए। वेरी कमेंडेबल जॉब सर, इट्स रियली वेरी अप्रिशिएबल एंड थैंक यू सो मच फॉर इंक्लूडिंग अस। थैंक यू सर।
Thank you very much. Thank you very much, sir.
On behalf of the dietetics department of SGPGI and all the dietitians from Lucknow and from other cities, we really want to thanks to the nephrology department, Bahira sir, Narayan sir, Gupta sir, Anupma madam, and everyone to make us the integral part of this conference. And also Anita madam was our nodal officer also, and we were so closely associated with her from last 18-20 years. अगर internship को हम लोग जोड़ते हैं, we are here from 2003. So एक बार मैम के लिए सभी लोग ये शुरू करना का क्रेडिट goes to her only. And नेक्स्ट एक गुप्ता सर ने जैसे फीडबैक की बात की, उसी लिए हम लोग भी डिस्कस कर रहे थे। फीडबैक में क्वेश्चन हम रख सकते हैं कि फ्यूचर जो हमारी SRNM या रीनल न्यूट्रिशन की कॉन्फ्रेंस हो रही है, हमारे जो बडिंग डाइटिशियंस या बाकी डाइटिशियंस हैं, अगर उनको कोई चीज लगता है जो छूट गया एंड दे रियली वांट टू इंक्लूड दोस टॉपिक्स फॉर इन अपकमिंग कॉन्फ्रेंसेस, तो वो हम सजेशंस और ले सकते हैं। थैंक यू सर, थैंक यू।
Yeah, Mike, so you can speak up, please. Yeah, यहाँ पर लीजिए।
Being a dietitian, I want to say that diet is medicine and our kitchen is pharmacy. डेप्रीविएशन आने के बाद ही डाइट में प्रिस्क्रिप्शन किया जाता है, अमेंडमेंट किया जाता है, चेंजेस लाया जाता है। दी डे ह्यूमन बीइंग कंसीव इन मदर रूम, न्यूट्रिशन विल बी स्टार्ट एंड इट विल कंटिन्यू टिल ही डाई। जब तक व्यक्ति जीवित रहता है, अपने अकॉर्डिंग हमेशा वो न्यूट्रिशियस डाइट ही लेता है। आफ्टर डेप्रीविएशन, आफ्टर बायोकेमिकल इन्वेस्टिगेशन ही जो है चेंजेस डाइट में लाया जाता है। तो बीइंग अ न्यूट्रिशनिस्ट, वी आर आल्सो नो all things are nutritious, but after deprivation we can amendment or we can change it.
Thank you. Thank you very much for suggestion. Anyone has anything to say? Yeah, please.
थैंक यू सर। वेरी वेल ऑर्गेनाइज्ड प्रोग्राम। मैं ये कहना चाहती हूँ कि मैंने इसके पहले एक प्रोग्राम यहाँ पर अटेंड किया था। मुझे लगता है कि शायद वो मेरा पहला प्रोग्राम था जिसमें मैम ने कुछ प्रैक्टिकल अप्रोच पे ध्यान दिया था। जैसे कि उन्होंने असेसमेंट करवाया था, न्यूट्रिशनल असेसमेंट, हैंड ग्रिप मेजरमेंट। ये सारी चीज़ें जो प्रैक्टिकल अप्रोच है वो डाइटिशियंस के लिए पॉसिबल नहीं है कि हर डाइटिशियन हर सेटअप में सीखे, तो उसका भी कुछ इसमें होना चाहिए। ज़्यादा से ज़्यादा हमें केस स्टडी बेस्ड थोड़ी सी हम प्रेजेंटेशन करें ताकि हम प्रैक्टिकल चीज़ों को सीख सकें, क्योंकि ज़्यादातर अब चैट जीपीटी से लोग पढ़ना शुरू कर दिया सबने, बहुत सारी नॉलेज उससे गेन करते हैं, तो हमें प्रैक्टिकल सीखना है, यही मैं कहना चाहती
बहुत
हूँ।
बढ़िया सजेशन। This is all good practical aspects of अब एक हमारी भी कंप्लेन है आप लोगों से। जब भी हम प्रोग्राम अरेंज करते हैं तो हमारा, जैसे आपने देखा होगा कि हमने बहुत ज्यादा नेफ्रोलॉजिस्ट या क्लिनिशियंस को नहीं बुलाया था। हमने उन्हीं लोगों को बुलाया था जो कुछ लोग डाइट पे काम करते हैं या जिनका डाइट से रिलेटेड पब्लिकेशंस हैं और जिनको इन डेप्थ नॉलेज है। कुछ ही समय में एक्चुअली आप देखेंगे तो इफेक्टिव हमारा टाइम जो था हमारे पास कल 1 बजे से लेकर 7 बजे तक 6 घंटे का, और आज हमारे पास 5-6 घंटे का था। तो हमें कम समय में ज़्यादा से ज़्यादा टॉपिक कवर करने होते हैं, और जैसा आपने बताया आज का समय में लिटरेचर की कोई कमी नहीं होती, तो आप सब लोग पढ़े रहते हैं। प्लस जो एक हमारा कंसेप्ट है कि जब आप डाइटरी कोर्सेज करते हैं तो मेजरमेंट्स, एंथ्रोपोमेट्रीज और ये सब वहाँ अवश्य सिखाए जाते हैं, जो मैं समझता हूँ। तो हमारा ये था कि एक ऐसी इंटरेक्शंस हो लोगों के बीच जो क्लिनिशियन को लगता है कि डाइटिशियन ने डाइट कम कर दी, हमारा मरीज मालनरिस्ट हो गया, और डाइटिशियन को लगता है कि उन्होंने हमें ने जो सजेस्ट किया उसको हमारे ना क्लिनिशियन फॉलो कर रहे हैं और ना ही हमारा पेशेंट फॉलो कर रहा है। तो एक बहुत सारी जो भ्रांतियां होती है इस बीच में ये दूर हो जाए। और क्यों फिजिशियन समझता है कि ये डाइट की जरूरत, रिस्ट्रिक्शन जरूरत नहीं है, क्यों डाइटिशियन को लगता है कि नहीं, इसकी न्यूट्रिशनिस्ट को लगता है कि इसकी जरूरत है। तो इस तरह की भ्रांतियां अगर जब हम एक दूसरे से जब सुनते हैं तो कुछ चीजें हमें समझ में आती है। तो इसका पर्पस कम समय में ज्यादा से ज्यादा टॉपिक कवर हो, इसलिए ये थोड़ी सी इंटरेक्शंस का हमें पता है। और बहुत ज्यादा इंटरेक्शन का जब समय होता है ना, तो जैसे आपने लास्ट सेशन में भी देखा होगा जब हिमानी पुरी जहाँ बात कर रही थी और अर्चना जी ने क्वेश्चन करा था, तो क्रॉस टॉक होते हैं, एंड दैट क्रॉस टॉक्स डेविएट्स फ्रॉम योर मेन फोकस। तो कुछ एरिया जो है ग्रे एरिया रहेगा, वो हमेशा रहेगा। हम फिजिशियंस को भी पता नहीं चलता है कि ये डिजीज क्यों हुआ, ये ग्रे एरियाज में कभी कभार हम लोग भी घूमते रहते हैं। हमने ज्यादा फोकस किया है कि हमारे डाइटिशियंस और न्यूट्रिशनिस्ट जो भी विशेषज्ञ हैं वो इस बातों को समझें, और क्लिनिशियन का क्या कंसर्न है और आपका क्या कंसर्न है इस बातों को देखें। लेकिन हमने ये भी देखा है कि जब हम प्रोग्राम अरेंज करते हैं तो बहुत सारे हमारे जो ट्रेनीज हैं वो कॉन्फ्रेंस हॉल में कम दिखाई पड़ते हैं, बाहर ज्यादा दिखाई पड़ते हैं। तो जो जिसको हम लोग कभी कभार बोलते हैं कि आउटस्टैंडिंग डेलीगेट्स, दोज हु ऑलवेज रिमेन आउटसाइड। तो ये जो है ये केवल आपके लिए नहीं है, ये हमारे फिजिशियंस में भी होते हैं। हमारे फिजिशियंस में भी एक आउटस्टैंडिंग डेलीगेट्स होते हैं जो हमेशा स्टॉल्स पे घूमते हैं। तो इस चीजों को भी हमें दूर करना पड़ेगा। वी मस्ट अंडरस्टैंड इसके पीछे कितनी एनर्जी लगती है, कितने हम इसके पीछे पैसे खर्च करते हैं, कितना समय लगाते हैं। और हमें केवल एक ही बात का सेटिस्फेक्शन होता है कि हर व्यक्ति अगर 1-2 अक्षर और 1-2 बातें भी सीख कर यहाँ से गए तो हमें लगता है कि वी हैव फुलफिल्ड इन आवर मिशन। तो यही हमारा एक एम रहता है। ये नहीं रहता कि हमने जितनी बातें बोली और हर आज चीज आप हर व्यक्ति समझ ही जाए, ये संभव नहीं है इस 8 घंटे में। क्योंकि देखिए कोई भी कोर्स होता है ना शुरू से बिल्डअप होता है। कोई भी कोर्स 3 साल के लिए, 2.5 साल के लिए या 4 साल के लिए बनाए इसलिए जाते हैं कि आप ग्रेजुअली सीखेंगे तो आपके को समझ में आती है, वो हम उसको मेमोराइज कर सकते हैं, हम उसको याद रख सकते हैं। तो इसका कंसर्न यही है। लेकिन फिर भी आप लोगों का सजेशंस बहुत ही सराहनीय है, हम लोग नोट करेंगे। एक हम फीडबैक फॉर्म भी देंगे, आप लोग उनको भेजना। आज जितने भी लोग मेंबर एसआरएनएम के नहीं है वो फ्री मेंबरशिप के लिए हमने बोला हुआ है। जिसने अटेंड किया है वो तो हो ही जाएंगे मेंबर। और हम कोशिश यही करेंगे कि ये प्रोग्राम चलते रहे और आप लोग इसी तरह से इसको अटेंड करें और इसका जितना ज़्यादा से ज़्यादा लाभ हो आप लोग उठाएं। इसके बाद हम अपने जो हमारे जो फैकल्टी मेंबर्स हैं उनसे अनुरोध करूंगा कि अगर आप कुछ बोलना चाहते हैं तो आप, हमारे माइनस बहेरा जी हैं, ही इज द वन फैकल्टी मेंबर हु हैज डन द मोस्ट, हु वाज द ऑर्गेनाइजिंग सेक्रेटरी एंड मैक्सिमम ब्रांड ही हैज टेकन। सो फ्यू वर्ड्स फ्रॉम यू।
हेलो, एक्चुअली आपने जो बोले कि रजिस्ट्रेशन बारे, आई वांट टू टेल यू ना, अराउंड 120 delegates have registered apart from faculty,
Sorry, 170 we have registered after faculty, but only 50 has joined. It is the very same thing for me. And one out of 170, only 50 joined. And today morning, nobody was there. And we'll try to include more and more. Yeah, we'll make this curriculum more lucid so that everybody can grasp it. I understand there is some communication gap between the speaker and audience, and I think that level of is too high. I have got feedback from many of you. I have asked personally many people, many teachers are sitting here also from different colleges, and we find that it was too high. But we are planning to conduct some small CMEs and register 100 students and on 4 hours courses, and we can carry it very well. Yes, sir. I again I want to thank you all, each of one you, all the nephrologists, nephrology from various corners, and nutritionists and delegates that could able find about their valuable time to participate with us. And I understand that your time is very valuable, and our delegates must have benefited with this your third process.
I have some suggestions, please. साल में सर 12 महीना ही होते हैं, है ना? Or there are multiple things to happen. So either you can have the conference and in between we can have the small courses of a daytime or 6 hours or 8 hours of these courses that can be conducted. And definitely we are going to plan to start renal nutrition, advanced renal nutrition courses at SGPGI under the CMT. And so anybody who would be interested in getting these MSc courses in renal nutrition, they can get that course in. So we are likely to advertise from the next years. And so that would be the one thing that might give you more in-depth knowledge about the renal nutrition parts.
I think the suggestion by everybody is quite valid, and we need to improve on the program's schedule. And I understand probably the level which was depicted by the presenters must have been a bit higher for you. So I think a good suggestion from you people, we'll definitely try to base them on situation basis, and that would definitely help you people as well as make us also learn in the situations which may be not what we may not think it is important for us, may be benefit to both the ends. And the purpose of this whole conference is that it should benefit, be a two-way process. It should not be just we understanding or we just delivering it, or you are delivering and we are not taking it over. So I think what you have suggested and others have the same opinion. We would try to make it more focused and a case-based approach, and that would be the program schedule in the near future.
Anybody want to say anything? Anybody?
But I must say that you people were very active and were there till the end. What some people are always outstanding, but there have been people who are instanding itself.
So, ladies and gentlemen, this all shows that you people are even at the validatory functions. So many persons even I have not seen in ISN Con. So I have arranged ISN Con for several 6-7 years continuously, and I have never seen this much number present at the end of the conference. So thank you, ladies and gentlemen. Thank you for being here and actively participating. So that gives us satisfaction that everybody here was participating very actively. So thank you very much. I would like to thank at the end all the delegates, even our colleagues from the Patna who are here, Dr. Om Kumar, Dr. Sasi, Dr. Rishi, and so many persons are here. So thank you being with us. At the end, I would not like to forget to thank our industry persons without whose contribution it is not possible to conduct any CME or any conferences, any meeting. So thanks a lot to all of you, all the industry persons, for generous contribution in making this program successful. I would like to thank all the staffs of this hotel, sorry, of this hotel. Actually, the Centrum, the administration of the Centrum was so much cooperative that since day before yesterday, they have opened the door for making this all arrangements which you are looking at this at present time. So that was all his operations. So I would like to thank each and every staff of this hotel Centrum for their generous what I can say, their generous contribution towards us, their attitude, their cooperation. So thank you every staffs of this hotel Centrum. So at the end, I may forget some names. I don't want to take names of the all. And at the end, I would like to thank Professor Amit Gupta sir, who was our founder member of one of the founder member of the Department of Nephrology. And you must acknowledge him. He was since the beginning of this conference and till the end. So everyone request him to come on the desk. And we like to have one big group photographs. Anyone who are here, you can come on this stage and we can have the big group photographs.
All that I would say is that 3 cheers to the Department of Nephrology for having done a great job. Without all of them working together, this conference wouldn't have come to fruition. Thank you so much indeed.
I have to mention about Dr. Ankita. She did a great job, and people were surprised that she had no idea of nephrology, but she really sama bandh diya aapne. Thank you so much.
Thank you. Thank you. Thank you. Really, I forgot your name. Thank you very much.
Participants of the entertainment program last night.
Ah. Big entertainers. So high tea is served outside, and everybody can have the high tea, and then they can depart for home.
Sir, I have a presentation for IPN only. It will take 1 or 2 minutes, sir.
आप करो कब करना
सर आप प्लीज वो कर दीजिए तो सर सर आईपीएन का प्रेजेंटेशन था सर तो सर आई गिवन स्लाइड टू हिम हार्डली इट विल टेक 2 to 3
आप करा दे बताओ ना आप बोल दो
सर प्लीज आप डिक्लेयर कर दीजिए तो फिर बैठ जाएंगे
कुछ आईएपीएन का कुछ प्रेजेंटेशन है, ये दिखाना चाहते हैं अबाउट नेक्स्ट मीटिंग, सो यू कैन शो.
Thank you, sir.
I would like to thank Mr. Ritesh from RJ Trade Wings for his generous cooperation, and you might have acknowledged his service. He was very pertinent to his job. So thank you, Ritesh. I would like to thank Inder Singh ji for all his support. Thank you.
Hello, please, IPN team, IPN, please be seated. वो सर स्लाइड होगी. कौन है? आगे मैम आईपीएन के मेंबर सब चले गए बाहर. चलिए कोई नहीं. On behalf of IPN India, we immensely grateful to the Department of Nephrology, SGPGI, Institute of Medical Sciences, for hosting this esteemed event. We are deeply grateful to Dr. Narayan Prasad sir, Professor and Head Department of Nephrology, SGPGI, whose guidance and expertise have been instrumental in shaping this event. Additionally, our heartfelt gratitude to Dr. Manas Ranjan sir, the esteemed Associate Professor, Department of Nephrology, whose contribution has enriched the academic landscape of this domain, and your dedication to fostering innovation and excellence in healthcare is truly commendable. Before moving further, I would like to share a brief overview of the IPN India. Excuse me, sir. आप स्लाइड चला दीजिए बस. नहीं नहीं बस सर क्या नहीं नहीं सर क्या. Thank you all.